Yes, I think we can work on getting that taken care of. Rita, do you mind just saying hello so we can do a sound check with you?
Yes. Hi, good morning.
Okay, perfect. Loud and clear.
All right, great.
Okay, then you should be a co-host. Do you mind just checking to see if you can share your slides? Or share your screen?
Yeah, and I will just do it now just to see what version comes, what this looks like.
Absolutely, yeah. And feel free to share in advance one or two just so we're...
Okay. Yeah, and the display you're seeing is okay?
I think you have to request control. No. Are you sharing?
We're not seeing anything, Rita.
Oh, okay. Okay, here.
Ah, here we go. There you go.
Okay, we can see it now. It is not the presenter view. Like we can see the full slide deck. There we go. Now it is the presenter.
Okay. All right, perfect. Okay, I think and I will stop sharing. Yeah. Okay, yeah, I got it.
Okay. Thank you so much. So we'll do all the roll call and introductions. Then Dr. Daly will do his intro slides, and then we'll toss to you. So if you can try to start sharing your screen after Dr. Daly's introduction slides.
Okay, that's perfect.
morning and welcome everyone. It is 7 a.m. on the West Coast, 10 a.m. on the East Coast, and this is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is February 4th, 2022. It's just 2 days after Groundhog Day, so if you're feeling like this is Groundhog Day, it may be justified. For those of us who follow the Groundhog Punxsutawney Phil, you'll know he saw a shadow, and so we will have 6 more weeks of winter. And it turns out, I think he's also predicting the next 6 weeks of ACIP, where we're going to have to keep our heads down, stay warm, and hope for spring break soon. So with that, I'm pleased to call today's ACIP meeting to order, and I'll turn it over to Dr. Melinda Wharton to share today's announcements. Dr. Wharton.
Good morning. Thank you, Dr. Lee. And to the rest of you, good morning and welcome to the February 4th virtual meeting of the Advisory Committee on Immunization Practices. Copies of the slides being presented at today's meeting are or will be available on the ACIP website. Additionally, slides are available through...
Hold for a moment until I can find Dr. Wharton.
Dr. Lee, can you hear us in the room?
Many of us can.
Dr. Lee, does that, Dr. Bell, does that mean you can hear us?
Yes, I can.
Okay.
Okay, can you hear me on this microphone?
We all can.
I can, yeah.
I'm not sure if we can't hear the room, but we can't hear Dr. Wharton. So if we could work on the audio, that would be wonderful. Thank you.
Dr. Lee, can you hear me on this microphone?
We can hear you.
I can hear you.
It only seems that it's Dr. Lee who can't hear you. We can all hear you, Dr. Wharton.
Thank you.
Okay, please go ahead.
Dr. Lee, can you hear me now?
I can, thank you. Thank you for your patience not being in the same room.
Okay, thank you. This is the challenges of remote meetings. So we will restart. Good morning and welcome to the February 4th virtual meeting of the Advisory Committee on Immunization Practices. Copies of the slides being presented at today's meeting are or will be available on the ACIP website. Additionally, we make slides available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those of you who are listening to us on the Zoom line. Please mute your lines at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the virtual hand-raising function in Zoom to raise your hand. During the discussion period, Dr. Lee will first take questions from the voting ACIP members and then from ex officio members and liaison representatives. Please disable your video until it's time to vote, and then we'd appreciate it if you could turn on your video during the votes. Next slide, and next slide. This meeting's oral and written, we will be having public comment today during today's meeting. The Advisory Committee on Immunization Practices is, at its heart, a public body. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we will be holding one oral public comment period at approximately 11:10 a.m. Eastern Time. To create a fair and more efficient process for requesting to make an oral comment, people interested in making an oral comment are requested to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have already been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0022. Information on the written public comment process, as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflicts of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide. And at this point, I will turn the podium back over to Dr. Lee. Thank you.
Thank you. For the ACIP members, I'll ask you state your name, affiliation, and whether you have any conflicts of interest. Today, we'll start with Dr. Talbot.
You went totally out of order and totally caught me off guard. Good morning. My name is Kim Talbot. I am a infectious disease physician at Vanderbilt University Medical Center, and I have no conflicts.
Thank you. Dr. Sanchez.
Hello, Sanchez. I'm professor of pediatrics at the Ohio State University College of Medicine and Nationwide Children's Hospital, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's. Thank you.
Okay. Did you state your conflicts? Apologies if I missed it.
Yeah, I have no conflict.
Thank you. Dr. Paling.
Good morning. This is Kathy Paling. I am a professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist, and I have no conflict. Thank you.
Thank you. Ms. McNally. We'll move to Dr. Long.
Good morning. This is Sarah Long. I'm a pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict.
Thank you. Dr. Lair?
I'm Dr. Jamie Lair, a family physician in private practice in Ithaca, New York, and I have no conflicts.
Thank you. Dr. Cotton.
Good morning, Dr. Camille Cotton. I am the clinical director of transplant and immunocompromised host infectious diseases at Massachusetts General Hospital and associate professor at Harvard Medical School. I have no conflicts.
Thank you, Dr. Cotton. Dr. Daly?
Good morning, Matt Daly. I'm a pediatrician. I'm at Kaiser Permanente, Colorado. I'm also an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Sineas?
Good morning. I'm Dr. Sybil Sineas. I am an internist and pediatrician. I'm an associate professor of medicine pediatrics at Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Chen?
Wilbur Chen, adult infectious disease physician and professor of medicine at the University of Maryland School of Medicine. One of the hats that I wear is director of travel medicine practice. For full transparency, my employing institution, the University of Maryland, has a grant from Emergent Biosolutions that supports work I do on developing a Shigella vaccine, a diarrheal pathogen. I don't believe that this presents a conflict of interest for our discussions today. Thanks.
Thank you, Dr. Chen. Dr. Brooks?
Oliver Brooks, pediatrician, chief medical officer, Watts Healthcare Corporation. Good morning.
I'm sorry if I missed it, but did you state if you had conflict?
And I have no conflict.
Okay, thank you.
Thank you.
Dr. Bell.
Beth Bell, clinical professor, University of Washington. I have no conflicts.
Thank you. Ms. Bata? Okay, we'll move to Dr. Alt.
Good morning. My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas. I have no conflicts. Thank you.
Thank you. And this is Grace Lee. I'm professor of pediatrics at Stanford University School of Medicine, associate CMO for Stanford Children's Health, and I have no conflicts. Are there any members who have arrived that I have not yet called on? Okay, thank you. For our committee today, we do have quorum, so we're able to proceed. For our ex officio and liaison members, I will announce the organization name, and then please indicate if you're present and your first and last name. First, we'll begin with Centers for Disease Control and Prevention.
Good morning, Dr. Lee. Sam Posner, NCIRD.
Morning, Dr. Posner. Centers for Medicare and Medicaid Services.
Good morning, Mary Beth Hance, present.
Thank you. Food and Drug Administration.
Good morning, Doran Fink, present on behalf of the U.S. Food and Drug Administration Office of Vaccines.
Thank you, Dr. Fink. Health Resources and Services Administration.
Good morning. This is Mary Rubin from the Division of Injury Compensation Programs, present.
Morning. Indian Health Service.
Good morning. This is Dr. Matthew Clark with the Indian Health Service.
Thank you. And National Institutes of Health.
Good morning, John Barngle, present for the representing the NIH-NIAID.
Thank you. Office of Infectious Disease and HIV/AIDS Policy.
Well, good morning. This is David Kim, representing OIDT in the Office of the Assistant Secretary for Health.
Good morning. Next, we'll move on to our liaison representatives, beginning with American Academy of Family Physicians.
Hi, this is Amy Mullins with AAFP, present.
Thank you. American Academy of Pediatrics.
Good morning. This is Bonnie Maldonado, and I'm chair of the Committee on Infectious Diseases for the American Academy of Pediatrics and professor of Global Health and Infectious Diseases at Stanford University School of Medicine.
Thank you. American Academy of Physician Assistants.
Good morning. This is Marie-Michelle Léger from AAPA, American Academy of Physician Associates.
Thank you. American College Health Association.
Good morning. This is Sharon McMullen and Dr. Tavi Chai for ACHA.
Thank you. American College of Nurse Midwives.
Cheryl Hay, present.
Thank you. American College of Obstetricians and Gynecologists.
This is Dr. Linda Eckert, Professor of Obstetrics and Gynecology at University of Washington for ACOG, present.
Thank you. American College of Physicians.
Good morning, Jason Goldman, General Internal Medicine Private Practice in Florida, also affiliated associate professor at Florida Atlantic University, representing American College of Physicians. Pleasure to be here.
Thank you. American Geriatric Society.
Ken Schmader here for AGS.
Thank you. America's Health Insurance Plans.
This is Bob Gluckman, CMO Providence Health Plans, present.
Thank you. American Immunization Registry Association.
Morning, Rebecca Coyle and Beth Perillo representing ERA.
Morning. American Medical Association.
Sandra Freihofer, General Internist in Atlanta and Adjunct Associate Professor of Medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Carol Hayes, substituting for Chad Riddle.
Thank you. American Osteopathic Association.
Stan Grog, present. Good morning.
Morning. Thank you. American Pharmacists Association.
Good morning. This is Michael Hogue, Dean and Professor of Loma Linda University School of Pharmacy and Professor of Preventive Medicine at Loma Linda School of Medicine, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, representing AIMS.
Thank you. Association for Prevention, Teaching, and Research.
Richard Zimmerman at the University of Pittsburgh, representing APTR.
Thank you. Association of State and Territorial Health Officials. Move on to Biotechnology Innovation Organization.
Good morning, Phyllis Arthur representing Bio.
Morning. Council of State and Territorial Epidemiologists.
Hi, Dr. Christine Hahn, Idaho State Epidemiologist representing CSTE.
Thank you. Canadian National Advisory Committee on Immunization.
Matthew Tunis here for NACI.
Thank you. Infectious Disease Society of America.
Good morning, Jeff Tuchin, Health Officer, Public Health, Seattle and King County, Professor of Medicine, Division of Infectious Diseases, University of Washington, representing IDSA.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett, present for ISTM.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACCHO, present.
Good morning. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield, representing NAPNAP.
Good morning. National Foundation of Infectious Diseases.
Good morning. This is Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt and Medical Director of the NFID.
Thank you. National Medical Association.
Good morning. This is Pat Whitley-Williams, Professor of Pediatrics. I'm a pediatric ID physician at Rutgers Robert Wood Johnson Medical School.
Thank you. Pediatric Infectious Disease Society.
Good morning. Sean O'Leary, representing PIDS.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman, representing SAM.
Thank you. And Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care in Delaware, representing SHEA.
Thank you, everyone. Are there any individuals who have arrived after roll call that would like to announce themselves? Okay, perfect. Thank you, everyone. Thanks for your patience. Before we get started, I would like to ask if Dr. Doran Fink from the FDA would like to make a few comments and provide any updates to the committee. Dr. Fink?
Hi, Dr. Lee. Thank you for asking. I actually have two announcements to make today on behalf of FDA. First, and this is one of the discussion topics for the ACIP today, I would like to announce that, as many of you already know, on Monday, January 31st, FDA approved Spikevax, also known as the Moderna COVID-19 vaccine, is used under emergency use authorization as a 2-dose primary series for use in adults 18 years of age and older. FDA's approval was based on both updated data and analyses from the same phase 3 clinical trial involving approximately 30,000 participants that initially supported emergency use authorization of the vaccine back in December of 2020. And also our approval considered real-world experience from post-authorization use of the vaccine in many millions of individuals. In the updated efficacy analyses, which included a median placebo-controlled blinded follow-up of 4 months, vaccine efficacy against any symptomatic COVID starting 14 days after dose 2 was approximately 93%, and vaccine efficacy against severe COVID was approximately 98%. The review of safety data from additional follow-up conducted in the clinical trial, as well as from post-authorization experience, did not raise any new safety concerns compared to the safety profile that was previously labeled in the emergency use authorization fact sheets. Important but very uncommon adverse reactions continue to be anaphylaxis, as well as myocarditis and pericarditis, in particular following dose 2, and in particular among males less than 40 years of age. And the approved U.S. prescribing information for Spikevax includes warnings about these adverse reactions, and they will continue to be followed through post-marketing surveillance. We recognize that approval of the biologics license application for Spikevax represents an important step in building and maintaining our armamentarium of countermeasures against COVID-19, as well as an important regulatory step for this particular vaccine. It will certainly not be the last step. There are other uses of this vaccine, for example, booster doses that are currently available under emergency use authorization, and work is ongoing to eventually transition some of these things over to licensure. And additionally, we anticipate that in the future there will be supplements to the license or amendments to the emergency use authorization to address other needs as they arise. The second announcement that I would like to make today involves the upcoming meeting of the Vaccines and Related Biological Products Advisory Committee, scheduled for February 15th, that was announced publicly by FDA earlier this week. In mid-December, Pfizer BioNTech announced initial safety and immunogenicity results from infants and children 6 months through 4 years of age, enrolled in their ongoing clinical trial of the Pfizer BioNTech COVID-19 vaccine, and also announced their plans to amend the trial to evaluate the third dose of the vaccine in this age group. As reports of pediatric hospitalizations increased in association with the Omicron variant surge in late December, FDA requested Pfizer to provide more detailed data for our review as the information became available. At the same time, FDA has received many inquiries from healthcare providers, from advocacy groups, and from the general public expressing intense interest in the details of the data and prospects for emergency use authorization of the vaccine for use in this age group. During our ongoing review, we recognize that additional immunogenicity and efficacy data have become available to better inform vaccine benefits. In the meantime, while the Omicron surge is now receding in some parts of the nation, it's certainly not over. Furthermore, it is imperative not only to react to the present situation, but also to be prepared for when we are confronted with the next unexpected twist. The decision to hold this VRPAC was not only motivated by the need for transparency on the newly available data, which will be addressed through the meeting briefing documents, presentations, and discussion, but also motivated by the defining unpredictability of the pandemic. FDA intends to conduct an open, transparent, and thorough discussion of the available data, to listen carefully to the assessment of our expert committee members, and to end the meeting better prepared to build upon our response to COVID-19, whether this follows from a clear recommendation for an authorization or from recommendations for additional data that could support an expedient authorization in the near future. Thank you.
Thank you, Dr. Fink. And again, thank you to the FDA for your continued work on all of the myriad of issues that continue to come up during this pandemic. So we will now move on to the first session for the day. During today's meeting, as a reminder, I'll invite individuals to contribute to the discussion. Please raise your hands electronically, and I will call on ACIP members first, followed by our ex officio members and liaisons. But before we get started, I wanted to ask if Ms. Bata is able to unmute and provide her name, affiliation, and whether she has any conflicts of interest.
Good morning. I am here. This is Lynn Bata. I am a immunization clinical consultant with the Minnesota Department of Health, and I have no conflicts.
Thank you, Ms. Bata. And we will start today with Dr. Matt Daly, who is chair of our COVID-19 vaccines work group, to provide an introduction and overview of today's meeting. So Dr. Daly.
Great, thank you so much. So I will be introducing today's sessions. I'm presenting on behalf of the ACIP COVID-19 vaccines work group. Next slide, please. So through January 30th of 2022, there have been nearly 75 million cases of COVID-19 in the United States. And although case counts have been declining in the last several weeks, we're still averaging hundreds of thousands of cases of COVID-19 every day in the US. Next slide, please. And during the pandemic, more than 880,000 individuals in the US have died from COVID-19. And based on the most recent 7-day moving average, more than 2,000 individuals will die today from COVID-19. Next slide, please. So this figure shows rates of COVID-19 death by vaccination status. And the black line shows rate of death from COVID-19 for the unvaccinated, and the blue line shows rate of death for the fully vaccinated. And this can be viewed as a visual representation of real-world effectiveness, real-world evidence of high vaccine effectiveness. But I also see something else. The space between the black and blue lines here is lives saved by vaccination. Next slide, please. So to achieve disease prevention, it takes not just having an effective vaccine, but an effective vaccination program. There needs to be adequate vaccine supplies, the people, the processes to administer vaccines, and in addition, the public needs to be accepting of vaccines. And as you can see in this graph, across every adult age group, more than 3/4 in the United States have received at least one dose of a COVID-19 vaccine. And while I fully recognize that these are lower vaccination rates than perhaps we would have hoped, and I hope they continue to rise, this is still an important accomplishment. Next slide, please. So there have been several recent studies that have tried to estimate COVID-19 associated hospitalizations and deaths prevented by COVID-19 vaccination in the United States. And based on these new studies, it's been estimated that up to 10.3 million hospitalizations have been averted through November of 2021 through vaccination, and an estimated 1.1 million deaths have been averted through November 2021 by vaccination. Next slide, please. So here are a number of FDA updates. Dr. Fink just went over these very well, so I won't read them. I will highlight, though, something that Dr. Fink mentioned, which is that the Moderna COVID-19 vaccine remains under emergency use authorization for the following indications: when it's used as a third dose in the primary series for individuals with moderate to severe immunocompromise, and when it's used as a booster dose. Next slide, please. So here I want to review the COVID-19 vaccines work group activities for the months of January and February of 2022. The work group reviewed data on the safety and efficacy of Moderna COVID-19 vaccine from the phase 3 clinical trials. In addition, reviewed meta-analysis for the global real-world effectiveness data from Moderna COVID-19 vaccine. In addition, the work group reviewed safety updates for Moderna COVID-19 vaccine specifically and for mRNA COVID-19 vaccines in general. In addition, the work group looked at the grade and evidence to recommendations framework data for Moderna COVID-19 vaccine primary series. In addition, the work group did review global data for myocarditis after mRNA COVID-19 vaccines. And then finally, the work group, in addition, looked at emerging data about safety and effectiveness of longer interdose intervals for mRNA COVID-19 vaccines. Next slide, please. So here's the agenda for today. First, we'll hear from Dr. Rita Das from Moderna, who will review mRNA 1273 COVID-19 vaccine biologics license application safety and efficacy data. This will be followed by a break. After that, there'll be a public comment period. After the public comment period, we'll hear from Dr. Shimabukuro at the CDC, who will present updates on myocarditis and pericarditis following Moderna COVID-19 vaccination. After that, we'll hear from Dr. Krasolik from the CDC, who will give us an update on the MOVING study, which is looking at longer-term outcomes following vaccine-associated myocarditis. After that, we'll hear from Dr. Talbot, who's the VAST chair. And VAST is the Vaccine Safety Technical Subgroup, and she'll provide VAST assessment of the current state of knowledge around COVID-19 vaccine safety, specifically focused on Moderna COVID-19 vaccination. Following that, we'll have a break. Following that, we'll hear from Dr. Wallace, who will present the grade evidence around Moderna COVID-19 vaccine. Following Dr. Wallace's presentation, we'll hear from Dr. Oliver, who will present evidence to recommendations framework regarding the use of Moderna COVID-19 vaccine for a primary series in individuals 18 years of age and older. After that, we'll have a discussion. After that, we will have a vote on the routine use of Moderna COVID-19 vaccine for individuals 18 and older. Next slide, please. Following the vote, then we'll hear from Dr. Hall from the CDC, who will provide updates to clinical considerations. Following this, we'll hear from colleagues to the north. This is from the Public Health Agency of Canada, Dr. Tunis, Dr. Warshawski, and then we'll hear from Ms. Ogunake-Cook. They will present the Canadian experience and evidence with COVID-19 vaccine primary series extended intervals. Following this, we'll hear from Dr. Klein, who's from Kaiser Permanente, Northern California. She'll present VSD data on myocarditis after Moderna and Pfizer-BioNTech COVID-19 vaccines. Following this, we'll hear from Ms. Malia from the CDC, who will present regarding myocarditis and COVID-19 vaccine intervals, international data and policies. And then following that, we'll hear from Dr. Oliver from the CDC, who will present a summary and workgroup interpretations of extended intervals for mRNA COVID-19 vaccines, after which we'll have additional time for discussion. Next slide, please. So on this slide, we list the COVID-19 vaccines workgroup members who've been tremendously helpful in all of this. This includes ACIP members, ex officio and government members, liaisons and consultants, as well as the outstanding leadership of Dr. Sarah Oliver. Next slide. And then this slide shows a number of individuals from the CDC who are essential to the work of the COVID-19 vaccines work group. Next slide, please. And then I will turn it back to you, Dr. Lee.
Thank you, Dr. Daly. With that, we'll move on to Dr. Rita Das from Moderna, who will be presenting on mRNA 1273 COVID-19 vaccine BLA safety and efficacy data. So please go ahead, Dr. Das.
Thank you so much. Good morning. And thank you again to the ACIP for their diligent efforts throughout the pandemic. I'm pleased to present an overview of the BLA for the Moderna COVID-19 vaccine, or Spikevax, which was approved at the beginning of this week. We will discuss the contents of the BLA, the phase 3 safety data, and then the efficacy data. As was just mentioned, this approval includes the administration of the primary series in individuals 18 years of age and older. The follow-up time included is 5.3 months for the blinded study, that's post-vaccination, and 7.6 months for the blinded and open label phases of the study together. The BLA does not include the authorized indication for a third 100 microgram dose for immunocompromised populations, as well as the indication for the 50 microgram booster. The data for the Omicron variant also are not covered in this presentation. I'm going to move to my next slide. I just wanted to confirm that the slides are advancing for everyone.
Yes.
Okay, great. Thank you. So again, Spikevax is indicated for the immunization to prevent COVID-19 caused by SARS-CoV-2 in individuals 18 years of age and older. It's administered as an intramuscular injection in a series of 2 doses with a 0.5 ml volume, 1 month apart. And again, the dose is 100 micrograms. So I'll take you through Protocol 301, or the COVE trial, which is the pivotal safety and efficacy study. The study enrolled 30,400 people who were randomized 1-to-1 to receive the vaccine mRNA 1273 or placebo, about 15,200 in each group. The study started in July 2020 and completed enrollment by October 2020. The initial efficacy readout came from the interim analysis, which was at the end of November. That led to the approval of the EUA on December 18th. Thereafter, participants were offered unblinding, and placebo recipients were allowed to be vaccinated. All participants were then continued to be followed in an open label manner according to the original schedule of events. So in the next slide, I have the details of the schedule of events of the study. So at baseline, all participants had a nasopharyngeal swab and a blood sample to assess their SARS-CoV-2 status. After vaccination, everybody was given an e-diary to monitor solicited adverse reactions for 7 days. Unsolicited adverse reactions were monitored via weekly phone calls for 28 days. The same thing repeated after dose 2. Serious adverse events, medically attended adverse events, and adverse events leading to discontinuation were to be monitored for the duration of the study, which is planned to be 2 years. Throughout the study, also, case monitoring was conducted through weekly e-diary prompts and monthly phone calls. If the participants met the criteria for an illness visit, they came into the site, had a sample collected for central lab testing, and then participants were followed daily through telemedicine contacts for 14 days or until the resolution of symptoms, whichever was longer. Additional clinic visits were planned for 3, 6, 12, and 24 months after vaccination. So the mean age of the population in the study was about 52 years old. The goal of the study was to enrich for populations most affected by severe COVID-19. Accordingly, 25% of participants were greater than 65 years old, about 1,500 were greater than 75 years old, and another 17% were 18 to 64 years old with comorbid conditions like chronic lung disease, significant cardiac disease, obesity, liver disease, or HIV. And the HIV group had about 90 participants in the vaccine and placebo recipients. We had assessed baseline SARS-CoV-2 status, and approximately 2% of participants had baseline evidence of prior SARS-CoV-2 infection. So the racial and ethnic distribution of the study was generally similar to the US population, and this was a key objective in the recruitment of the study. There were 10% Black or African American participants and 20% Hispanic or Latino participants in the study. So now on to the safety. So once again, after each dose, solicited reactions were followed for 7 days, unsolicited for 28 days, and serious adverse events, medically attended adverse events, and adverse events leading to discontinuation were followed for the whole study. Solicited injection site reactions were more common among vaccine recipients compared to placebo recipients. This slide shows the solicited local reactions after dose 1. Injection site pain was the most common reaction, and the slide is also broken down by 18 to 64 and above 65, and local reactions were very similar between the two age groups. So the next slide here shows the solicited local reactions after dose 2, which were very similar. Again, mostly grade 1 or grade 2. Overall, local reactions were also of short duration and generally resolved in 1 to 3 days. Delayed local reactions with an onset after 7 days were seen, but were relatively rare, occurring in 2.4% of vaccine recipients and 1.4% of placebo recipients. Now on to the solicited systemic reactions. Again, for the solicited systemic reactions, most were grade 1 or grade 2 and were observed more frequently in the vaccine compared to the placebo recipients. Fatigue and headache were the most common reactions. And then on the next slide, so this is post-dose 1. On the next slide, I have post-dose 2. And we saw in the trial, as it's seen certainly in practice, that solicited reactions were more common post-dose 2 compared to post-dose 1. Older, greater than 65-year-old participants had a numerically lower reactogenicity compared to their younger counterparts. The duration of solicited systemic adverse reactions were also short, ranging from 1 to 3 days. So now on to unsolicited events. So unsolicited events occurring within 28 days of vaccination were similar among vaccine and placebo groups. Medically attended adverse events, serious adverse events, and deaths were also similar. And here we have the system organ class breakdown for the serious adverse events which occurred in the study. And as you can see here, the blue is the mRNA 1273, the gray is the placebo, and the occurrence, the system organ class of the solicited, of these serious adverse events were generally balanced. The same was noted for the medically attended adverse events, and I'm not showing you the graphic here. So next, looking specifically at myocarditis and pericarditis. During the blinded or the open label periods of the study, there were no myocarditis events. For pericarditis, in the blinded phase, there were 2 events in the vaccine group and 2 events in the placebo group. I'll go through the events in the vaccine group. The first one, the event that was considered related, was a 59-year-old woman with some symptoms 4 days post-dose 2, who then experienced chest pain and syncope 2 months later, when pericarditis and an effusion were diagnosed. This was considered related. The other case was a post-myocardial infarction pericarditis, which was considered unrelated. Now on to the open label phase. In the open label phase, again, no myocarditis was observed. There was 1 pericarditis event in a 23-year-old male who had COVID about 2 months prior to vaccination. And subsequent to vaccination, he developed bradycardia and was diagnosed with a pericardial effusion. This was also classified as a vaccine-related event. All of the events of pericarditis that occurred in either the blinded phase or the open label phase of the study resolved. Now on to efficacy. As a reminder, 30,000 participants were randomized to vaccine or placebo. The first read on the efficacy was at the interim analysis conducted in November of 2020, which showed the 94.1% efficacy. For the BLA, the final blinded analysis was performed with 5.3 months of follow-up that was calculated post-dose 1, and that was through March of 2021. Subsequently, the study entered the open label phase and placebo recipients were offered vaccines. Effectiveness has been followed since then in an open label manner. Additionally, boosting of study participants started in September of 2021 and is ongoing. So here's the final blinded analysis of efficacy, and the results were very similar to the initial interim analysis. There were 700, this is the COVID-19 infection endpoint, and there were 744 cases in the placebo group compared to 55 cases in the vaccine group for an efficacy of 93.2%. The median duration of follow-up here was 5.3 months. Since the study was conducted between July 2020 and March of, or since the blinded period of the study was conducted between July 2020 and March of 2021, the predominant SARS-CoV-2 variants identified in the majority of the COVID-19 cases were sequenced to be either the original or the alpha variant. Some additional variants that were identified included epsilon, gamma, and zeta. The case numbers for the other variants was small, but there was no indication that efficacy against other variants was impacted. Of course, there was no Delta or Omicron circulation during that time. So looking closer at the efficacy during various time periods, the efficacy was consistent and durable over the observation period. High efficacy started after vaccination and was maintained very consistently through greater than 4 months after vaccination. Vaccine efficacy to prevent severe COVID-19 was also consistent, with 106 cases in the placebo group and 2 cases in the vaccine group for an efficacy of 98.2%. Now here's a slide of all of the different endpoints. I already discussed the COVID-19 overall, the severe COVID-19, but here you also have SARS-CoV-2 infection regardless of symptoms, COVID-19 by the secondary or the CDC definition, deaths related to COVID-19, and COVID-19 efficacy starting 14 days after the first injection. And all of these were extremely consistent. Even asymptomatic infection was prevented by vaccination with an efficacy point estimate of 63%. Efficacy regardless of baseline serostatus also was consistent. The group sizes and the number of cases, however, became too small for an analysis on baseline SARS-CoV-2 seropositive only. Now here is efficacy by demographics. Efficacy was consistent across age. Greater than 65 had very high and consistent efficacy, and greater than 75 also had very high and consistent efficacy, although the case numbers did become small here. Efficacy also was consistent across race and ethnic groups. I'm not showing the data here, but efficacy for comorbid conditions, the ones that were targeted to be recruited in the trial, were also similarly consistent. So in summary, mRNA-1273 was well tolerated in individuals greater than 18 years old. Pain was the most commonly reported local reaction. Fatigue, headache, myalgia, and arthralgia were the most commonly reported systemic reactions. Systemic reactions were more common after dose 2 than dose 1. And there was no difference in adverse reactions for 18 to 64 versus greater than 65 years of age. And then after a median of 5.3 months post-dose 1 of efficacy follow-up, there was 93.2% efficacy against COVID-19 starting 14 days post-dose 2, 98.2% efficacy against severe COVID-19 starting 14 days post-dose 2, 82% reduction of infection regardless of symptoms, and 63% reduction in asymptomatic infection, all of this starting 14 days post-dose 2. Efficacy was consistent regardless of risk factors, age, gender, or race or ethnicity. So with that, I will conclude my, my presentation. I certainly need to acknowledge all of our collaborators and partners, all of the investigators and study personnel at the site, our colleagues at BARDA, NIAID, and the laboratory at Duke University. And most importantly, I'd like to thank our trial participants whose dedication to the trial really made all of this possible. Thank you very much, and I'm very happy to take questions.
Thank you, Dr. Doss. This presentation is now open for questions. And I see, Dr. Paling, you have your hand raised.
Yes, good morning, and thank you, Dr. Doss. This is a fabulous presentation, and really appreciate all the detail, including going through the results by race and ethnicity. The question I wanted to ask is, have you had a chance to look at the vaccine effectiveness for persons with and without comorbid conditions? Thank you.
Yes, absolutely. We have looked at all of the comorbid conditions, respiratory disease, cardiac disease, obesity, HIV. All of the efficacies were very consistent, above 80% for all of the comorbid conditions.
Thank you. Dr. Lair?
Thank you for this presentation. Could you please go to slide 8? I was wondering how you did the asymptomatic data I didn't see that when you were looking at testing, and I didn't think it was probably from the blood test that you had at day 200 something or other.
Yes, yes. So asymptomatic infection, and we did not do weekly or every 2 week screening for asymptomatic infection. These numbers came from the nuclear protein assays, which were done at every time participants had a blood draw. So, and as well as every time participants came into the study, into the site for a visit, they had a nasopharyngeal swab. So we took all of those positives and then checked to look whether there were any symptoms pages that were documented in the CRS. And so that's how, so the participants who had positives, either by serology or by PCR and P-swab scheduled at routine times, but did not have any symptoms, contributed to the asymptomatic infection analysis. I think it provides a good directional estimate, but it's certainly not a priori weekly or every other week screening for asymptomatic infection.
Thank you. And then if I could have one more question, if you go to page 26, your curve flattens out for the placebo there. And I'm just wondering, why would it flatten out if you're still getting more cases? I just didn't understand that. Thank you.
Yeah, I think we still were subject to the ebbs and flows of the overall trajectory of the pandemic. That's what I can come up with for the curve flattening out. Our COVID-19 infection curve does the same. So I think the most, if I would speculate, it would probably be because of kind of the trajectory of the pandemic at that time.
Thank you, Dr. Lair and Dr. Das. Are there any additional questions for Dr. Das? Dr. Sanchez.
Thank you, and thank you for that presentation. Certainly, it's great data and very encouraging. I had a question on the deaths. On your slide 18, any death that was reported was 16 in the vaccine group, and then placebo was also 16, certainly similar. But then you really, so then you finally analyzed only the COVID-related deaths, right, in the number of events. Do you know what these deaths were due to?
Yep, so these are the total, these are actually the total deaths. The COVID-related deaths analysis was 3 deaths in the placebo group and no deaths in the vaccine group. Let me actually take the slide down for a second, and I will get to the all deaths slide. Apologies, bear with me for a second. Yeah, and so just while I'm getting to the slide, none of the deaths were considered related to vaccine, and kind of the number of deaths were really reflective of the type of population that was enrolled, with multiple comorbid conditions. And so here we go. I can show you. Okay. Into presentation mode. Yeah, and so these are the deaths, all the deaths in the study, kind of broken out by vaccine and placebo. And so again, it is, the relationship to treatment is all is not related, and the conditions are reflective of the large size of the population and and the comorbid conditions of the participants who were enrolled. And then here is the, so here's the rest of it. So the database was locked on May 4th, and then all of the data are through the March time point.
Thank you. And I have another question. Were you able to look at development of diabetes? I know this is an older age group, but I presume that was one of the comorbid conditions?
Yes, diabetes was indeed one of the comorbid conditions. As of the new, I think you're asking about the new development of diabetes during the trial. Yeah. Is that correct?
Yes.
Yes, and let me take that back, and I will ask my colleagues if there is a specific dedicated analysis for that.
I know that's been seen more in the children, but it's with COVID, but just was wondering in the adult population.
Yeah, I'm not recalling it as a signal that came out, but let me, I will confirm with my colleagues to see if this analysis was specifically done.
Thank you.
Thank you. Dr. Long?
Yes, thank you so much. I know that we've seen about severe disease, hospitalizations, and death, but the question is about infection, be it symptomatic or asymptomatic, and the protection against those kinds of infections not leading to hospitalization over the even short time of the study. Meaning increasing days since your first dose, second dose, whatever.
Yeah. So, I mean, our protection by the time frames that we looked at was extremely flat. So, we did that, and I showed you the COVID-19 analysis by time frame, and it was extremely flat. All of the always like consistently at 90, we did the same for the other endpoints. Again, those were all flat as well, indicating the consistent and not waning protection over the period that was assessed in the study. The COVID-19 endpoint was 2 symptoms plus the positive PCR, but then we also looked at the more permissive, or perhaps more kind of relevant to your question, the CDC case definition, which only required 1 symptom plus the positive PCR. And there again, the efficacy was very consistent.
Thank you.
Thank you. Are there any additional questions for Dr. Das? Dr. Paling.
Yes, I wanted to ask about anaphylaxis in the trial. Could you share the results on that? Thank you.
Yes, absolutely. Let me pull that up. Okay, yes. So anaphylaxis was reported in 2 participants. So it was actually balanced between the vaccine and the placebo group. In the placebo group, an anaphylaxis was reported in 2 participants on day 10 and day 11 after the first injection. And then among the vaccine groups, it was also reported in 2 participants. And the anaphylaxis events in the vaccine group were actually reported a bit later, almost 2 months after the second dose. Both were considered not related. And so, although there was not an imbalance of anaphylaxis that was seen in the trial, anaphylaxis, of course, is listed in the label as a possible side effect.
Thank you very much. Last call for questions. Okay, Dr. Sanchez.
I was just interested in learning a little bit more about the pericarditis in the 23-year-old male who it sounds that it was after the vaccine, but he had been in the placebo group and had had COVID previously. And do you know what the severity of that COVID infection had been? Because he was diagnosed with COVID and he was placebo, and then he got the first dose of the vaccine, and then subsequently after dose 2 is when he developed the pericardial effusion. Do you know the severity of that COVID-19 infection? Had he had some more? Was he hospitalized? Had he been, because this is an issue that comes up is after COVID and after having COVID, when do you vaccinate and how long do you wait and what other should you? I was just wondering if you knew the severity of that COVID-19 infection.
No. So he was not hospitalized or did not meet the criteria for severe COVID because he was because this participant was one of the cases in the in the blinded phase of the analysis. Beyond that, yes, I'm getting a confirmation that the COVID case was mild, and that is the information that we have, that 43 days after dose 2, he was diagnosed with bradycardia and a pericardial effusion. And there was some kind of bradycardia prior to that, which was not associated with any chest pain.
And it was 2 months, and the first dose was 2 months after receiving that first COVID, the first dose. Okay.
Yeah, so he had COVID with mild symptoms. Then 2 months later, after the unblinding of the study, he received the first dose of the vaccine, then received the second dose of the vaccine a month later. And then subsequent to that, there was some bradycardia that was noted. And about 43 days after dose 2 was diagnosed with a pericardial effusion and pericarditis.
Thank you.
Thank you. I'm going to actually suggest that we take a break. So we'll thank our presenters, and we will now recess until 10 minutes after the hour, after which we will return for a public comment session. Thank you, everyone.
LL1234.
Thanks, everyone. It's now 10 minutes after the hour, and we'll reconvene the meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. As a reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed today. Thank you again to our speakers, and we look forward to your comments. Our first public comment speaker today is Milena Berhan.
Thank you, Dr. Lee. My name is Milena Berhan, and today I'm representing the National Consumers League. Since NCL's founding in 1899 by social reformer Florence Kelley, we have advocated for the critical role immunizations play in the preservation and improvement of public health. We extend our gratitude to this committee for the opportunity to present public comment. An estimated 890,000 Americans have died from COVID-19 during this pandemic that has persisted in the US for the past 2 years. The COVID-19 virus continues to threaten the health and safety of many, especially vulnerable populations such as the elderly and immunocompromised groups. The currently available COVID-19 vaccines have worked to save lives and avoid preventable illness, hospitalizations, and deaths in our communities. The National Consumers League commends the FDA and the CDC on the approval of the Moderna COVID-19 vaccine, which will continue to be a key tool in the public health response to this pandemic. This vaccine has been and will continue to be a safe and effective measure to protecting Americans 18 years of age and older. America's families are hopeful that the Pfizer COVID-19 vaccine will be granted emergency use approval for children under 5 years of age. Hospitalization of children under 5 years of age has soared, further evidence of the need for expanding vaccine access to children in this age group. Vaccinating children under the age of 5 will protect them from illness, but also protect their families, caretakers, and teachers from contracting COVID-19 as well. We are also concerned about the widespread drop in routine childhood immunization rates during the pandemic. According to CDC data released last May, over 11.7 million children have missed doses of their recommended vaccines. We are particularly worried that our nation's most vulnerable children, those who qualified for the Vaccines for Children program, are getting caught up at a much slower rate than children with commercial insurance. The National Consumers League recognizes the extreme importance of immunizations in protecting the health and safety of all Americans and will continue its efforts to increase vaccine confidence and uptake across lifespans. We look forward to the upcoming recommendations by this committee regarding these COVID-19 vaccines. Thank you.
Thank you for your comment. Next, we have Laura Burns.
Good morning. My name is Laura Burns, and I represent TRAPAG, the Transplant and Immunocompromised Patient Advocacy Group. There are about 2,000 of us linked by a Facebook group. About half of us are participants in the Johns Hopkins vaccine efficacy studies for transplant patients and the immunocompromised. TRAPAG strongly supports approval of the BLA for the Moderna vaccine, but we wish that the approval could take the straitjacket off our doctors and give them the ability to individualize our care. I'd like to quote something Dr. Dori Segev, the head of the Johns Hopkins studies, said in an interview a couple of weeks ago. Quote, "So, for example, if one of my patients got 3 doses and they ended up with a relatively low but still positive antibody, I would want to give them a 4th dose to boost them up so it will be much higher. But I can't do that today. The only 4th dose that people can get is if they had 3 doses 6 months ago. Now they can get a 4th dose as a booster, but not to complete the primary series," unquote. Our group is very active on Facebook, and we are all discussing our individual dilemmas. For example, a number of people get infusions twice a year. Many find their 5-month booster falls at the same time as their infusion. But they know from their doctors that the infusion will negate the vaccine effectiveness. What to do? We're seeing the same thing with Evusheld. People know they should get boosted before Evusheld. And wouldn't it be better to get the booster now 4 months after their third dose and then Evusheld, rather than waiting a month for the booster and then another 2 weeks for Evusheld. 6 weeks. Likewise, many of our doctors tell us they wish we could get a full dose of Moderna for our booster. They think it makes more sense for the immunocompromised, especially if we had a weak response to the primary series. I'll close with another quote from Dr. Segev's interview. As doctors, I'm sure you'll be able to appreciate it. Quote, look, this really needs to be individualized. We can't keep going. The CDC, FDA guidelines can't be this really complex decision tree of, well, did you have 3 doses and was your antibody level less than 250? And if it was, are you taking MMF? And if you are, then you should get a 4th dose, but it should be at 2 months, whereas this other person should get it at 4. I mean, that's just way too complicated for a big government agency to be doing. But that is what doctors do. That's like what medical providers do. They individualize care for their patient. The difference is for any other medication I give my patient, I have the permission to do so. For vaccines, we don't have permission to do so, unquote. Committee members, thank you so much for your attention and for all that you're doing to keep us safe. Again, we fully support the BLA for Moderna. Thank you.
Next, we have Dr. Leila Sani.
Good morning. My name is Leila Sani. On behalf of Texas Children's Hospital, I would like to thank the CDC employees and ACIP members who have diligently analyzed COVID-19 epidemiology and vaccine safety and efficacy data and adeptly provided risk-benefit assessments based on this information. Using your in-depth analyses, my colleagues and I have been able to assure families of the safety and effectiveness of COVID-19 vaccines. As an epidemiologist with more than a decade of experience conducting pediatric infectious disease research, I know that vaccines are the best way to protect people from COVID-19 and are our best hope for ending the pandemic. As you continue your discussions today and in the future, I urge you not to minimize the risk of COVID-19 to our youngest children under 5 years of age. To date, almost 10 million children have been diagnosed with COVID-19, with almost 2 million cases and almost 400 deaths occurring in children younger than 5. Early in the pandemic, compared to the elderly, children were thought to be relatively unaffected by COVID-19, and pediatric hospitalizations and deaths have been largely overshadowed, causing many to question the need for COVID-19 vaccines for children. However, with the arrival of the Omicron variant, children's hospitals across the nation have reported dramatic increases in COVID-19 hospitalizations. As we continue to vaccinate persons 5 years of age and older, we drive COVID-19 into the unprotected group of our youngest children. As a result, hospitalization rates in children younger than 5 years are the highest they've been at any point in the pandemic, peaking in January almost 5 times higher than they were last year. Children younger than 5 are typically unable to wear masks for extended periods of time and don't understand the concept of social distancing. At the same time, we know that interaction with other children and early childhood education are essential for child development. Parents of young children have no good choices. They must either accept the risk of infection as a consequence of social interactions and preschool attendance in communities with high levels of COVID-19 and minimal mitigation measures, or they must forego the important benefits these activities confer. They deserve better options. Although the immunogenicity of a 2-dose primary series of COVID-19 vaccines for children under the age of 5 produced a less robust immune response than desired, there is every reason to believe that it provides some protection. The safety profile of this vaccine is reassuring, and the 3rd dose currently being studied is expected to provide comparable protection to COVID-19 vaccines given to older children and adults. For these reasons, ACIP must act expeditiously to recommend COVID-19 vaccines for children younger than 5 years of age as soon as emergency use authorization is granted. As we approach the 2-year mark of the COVID-19 pandemic, we must do everything we can to minimize further detrimental effects to young children, many of whom cannot remember a life before the pandemic. COVID-19 vaccines are safe and effective for children of all ages, and I urge you to give these factors your every consideration. Thank you for your time.
Thank you for your comment. Next is Mr. Kermit Kubitz.
Good morning. My name is Kermit Kubitz, and I support the comments before me of the National Consumers League and the Transplant Group. The success and positive benefit risk of COVID-19 vaccines is clear. And the most important slide that I saw in the presentations this morning was the success in vaccination of preventing more than 10 million hospitalizations and more than 1.1 million deaths. That is, without the COVID-19 vaccines, we could have had 2 million deaths from COVID-19 in the United States instead of the 890,000 so far. And further vaccination will allow a return to normalcy. So I support the COVID-19 vaccine BLA for Moderna. Increased vaccination will allow a return to normalcy. Denmark, for example, has recently lifted COVID restrictions because of its high vaccination rate of more than 80% compared to the US of about 64% fully vaccinated. And if we want a return to normalcy, if we want a return to schools without masks, if we want a return to dining in restaurants, if we want a return to meeting in groups, we must have vaccination to the level that reduces the pandemic to an endemic, if that is the future. I also support rapid development and approval of lower cost vaccines like biological ease Corbevax, which is capable of promoting more widespread worldwide vaccination. The development of variants around the world threatens all of us. No one is protected until everyone in the world is protected, and we must support global vaccine equity and increase vaccination of the 70% of the world which has not received the same vaccination levels in the United States. And I want to thank all the doctors and nurses around the country struggling with the pandemic and the result of the pandemic of the unvaccinated, causing hospitals to be overwhelmed. Thank you, CDC and FDA and ACIP members, for all you do.
Thank you for your comment. Next, we have Dr. Aaron Prosser.
I want to thank the committee for the opportunity to provide comments. My name is Dr. Aaron Prosser, medical resident at McMaster University in Canada. COVID-19 vaccines have been a vital tool for reducing the burden of this disease on healthcare systems. My comments pertain to COVID-19 vaccine mandates. This is because policies set by the CDC influence whether COVID-19 vaccination will, for example, be a condition of employment or education. In addition to increasing vaccination levels, mandates isolate those who remain unvaccinated from accessing various settings. The hope is isolation will reduce transmission from the unvaccinated. This is based on the idea that unvaccinated people are at high absolute risk of transmission in non-household settings. These risks are thought to be high enough to justify excluding the unvaccinated. However, these absolute risks have not been quantified. The arithmetic is simple and the data is publicly available. These absolute risks are the combined probabilities that an unvaccinated person gets infected and transmits COVID-19 in a given type of setting. My colleagues and I have quantified these absolute risks in a recent paper which, while a preprint, is timeless. Dividing one by these absolute risks gives a metric similar to the number needed to treat, which we call the number needed to isolate. In the United States, once a wave of infection subsides, we found that on any given day, the absolute risk of a transmission event in healthcare or educational settings is between 1 in 1,000 and 1 in 3,000. In other words, on any given day, we would have to exclude between 1,000 and 3,000 unvaccinated people from working in healthcare or accessing education to prevent one transmission event. Please note, this is to prevent usually mild, sometimes asymptomatic infection, especially given the high levels of immunity already present in the population, particularly the most vulnerable. And so my comment is one of proportionality and compassion. COVID-19 has been devastating. COVID-19 vaccines are beneficial, especially for preventing severe illness, but our policy responses towards unvaccinated people needs to be proportionate to the risks, compassionate to the harms of these policies, and open to accommodation. In medicine, there is a clinical intuition that if one has to apply an intervention to hundreds or thousands of people to extract one benefit, a careful weighing of harms and benefits is needed. We may disagree with the viewpoints of people who remain unvaccinated, but we must consider the harms of exclusion through mandates, which includes making people unemployed, unemployable, and unable to access education. My one request is that you clarify your position on COVID-19 vaccine mandates, since your decision today on this question will echo throughout the United States and beyond. I think it is important that this be part of the public record. Thank you very much for your time.
Thank you for your comments. Next, we'll move on to Mr.
Hello. My name is Steve Kirsch. I'm the Executive Director of the Vaccine Safety Research Foundation. I have no conflicts. My remarks, as well as all the supporting data, are posted on my Substack at stevekirsch.substack.com. There are 4 compelling reasons why you should not approve the Moderna vaccine. Reason number 1, after 90 days, the Moderna vaccine has negative efficacy against Omicron. You cannot possibly approve a vaccine which, after just 90 days, shows negative efficacy against the predominant variant. This was very clearly shown for the Moderna vaccine in the Denmark study and subsequently confirmed by data from the German government. There are now over 13 studies, including the famous Harvard study, that clearly shows that the infection rate is highest in those countries with the greatest vaccination rate. If the vaccines worked as claimed, how do you explain these studies? Reason number 2, the Moderna vaccine kills more people than it's likely to save. A conservative estimate of the number of deaths using the various data and CDC's own methodology shows the Moderna vaccine has killed at least 64,000 people. The Moderna trial data shows that over 13,000 lives may have been saved, but that is optimistic because the dominant variant has shifted. In short, the Moderna vaccine will kill at least 4.8 people from all-cause mortality for every life we might save from COVID. It simply makes no sense. Reason number 3, the vaccine fails on an absolute safety basis. The Moderna vaccine kills at least 643 people per million, as I just pointed out. That makes these vaccines nearly 1,000 times deadlier than the smallpox vaccine, which previously was the most deadly vaccine in human history and is considered too unsafe to use by experts. Reason number 4, you should not approve the vaccine until you see all the safety signals. Although the phase 3 trials claimed no safety concerns were identified, there are hundreds of very serious adverse events that are being ignored. For example, according to the VAERS US data, the average rate of pulmonary embolism reports is just 3 per year. With Moderna, we have 1,245 events, 415 times normal. How can that not be flagged as an adverse event? The only way that can happen is if the people who are in charge of monitoring the safety signals are either blind or corrupt. The public is not being informed of hundreds of safety signals like this. Some people believe that the reports in VAERS are unreliable. There's no evidence of this. In fact, the individual doctors report seeing adverse event rates that are 20,000 times higher than any other vaccine. These doctors are afraid to speak out due to threats and intimidation by state medical boards and others. And there were Facebook vaccine injury support groups with 250,000 people that were deleted by Facebook. Both of these anecdotes are impossible to explain if the COVID vaccines are truly safe and effective as claimed. Again, all of the supporting data is posted to my Substack at stevekirsch.substack.com. Thank you.
Thank you for your comment. Our next public comment speaker is Dr. David Wiseman.
Hello, can you hear me now?
Yes, please go ahead.
All right, thank you. Sorry, beg your pardon? Yes, thank you. FDA have repeated the regulatory misdirection used for Comirnaty by BLA approving a non-available Spikevax and maintaining an EUA for a legally distinct Moderna product with, quote, certain differences that do not impact safety or effectiveness. This nonsense, somewhat repeated in a presentation later today, was rationalized at the August 30th ACIP by the suggestion that full approval of one quasi-vaccine would motivate 31% of vaccine hesitants to take any of the 3 vaccines. This product is obsolete. Its pre-Omicron efficacy is irrelevant to this discussion, and no Omicron data have been presented today. The Spikevax indication is prevention of COVID, but it fails to meet FDA's guidance VE target of 50% with a lower confidence boundary of 30%. Not shown in the grave presentation later today is a Danish Hansen et al. Study with an initial 37% Omicron VE waning to negative 39% by 3 months. Neither is the Canadian Buchan study, with VE starting around 0, dropping to minus 40%. The February the 3rd UK report shows Omicron VE waning to around 50% by 5 weeks and below 30% by 15 weeks before the 5-month authorized boost interval. None of these support the indication of COVID prevention within FDA guidance. Whatever VE can be mangled out of spikebacks with boosting with a risk of immune erosion would only have been relevant had 3 doses, not 2, been included in the BLA. With almost no benefit, we are left with risk. There has now been enough time to collect data, but the label that says there are insufficient data to inform risks in pregnancy, something similar for lactation as well. Yet CDC still recommends vaccination in pregnancy and lactation. The label and CDC statements conflict regarding immunocompromised, who may have a diminished immune response to spikebacks. The trial saw herpes zoster reports double, and the effects of spikebacks on cancer, mutagenicity, and male fertility have still not been evaluated. Our earlier written comments documented intense safety signals for death, MI, coagulopathy, and thrombotic events. For myocarditis, FDA and Pfizer have acknowledged underreporting by 4.8 times. A recent MMWR paper revealed theirs 6.5 times underreporting for hospitalization in children. Still, spikebacks is not regulated as gene therapy product, as Moderna said in a 2020 SEC filing. We still lack the full sequence of this nucleoside modified mRNA. Moderna's founders previously wrote that their first application will likely not be a vaccine because the tolerance for side effects is very low in healthy individuals. If the use of booster doses was considered the last whack-a-mole, according to Dr. Long at the last ACIP meeting, using an obsolete product that ventures into negative VE territory before the authorized boosting interval must surely put us way beyond the last whack-a-mole. Thank you.
Thank you for your comment. Next, we have Ms. Elizabeth Dietz.
Good morning, Dr. Lee and committee members, and thanks for your tireless work in this pandemic. My name is Liz Dietz, and I'm speaking for myself as a citizen and as a grandmother. I strongly support the BLA for the Moderna vaccine and moving with all due speed to approve vaccines for under 5s. The effects of the pandemic are universal, but also hyperlocal, and inequalities in vaccine access and other NPIs are noticeable. I live in San Mateo County, California. Because of the strong public health leadership in my county and state, we have been doing relatively well. 86% of county residents 5 years and older have been vaccinated. The Omicron testing trend is going in the right direction, dropping from 16% positive in January, beginning of January, to a 7% positive rate on January 31st. But we are failing to reach some of our most vulnerable population elements. The Pacific Islander population, the Black African American community, and the Hispanic population are all less than 63% fully vaccinated. The February 1 report from the Kaiser Family Foundation is, for me, hard to put a shine on. 8 in 10 parents of unvaccinated kids don't say that Omicron doesn't make a difference, and 1/4 of the parents say they will definitely not get their 12 to 17-year-olds vaccinated for COVID-19. Why the resistance? On February 3, Brandy Zarodny published anti-vaccination groups have enjoyed a pandemic windfall. She reported that the Big Trees Informed Consent Action Network reported $5.5 million in revenue in 2020, a 60% increase over 2019. Robert Kennedy's organization, Children's Health Defense, more than doubled its revenue in 2020. By contrast, two pro-public health groups, Voices for Vaccines, budget was $600,000, and Vaccinate Your Family noted that they had $1.6 million in revenue. Pro-public health groups are woefully losing the funding race, and so these bad ideas spread. I'd like to point your attention to the Urgency of Normal group that has developed a platform for parents to convince school boards to give up NPIs and throw it open. I have no solutions other than to push back against these false ideas. The right to health is a fundamental right, even for the smallest children. None of us is safe until all of us are safe. Thank you for this opportunity to share my concerns with you.
Thank you for your comment. Our last public speaker for the session is Evelyn Pinheiro.
Good morning. Can you hear me?
Yes, we can. Please go ahead.
As an informed member of the public, a teacher, a mother of small children, I am in complete support of the BLA for the Moderna vaccine. I also belong to a group of parents and physicians called Protecting the Future, and we specifically implore you to expedite the authorization of this vaccine for children under 5 once it's deemed safe and effective. This is the only segment of the population who does not have access to a vaccine. Pediatric hospitalizations surged during the Omicron wave, and a full half of them in New York were from the 0 to 5 age group. At a time when districts are repealing their masking mandates and going back to normal, which mine just did last night, we still have no normal. I have no protection for my preschooler in school now, and parents of children under 5 note the same thing to me. While myocarditis has been a side effect under discussion, physicians note that this doesn't seem to be an issue in prepubescent children. If the committee feels they must limit usage to certain age groups due to this risk, we ask you to humbly bypass the age de-escalation barriers that would prevent the vaccine from being used in the younger age groups. We do have the upcoming possibility of a Pfizer vaccine, but especially in the 2 to 4-year-old population, this will be the subject of much debate. We desperately need access to the Moderna vaccine for the under 5 age group. In addition, I also implore you to allow off-label use for our children, especially those on high risk. Once Moderna is deemed safe and effective in the under 5 age group, please do everything in your power to expedite its EUA, including bypassing age de-escalation barriers.
Thank you for your comment. Next, well, let me actually just pause for a moment and thank all of our public comment speakers. We appreciate the engagement in our open public meeting. We will now move on to the vaccine safety session. We will have 2 presentations from our CDC colleagues, followed by a summary and assessment from Dr. Kip Talbot, who chairs the COVID-19 Vaccine Safety Technical Work Group. We'll begin with Dr. Tom Shimabukuro, who will provide updates on myocarditis and pericarditis following Moderna COVID-19 vaccines. Dr. Shimabukuro, the floor is yours.
Thanks. Can I get a quick sound check? Can you hear me okay?
We can hear you. Thank you.
Thanks. Hi, good morning. And today I'll be giving an update on myocarditis and pericarditis following Moderna COVID-19 vaccination. Next slide. I'll discuss reporting rates of myocarditis following Moderna COVID-19 primary series vaccination in the Vaccine Adverse Event Reporting System, or VAERS, among persons ages 18 years and older. Describe care and outcomes of persons ages 18 years and older with myocarditis after Moderna primary series vaccination reported to VAERS. And then describe a vaccine safety data link, or VSD, subgroup analysis of confirmed myocarditis and pericarditis cases after primary series Moderna vaccination among persons ages 18 to 39 years. Next slide. So starting with VAERS. VAERS is the nation's early warning system for vaccine safety. It's a spontaneous reporting or passive surveillance system that's co-managed by CDC and FDA and has been in effect since 1990. Next slide. As a passive surveillance system, VAERS accepts reports from everyone, regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. The key strengths for VAERS is that we can rapidly detect potential safety problems and can detect rare adverse events. Key limitations are those of spontaneous reporting or passive surveillance to include inconsistent quality and completeness of information, reporting biases, and generally we cannot determine cause and effect from VAERS data alone. Reports to VAERS do not necessarily mean that the vaccine caused the adverse event. Next slide. So I'll start with a table on reporting rates, and this is per million doses administered of myocarditis among males after Moderna COVID-19 vaccination in the days 0 to 7 after vaccination. Day 0 was the day of vaccination. and this is data through January 13th, 2022. So for the overall numbers, during that period, there have been 76.6 million total doses of Moderna COVID-19 vaccine administered to males. These are both dose 1 and dose 2. And during that time, there have been 283 myocarditis case reports in the days 0 to 7 after vaccination that met the CDC case definition. These are reports where we follow up to get medical records or interview the provider, and we confirm that the case report met CDC case definition. On the table there, you see the table for males, and it's broken down by ages in the age groups and by dose 1 and dose 2. Those are, again, reporting rates, are rates per million doses administered. And the numbers highlighted in peach are those where the reporting rates exceed the background incidence, and we determine the background incidence based on literature, based on published data in the scientific literature. So after dose 1, in the age groups 18 to 24, 25 to 29, and 30 to 39, the reporting rate exceeded the background incidence, 5.8 per million, 2.9 per million, and 3.3 per million. And then after dose 2, the reporting rates exceeded background incidence in the 18 to 24-year-old age group, 25 to 29, 30 to 39, and 40 to 49. And you can see from this table, reporting rates are consistently higher after dose 2 versus dose 1. However, when you get to 50 and older, the reporting rates are not exceeding the background incidence, and there really is not much difference between dose 1 and dose 2, as you might expect. Next slide. So this is a similar slide, but looking at females. So reporting rates per million doses administered of myocarditis among females after Moderna vaccination in the days 0 to 7 after vaccination. Again, data through January 13th, 2022. For the total numbers, there's roughly 85.7 million total doses of Moderna administered to females. And during this analytic period, we had 76 myocarditis case reports in the days 0 to 7 that met CDC case definition. And the reporting rates exceeded background incidence after dose 2 in the age groups 18 to 24 and 25 to 29. So it would probably be easier if these were on both slides, or if the tables were on both slides. But what we basically see, if you could switch back to the previous slide, you see that the reporting rates exceeded background incidence in more age groups for males for dose 1 and dose 2, and just the overall reporting rates were higher. Could you go to the next slide, please? And that's evidence by the actual numbers and by the highlighting of these slides in peach where the reporting rates exceeded the background incidence. You see only after dose 2 in females and only in the 18 to 24 and 25 to 29-year-old age groups. Next slide. So in this slide, I described the care and outcomes of myocarditis cases reported to VAERS after the Moderna primary series among persons ages 18 and older. Again, these are case reports in the 0 to 7 days after vaccination. So of the 359 case reports meeting case definition, most 337 were hospitalized, 335 were discharged, 230 or 69% were known to have recovered from symptoms at the time of the report. 2 had disposition under review. 22 were not hospitalized. They were seen in the emergency department, urgent care, outpatient clinics, or was not specified. Next slide. So in summary, 164 million total doses of Moderna COVID-19 vaccine were administered to persons ages 18 years and older as of January 13th, 2022. There were 359 total reports of myocarditis to VAERS in the 0 to 7 days following vaccination that met CDC case definition. Reporting rates of myocarditis exceed background rates for males in the ages 18 to 49 years, depending on dose, and in females in the ages 18 to 29 years after dose 2. Reporting rates of myocarditis were generally higher following dose 2 versus dose 1, especially in males. Most myocarditis patients were hospitalized and most were discharged home. Most discharged patients, 69%, had recovered from symptoms at the time of discharge. I do want to mention that VAERS is a surveillance system and is really not designed to assess the long-term outcomes, and we recognize that, and we have a special enhanced surveillance project that is following up. I'm doing a detailed follow-up on these case reports to further assess recovery status and long-term outcomes, and you'll hear about that in the next presentation. Next slide. So moving on to the Vaccine Safety Data Link. This is a collaborative project between CDC and 9 integrated healthcare organizations that you see here on the map. It's an electronic health record-based system, and it was established in 1990. Next slide. So we conduct rapid cycle analysis in the Vaccine Safety Data Link, and that's to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest among the VSD member population, and to describe uptake of COVID-19 vaccines over time among eligible VSD members overall, and in strata by age, sex, and race and ethnicity. And monitoring began in December 2020 when the vaccines became available. Next slide. So these are the VSD COVID-19 vaccine rapid cycle analysis pre-specified surveillance outcomes and the settings in which we monitor them. Next slide. So the analytic strategy for the primary analysis, we look at the number of outcomes observed in the risk interval after vaccination compared to the number expected. The expected counts were derived from vaccinated concurrent comparators who were in a comparison interval after COVID-19 vaccination. On each day that an outcome occurred, vaccinees who were in their risk interval were compared with similar vaccinees who were concurrently in their comparison interval, and the comparisons were adjusted for age group, sex, race and ethnicity, VSD site, and calendar date. Next slide. So the myocarditis and pericarditis electronic case identification follows this pathway. Cases are initially identified using ICD codes, and you see the code list there on the right-hand side. And this is followed by chart review and adjudication of these cases by clinical subject matter experts using the CDC case definition. So this is a chart-confirmed analysis. Next slide. This is the VSD mRNA COVID-19 vaccine totals, the uptake in persons ages 18 to 39 years. The Moderna vaccines are in the blue lines with dark blue Moderna dose 1 and light blue Moderna dose 2. And through the analytic period, there were about 923,000 Moderna dose 1s and about 901,000 Moderna dose 2s. Next slide. So this table shows confirmed myocarditis and pericarditis cases identified in the 0 to 7 day risk interval among persons ages 18 to 39 years compared with outcome events in vaccinated comparators on the same calendar days from Moderna COVID-19 vaccination. These analyses are through January 15th, 2022. So on the left-hand side of this table, you see the Moderna COVID-19 vaccine doses. And then in the next column, you have events in the risk window. The risk interval is 0 to 7 days, both the raw counts and then the per million doses, then the events in the comparison interval, and then the adjusted rate ratios, p-values, and the excess cases in the risk interval per million doses. The excess cases are the excess cases in the 0 to 7 days compared to the cases in the comparison interval at 22 to 42 days. So looking at dose 1, this is the second row, you'll see that the risk is The adjusted rate ratio is 3.46 and is statistically significant, and that equates to an excess cases of 6.9 per million doses administered. Then looking at dose 2, we see an adjusted rate ratio of 18.75, which is highly statistically significant, confidence interval from about 6.7 up to 65, and 31.2 excess cases in the risk interval per million doses administered. So the columns, the bottom two columns in blue there are actually subsets of the dose 2, where we're looking at males and females separately. You can see the adjusted rate ratio in males is 16.96, with a confidence interval of 6 up to about 59, with an excess number of excess cases of 61.8 per million doses administered. And then for dose 2 females, we have a small number of events. The adjusted rate ratio is not estimable because we don't have any comparison events in the comparison interval. However, we can calculate a lower bound of the 95% confidence interval, and we have 6.2 excess cases in the risk interval per million doses administered. Next slide. So in summary, there are about 920,000 dose 1 and about 901 dose 2 Moderna COVID-19 vaccinations that have been administered in the VSD during the analytic period through January 15th. VSD analyses with vaccinated concurrent comparators indicate that Moderna COVID-19 vaccination is associated with an increased risk of myocarditis and pericarditis in persons ages 18 to 39 years. The increased risk was observed after both dose 1 and dose 2 in the 0 to 7 day risk interval, with risk greater following dose 2. The dose 2 adjusted rate ratio was 18.75 versus the dose 1 adjusted rate ratio of 3.46. The highest excess cases per million doses administered were observed after dose 2. There were 31.2 excess cases per million doses administered in both males and females combined, and 61.8 excess cases in the risk interval per million doses administered to males. Next slide. I'd like to acknowledge the contributions of the following groups to this presentation. Next slide. Next slide. That concludes my presentation, and I'll be happy to answer questions, or if you want to move to the next presentation, be happy to answer at the end of the session.
Thank you, Dr. Shimabukuro, as always. Are there any questions that the committee members or our ex officio or liaisons would like to ask? And we'll have multiple opportunities during this vaccine safety session. First, we'll move to Dr. Paling.
All right. Thank you, Dr. Shimabukuro, for a great presentation. The question I wanted to ask related to a public comment. And so I wanted to have you help us explain for everybody about the difference in the reported cases of myocarditis and those that met the CDC definition, and why that's so important. Thank you.
Sure. So the VAERS data are based on spontaneous reports. So anyone can submit a report, a patient, a parent, healthcare provider, caregiver. These reports come into CDC in different states of completeness. And one thing that we do when we get these reports that are suspicious for myocarditis, we follow up on them by reaching out to the reporter. Specifically, we try to contact the healthcare provider, the healthcare facility, to get medical records, so we can basically review these medical records, fill in missing information, or confirm information in the report, or correct information that may be erroneous in the report. We sometimes actually speak to the healthcare provider over the phone, and we gather enough information where we feel that we can be confident applying the CDC case definitions for myocarditis and pericarditis, which are published in the MMWR. And this adjudication is done by clinicians who are trained in doing this. and then basically we put these into categories where we can say these meet the case definition, the CDC case definition. Some we don't have information to evaluate, and some we determine do not meet the case definition because they aren't myocarditis, or they just the evidence, the information that's provided leads us to believe that this is not a true case of myocarditis. In our analyses, the reporting rate analyses and our evaluation of these reports is based on reports that have been reviewed, adjudicated to meet the CDC case definition.
Thank you. Dr. Lair?
Thank you for this presentation. You focused on the 0 to 7 day interval, but I wonder, did you also study day 8 to 21 for comparison? So if someone called in and had chest pain and elevated troponin on day 10 after the vaccine, what would happen to that report? Thank you.
So we do that analysis, and in the enhanced surveillance follow-up on these, which you'll hear next, we do follow up on all cases that meet the CDC case definition for myocarditis. We know from reviewing VAERS data and from data in our vaccine safety data link, and also from data that's been generated from other international partners, that these cases do cluster in the day 2 to 3 to 4 after vaccination. In order to focus our analysis for this particular presentation, we decided to concentrate on cases that present or have symptom onset within the week of vaccination. We do have analyses that look at other intervals, mainly up to 21 days. But I think the data that we have right now, show a clear clustering in the several days after vaccination, and that's what we focused this presentation on.
Thank you. Dr. Brooks?
Yes, 2 quick questions. One is similar to what Dr. Lair just asked. So in the VSD data, you had the 0 to 7 days and then the 22 to 42. Was the rate in the 22 to 42 equal to what we expect to see in background, 0.2 to 2.2? And then the second question is, there were 335 hospitalizations and 359 cases in the VAERS data, and all went home were discharged with, and 2 are under review. So I'm curious whether those 2 under review, were there any deaths?
I don't know the answer to I think one of the questions you're asking is, what is the rate in the 22 to 42 days in the vaccine safety data link data? I don't have that information available to me. To get to the interval question, and I haven't presented this, but the VSD has in the past looked at different intervals of 0 to 7 and 0 to 21 days. And I think what we've noticed is when you look at the risks or the rates in these 2 intervals, most of it is concentrated in the 0 to 7 days. So I think we are pretty confident that these vaccine-associated cases tend to cluster fairly closely after vaccination. And then with respect to your question of the cases and our follow-up on these cases after primary series Moderna vaccination, there are reports of death where there was histopathologic or clinical evidence of myocarditis following vaccination, and we have reviewed those cases. But when we review those cases and do a thorough review and work with our partners out in the States, we don't have any cases where we've been able to definitively conclude that the vaccine was in the causal pathway for the death. And actually, if you can flip to I think it's the last extra slide. Can you go to the last extra slide, please? I'm sorry, the second to the last extra slide. This may give you some specifics on this, and this includes all deaths, not just Moderna deaths. It's all deaths death reports to VAERS among persons under 30 with myocarditis after primary series mRNA vaccination. So I just kind of want to walk you through this because I think this visual is probably going to best address your question and your concerns. So there were 13 cases with concern for myocarditis, 13 death reports with concern for myocarditis that we have identified through January. Of these, 3 did not have adequate information available to assess. You know, in some cases there was a death, but with clinical evidence of myocarditis, but there was not an autopsy or the conducted or additional tests, which really did not allow us to assess these cases. That left us with 10 with available information. Of those 10, 2 are ongoing. So we have 8 where we've completed the evaluation. Of those 8, 3 were not myocarditis. 5 were myocarditis. And of those 5, all 5 had potential infectious causes identified, so other potential etiologies identified, and that left us with no cases where there was no other cause identified. Does that help?
Very much. Thank you.
Thank you. Next, we'll move to Dr. Pablo Sanchez, and then we'll move to our next speaker.
Thank you, and thank you, Dr. Shimabukuro. Just a couple of things. In your slide 16, when you talk about the 923,000, those are administered to age 18 to 39 years? Or is that the total?
Yeah, could you go up to the graph, the actual graph of the I'm sorry, slide 14. Could you go to slide 14, please? So yes, so these are the numbers that you were looking at in a figure. So these are COVID vaccine doses administered to persons 18 to 39 years. So this is the study population that we're looking at.
Okay, great. Thank you. And then another question. Again, I wanted to go back to the age and, you know, looking at it beyond 7 days, only because in the study, in the randomized study, the cases of pericarditis, there was no myocarditis, occurred in older, you know, more removed from the vaccine administration. So, you know, it'd be important also to know that those may not have been related to the vaccine administration, but if they occurred late, I think they were like 69 days, 43 days after those 2. And so I think it's important to also look at it beyond to at least see if there was no relationship. But and then my last comment is just that there was also an increase in males in 40 to 49 years, if I remember. And so that's not part of your analysis currently.
Yes. Could you go to slide 5?
Yeah. So 40 to 49 after dose 2, there was a slight increase, not a sign.
Yes. So you're correct. In the VAERS analysis, we did notice an increased reporting rate above what we would expect based on baseline in males in the 40 to 49-year-old age group after dose 2. That age group, we are monitoring for myocarditis in that age group in the vaccine safety data link. We monitor in all ages, in fact. When we did our analysis, it was restricted to that 18 to 39-year-old age group, at least for Moderna, and that's largely a numbers issue. The more you extend, the less numbers you have relative to doses administered. So that was largely based on the number of cases.
Thank you.
Thank you. We will move on to Dr. Ian Kreselek to update us on myocarditis outcomes, known as the MOVING study. So Dr. Kreselek.
Thank you. So I'll be updating you on myocarditis outcomes following mRNA COVID-19 vaccination. Next slide, please. This is just a disclaimer. The conclusions in this report don't necessarily represent the official position of the CDC, and any mention of a product or name does not constitute endorsement. Next slide, please. So looking at the occurrence of myocarditis following mRNA COVID-19 vaccination, we observe evidence from safety monitoring systems in multiple countries that supports the finding of an increase but small risk of myocarditis following mRNA COVID-19 vaccination. And this risk of vaccine-associated myocarditis appears highest in adolescents and young adults, increased risk in males compared to females, and an increased risk following dose 2 compared to dose 1. Typically, onset is within a few days of vaccination, with most presenting within a week following vaccination. The severity of cases varies. Most who presented to medical care have responded well to medications and rest, and assessment of myocarditis health effects after COVID-19 vaccination are in progress. Next slide, please. So CDC initiated enhanced surveillance for myocarditis outcomes after mRNA COVID-19 vaccination in Vaccine Adverse Event Reporting System, or VAERS, case reports. The purpose of this enhanced surveillance was to assess functional status and clinical outcomes among individuals reported to have developed myocarditis after receiving mRNA COVID-19 vaccination. And this enhanced surveillance involved a 2-component survey conducted at least 90 days after the onset of myocarditis symptoms. The first part was a patient survey focused on 12 to 29 years of age to ascertain functional status, clinical symptoms, quality of life measures, and the need for medication or other medical treatment. The second part was a healthcare provider survey, which, for example, involved cardiologists. And the objective was to gather data on cardiac health and functional status. The timeline for the data collection was approximately between August of last year and January 2022. Next slide, please. So first, I'll present some preliminary data from surveys of patients at least 90 days post-myocarditis diagnosis. Next slide, please. So our outreach was focusing on myocarditis patients 12 to 29 years of age. As of November 2021, VAERS had received approximately 989 reports of myocarditis or myopericarditis after COVID-19 vaccination that met the CDC case definition. Of these, approximately 850 patients aged 12 to 29 years had reached 90 days post-myocarditis diagnosis. Of the approximately 850 patients 90 days post-diagnosis, 81% had a phone number listed in which we could contact them. Of those 648 who were called, 56% completed the survey, 42% were unreachable, and 3% declined to participate. For the 360 patients interviewed, the time from myocarditis onset to interview was 143 days, with an interquartile range of 131 to 162 days. Next slide, please. So if we look at some of the demographic characteristics of these myocarditis patients, we see most patients diagnosed with myocarditis were young males. If we look at the graph below, we see age group and sex on the x-axis, and we see male patients in the dark blue and female patients in the light green. Median patient age was 18 years, with an interquartile range of 15 to 22 years. Of the 360 patients 90 days post-myocarditis diagnosis, 86% or 308 were males. Next slide, please. So here we have the race and ethnicity of myocarditis patients. Most patients were white, non-Hispanic. Hispanic of any race made up 20% of patients, Asian non-Hispanic 5%, Black non-Hispanic and multiracial non-Hispanic 4% each, other non-Hispanic 3%, and American Indian or Alaskan Native non-Hispanic less than 1%. Next slide, please. So prior to the patient's myocarditis diagnosis, most patients received 2 doses of the COVID-19 vaccine. 87% reported receiving 2 doses. Of those who received 2 doses, 98% reported receiving both doses before they were diagnosed with myocarditis, and 9% had evidence of COVID-19 with a positive COVID-19 test before their myocarditis diagnosis. Next slide, please. So if we look at some of the self-reported previous medical history among these patients with myocarditis after mRNA COVID-19 vaccination, see that 17% reported having any condition, 3% reported having an arrhythmia, 2% each had a congenital heart disease or a history of myocarditis, and then less than 1% each had Kawasaki disease or had a history of previous heart failure. 9% had a history of asthma, 2% had an autoimmune disorder, 1% each had genetic or chromosomal condition or were immunosuppressed, and then less than 1% each had a history of leukemia or had type 1 diabetes. Next slide, please. And most patients with myocarditis after receiving COVID-19 vaccination reported being hospitalized at the time of their diagnosis. So 92% were hospitalized, 4% were readmitted following myocarditis. Of these that were readmitted, 62% were readmitted because of a concern with the heart, and 20% were prescribed medication for their heart at their last appointment with their provider. Next slide, please. So if we look at absenteeism related to missed school or work within the 2 weeks prior to the date of the interview reported among patients, see that 46 or 8% reported missing school. Of these, 37% believed it was due to their myocarditis, and 5% missed work. Of these, 37% believed it was due to their myocarditis. Next slide, please. So here we have the self-reported symptoms within 2 weeks prior to the date of the interview among myocarditis patients. This is looking at 4 main symptom types. So from top to bottom, we have chest pain, shortness of breath, palpitations, and fatigue. We have those experiencing the symptoms in yellow and those not in dark purple. We see about a third were experiencing chest pain, and about a quarter each were experiencing shortness of breath, palpitations, and fatigue. If we look at any symptom reported across all patients, we see about half, or 49%, reported experiencing at least one of these symptoms in the prior 2 weeks to the date of the interview. Next slide, please. So here we have the EuroQol 5-dimension, 5-level severity measurement of health status among patients who develop myocarditis after vaccination. This is an assessment of the patient's quality of life. We have on the x-axis below in this graphic, we have the quality of life measure or dimensions that we're looking at. We have the ability to do self-care, the ability to walk or mobility. We have the ability to perform usual activities, whether they're experiencing any pain or discomfort, and whether they're experiencing any anxiousness or depression. The 5-level of severity measurements can range from experiencing no problems to experiencing extreme problems. In this case, we've categorized those into experiencing any problems, shown in light green, and experiencing no problems, shown in the darker colored bars. We can see that most patients reported experiencing no problems with self-care, mobility, or usual activities. Most did not experience any pain or discomfort. However, when we look at anxiousness or depression, almost half were experiencing anxiousness or depression. Next slide, please. So next I'll report on some of the preliminary data from completed cardiologist or other healthcare provider surveys. Next slide, please. So our outreach to cardiologists or other healthcare providers involved interviews. So of the 360 patients that were interviewed, 346 listed contact information for a cardiologist or other healthcare provider. Of those 346 that we were provided contact with, 229 completed a survey. An additional 151 providers completed surveys they had submitted for multiple patients in VAERS or we were provided contact information via the VAERS report. We were unable to reach 268 providers. In total, 380 providers completed the survey with a median of 191 days, with an interquartile range of 170 to 216 days from patient myocarditis onset to the date of the provider survey. Next slide, please. So we found that the proportion of myocarditis patients cleared for physical activity by their cardiologist or healthcare provider has increased. So at the time of myocarditis diagnosis, 83% of patients had restrictions on their physical activity, while at the time of the provider survey, at least 90 days post-diagnosis, only 39% had restrictions on physical activity. Next slide, please. So based on the cardiologist or other healthcare provider assessment, most patients appeared to have fully or probably fully recovered from their myocarditis. If we look at the graphic below, we have the 4 categories of recovery, either the same cardiac status at the initial myocarditis diagnosis, the patient has improved but not fully recovered, the patient has probably fully recovered, but the provider is awaiting some additional information, and the patient has fully recovered. So in total, 81% of cardiologists or healthcare providers indicated the patient was fully or probably recovered, with more than 90% showing some improvement. Next slide, please. So here we have the proportion of myocarditis patients deemed to be fully or probably fully recovered by their healthcare provider as a function of time. So we have the cumulative proportion of patients recovered. On the x-axis, we have time from myocarditis onset to most recent provider appointment shown in weeks. So at about week 38, we see that about 80% of patients were fully or probably fully recovered. Next slide, please. So here we're showing results of the most recent cardiac function test or biomarker test, looking at 6 specific tests. So we have troponin, cardiac MRI, echocardiogram, electrocardiogram, exercise stress test, and ambulatory rhythm monitoring. We have a normal or baseline test results are shown in dark blue, and abnormal or elevated are shown in light blue. Overall, most of the recent cardiac function tests were normal, with the exception of cardiac MRIs, which most were abnormal, as that's the most recent cardiac function test. Next slide, please. So here we have the abnormal findings from those most recent cardiac function tests. On the x-axis below, we have cardiac MRI, electrocardiogram, exercise stress test, and ambulatory rhythm monitoring. Results for all patients are shown in dark blue, and in light blue we have patients fully or probably fully recovered. So for cardiac MRI, we see the most common abnormal finding in cardiac MRI was late gadolinium enhancement. Electrocardiogram, the most common abnormal finding was a T-wave abnormality. Exercise stress test, there was some other cardiac concern identified, and during ambulatory rhythm monitoring, the most common abnormality found was an arrhythmia. Next slide, please. So here we have overlap of abnormal findings among the most recent cardiac function tests. So, for example, looking at the first column, we have MRI, and then we have troponin at the top. We see that 51% of abnormal MRI findings also had an elevated troponin. 26% of abnormal MRIs also had an abnormal EKG. 3% of abnormal MRIs also had an abnormal ambulatory rhythm monitoring finding, and then 1% of abnormal MRIs also had an abnormal exercise stress test finding. Looking at echocardiogram across the bottom row, we see that a low percentage of abnormal findings for the most part in the overlap of abnormal echocardiogram findings and abnormal findings among these other tests. Next slide, please. So here we have a comparison of cardiac function tests at the time of diagnosis and at the time of follow-up. So there are two different time periods here: at the time of diagnosis on the left-hand side and at the time of follow-up on the right-hand side. We're looking at three tests here. We have cardiac MRI, echocardiogram, and troponin with three possible outcomes. And we have a normal test, abnormal test, or the result was not performed, or the test was not performed, or the result was not available. So if we go to the next slide, please, we can focus on cardiac MRI. So again, we have at the time of initial diagnosis on the left-hand side, and at the time of follow-up on the right-hand side. We see for the most part that many patients did not have an initial cardiac MRI performed, and we see those with an initial cardiac MRI that was abnormal also did not have a follow-up cardiac MRI. 79 patients had a follow-up cardiac MRI that was abnormal. Next slide, please. Here we're focusing on echocardiogram. Again, time of initial diagnosis on the left-hand side and time of follow-up on the right-hand side. Most patients had an initial echocardiogram that was normal and a follow-up echocardiogram that's normal. There were 17 patients that had a follow-up echocardiogram that was abnormal. Next slide, please. Here we're looking at troponin. We see that, again, most patients that had an initial troponin that was elevated didn't receive a follow-up test, or the test was not available. And on follow-up, 20 patients had elevated troponin level. Next slide, please. So here we're looking at the cardiac assessment and symptoms among patients deemed to be recovered and not recovered in their myocarditis. So we have two different groups. The top matrix there, we have patients deemed not recovered, and we have patients deemed fully or probably fully recovered at the bottom. This is looking at a subset of some symptoms and tests and healthcare provider assessment. So we're looking at shortness of breath, chest pain, daily medication, physical activity, troponin, echocardiogram, EKG, and cardiac MRI. Each row represents one of those tests or symptoms. Each column represents an individual patient. Normal or baseline function or absence of symptoms is shown in blue. Abnormal function or presence of symptoms is shown in red, and unknown or the test result not available shown in white. So if we go to the next slide, please. You can see among those patients deemed to be fully or probably fully recovered, there are a few patients that have a complete normal baseline function or absence of symptoms across this subset of tests and clinical assessments. Some also had normal baseline function, but were missing cardiac MRI results. Next slide, please. And even among patients deemed not recovered, we see that some of them had normal or baseline function or absence of symptoms across all this subset of tests and clinical assessments, which suggests that there's some heterogeneity in the way patients are deemed recovered, and there's likely a lot of healthcare provider judgment in the assessment of these patients. Next slide, please. So in summary, at least 90 days after myocarditis diagnosis, most patients reported no impact on their quality of life, and most did not report missing school or work. A few were readmitted to the hospital. Most healthcare providers indicated the patient probably or fully recovered. However, there did not appear to be a single test that was indicative of recovery. And to our knowledge, there were no vaccine-associated myocarditis deaths in this group of patients that we interviewed. Currently, there are ongoing efforts to continue patient follow-up and contact myocarditis patients who are not yet recovered at the time of the survey. There are additional surveys are being modified for children aged 5 to 11 and follow-up to start in February 2022. Next slide, please. I'd just like to acknowledge all the individuals and teams that made this analysis possible. Next slide, please. Thank you.
Thank you very much. I'd like to open up this presentation for clarifying questions, and then would want to remind our committee members that we have Dr. Talbot, who will also provide a summary and assessment. Dr. Paling.
Yes, Dr. Kreslek, thank you very much for this presentation. I really appreciate the additional data and follow-up from the patients and the providers to understand what's going on. I wanted to ask a clarifying question, and you focused in the VAERS database on 12 to 29 years of age. Knowing that you went down to 12 years of age, I'm assuming this data is for Pfizer or Moderna vaccine, and that's why some of these numbers look different than what Dr. Shimabukuro presented earlier. Is that correct? Thank you.
That is correct. It's both the Pfizer and Moderna vaccine.
Thank you. Ms. Bata.
Thank you. And thank you, Dr. Kreslek. I had the same question about this data being any mRNA vaccine, but also in your survey, was there any assessment of social or behavioral impact and whether those types of impact from the myocarditis have been resolving? When I'm looking on slide 16, or excuse me, slide 19, it looks like the recovery, 50% recovery happened shortly after 16 weeks. And so that's a long time for a person to maybe be with limited activity or may not be able to work or anything like that. So I just want to make sure that we're not just looking at the physiology, but the whole impact of a person who ended up with myocarditis after getting vaccinated. Thank you.
Certainly, and we attempted to get at that by assessing the quality of life measures. So we did administer the Euroqual 5-dimension, 5-level severity measurement of health status, which did look at some measures, including anxiousness or depression, as well as being able to perform usual activities. And while most appeared to be able to perform usual activities, we did find that about half were experiencing some level of anxiousness or depression, which could have been extreme.
Thank you.
So there was probably some impact because of that.
Thank you.
Thank you. And actually, Dr. Cotton, if you'll indulge me for a moment, I just wanted to follow up on this particular comment, which is, well, first, I wanted to thank the teams that have been involved in this particular study. We recognize that the study was going above and beyond in order to respond to the pandemic and ensure that the committee and the public had the information it needed about the long-term follow-up of these cases. Second, I just wanted to highlight that because we're doing long-term follow-up on cases only in order to ensure we have these long-term outcomes, we also don't have any controls in this long-term follow-up study. So the medical information from the long-term cardiology follow-up, I think, continues to reflect disease that is mild and consistent with what we've seen previously. But what I found remarkable is, and telling, is that some of the patient and family-centered measures, such as the Euroqual measures that you described, as well as some of the return to activity measures, that we are seeing there is a substantial impact on individuals, but we have to acknowledge that these data likely reflect the experience that many of us having living through this pandemic, whether or not we're infected or vaccinated. So I'm actually hopeful that other ongoing studies supported by the CDC, by NIH, and by the FDA will continue to shed light on the impact of this pandemic on our children and young adults. With that, I will actually turn it over to Dr. Cotton.
Thank you, Dr. Lee. I wanted to emphasize your point, which is this data, although clearly very robust and very interesting and helpful for us to look at, it's really hard to fully understand what this means in isolation. And most of the time in the medical world, we don't look at data without a control population or other populations to compare to. So I would encourage, obviously, regular people aren't getting cardiac MRIs and all of that, of course. But I would consider doing work where you could look at people who had myocarditis from true infection, which has been devastating and has a much bigger impact, I think, than these vaccine-related myocarditis. And then I would also, for the epidemiology, it would be helpful to have controlled populations. And I would just encourage further speakers on this topic or people doing work to make sure that they have good comparison populations. I think that there's a little bit of danger in focusing on vaccine and myocarditis when the elephant in the room is really true disease and true infection from COVID-19 and the potentially devastating, even life-threatening myocarditis we see in that setting. Thank you.
Thank you, Dr. Cotton. And we'll move on to Dr. Brooks.
Yes, very briefly. Can you go to that almost next to last slide where you had the fully recovered versus not fully recovered, the blue and the red? And this kind of goes along, thank you, with exactly what the last two speakers said. If you look at the top four, shortness of breath, chest pain, daily medication, and physical activity, those are the ones that a patient would feel. The bottom four are a doctor finding. And you'll note that on the fully recovered, once you get toward the end, the top four are all clear, generally speaking. Even before, you noted all of them, but the troponin was elevated, some. But these patients on the quality of life relative to physical findings, chest pain, shortness of breath, and that physical activity, they recovered. So I think that's reassuring. And just one other thing in general for the public, I just think it's so important that we are doing this dissection of the myocarditis. I think that your data, along with all the other data we've seen, gives you a full picture. We're going to hear one more, at least one more. So I just want to point that out and then say thank you for your presentation.
Thank you, Dr. Brooks, and thank you, Dr. Koselleck. I think we will move on to Dr. Kip Talbot to provide a summary assessment of the vaccine safety technical work group's thoughts. So, Dr. Talbot.
Thank you. All right, so this is the COVID-19 Vaccine Safety Technical Work Group, otherwise known as VAST, assessment of the data that was just presented and some other that has been reviewed. Next slide. So the objectives of VAST are to review, evaluate, and interpret post-authorization approval COVID-19 vaccination safety data. It serves as a central hub for technical subject matter expertise from federal agencies conducting post-authorization and approval safety monitoring. There's advice on analysis, interpretation, and presentation of vaccine safety data, and provide updates to the ACIP COVID-19 Vaccines Work Group and the entire ACIP on COVID-19 vaccine safety. Next slide. VAST continues to review vaccination data, and this is done with the U.S. safety monitoring systems, including the Vaccine Adverse Events Reporting System, VAERS, which is done with collaboration of the FDA and CDC, the Vaccine Safety Data Link, the FDA BEST system, the Department of Veterans Affairs, Indian Health Service, and the Department of Defense. We continue to work with international partners, including the Public Health Agency of Canada and the Global Advisory Committee on Vaccine Safety. Special evaluations, including myocarditis case follow-up studies, as was just seen, have also been reviewed. Next slide. So from December 21st to today, VAST has had 45 independent meetings to review vaccine safety data. There have been 12 joint meetings with ACIP COVID-19 Vaccines Work Group, and there have been 15 ACIP meeting presentations or reports with VAST assessments. Next slide. VAST review of the Moderna COVID-19 vaccine post-authorization data includes CDC safety monitoring systems, as mentioned previously, including VAERS, VSAFE, and VSD, other U.S. monitoring systems, and international partners. Next slide. Previously, we mentioned anaphylaxis following messenger RNA COVID-19 vaccination. Anaphylaxis following messenger RNA COVID-19 vaccines was identified in December of 2020. Safety data and VAST assessments were presented in January and March 2021. CDC and FDA recommended risk mitigation strategies, including screening for risk prior to vaccination, monitoring for symptoms post-vaccination, early recognition and management of anaphylaxis on site, provider and patient education by CDC and partners. Anaphylaxis following vaccination was reviewed again in August 2021 for the Pfizer BLA. There have been no substantial change in benefit-risk balance with risk mitigation strategies. Next slide. So myocarditis. Myocarditis following messenger RNA COVID-19 vaccination was identified in May 2021. CDC issued clinical guidance for myocarditis, pericarditis following messenger RNA vaccines in May. Data was presented to the Vaccines and Related Biologics Products Advisory Committee, otherwise known as VRBPAC, on June 10th. Data and VAST assessment presented at ACIP meetings on June 23rd, and an MMWR was published. EUA fact sheets were revised with warning added June 25th. FDA approval of the Pfizer-BioNTech COVID-19 vaccine on August 23rd included information on myocarditis, pericarditis in the package insert. The FDA approval of Moderna COVID-19 vaccine, January 31st, also includes information on myocarditis, pericarditis in the package insert. Next slide. This is data from VAERS, which I will remind you is a collaboration with the CDC and FDA. These are reporting rates per 1 million doses administered of myocarditis in the window of 0 to 7 days after Moderna vaccination. And you'll notice the highlighted areas in green show that reporting rates exceed background incidence in males after dose 1 for males 18 to 39, and especially after dose 2 in males 18 to 49 years of age. In females, we see reporting rates exceeding background incidence after dose 2 in those 18 to 29 years of age. Next slide. You've seen this earlier this morning, and it's just a reminder that the risk interval is from 0 to 7 days, and mostly among 18 to 39-year-olds, and especially males following the second dose. Next slide. So myocarditis outcomes following messenger RNA COVID vaccination. So in VAERS, for all messenger RNA vaccines, we see 359 reports meeting case definition within the window in those adults over 18 years of age. 94% were hospitalized, and almost 70% have recovered from symptoms at time of the VAERS report. Follow-up surveys of myocarditis cases in VAERS, 360 patients interviewed with greater than 90 days of follow-up, 92% hospitalized, and 380 providers contacted. 81% indicated patient fully or probably fully recovered. From the Vaccine Safety Data Link, or VSD, comes information for Moderna vaccination alone. 38 chart confirmed cases among individuals 18 to 39 years of age. 79% were hospitalized, 75% for 2 days or less, and 100% have been discharged to home. Next slide. So the VAST assessment is as follows. Data available to date show association of myocarditis with Moderna messenger RNA COVID-19 vaccination in adolescents and young adults. Risk is low overall, but highest in adolescent and young adult males, especially following dose 2. Data continue to show that most cases of post-COVID-19 vaccination myocarditis appear clinically mild. More data are being accumulated and analyzed to further define myocarditis clinical course and risk. And at the present time, data do not suggest new safety concerns regarding Moderna vaccination among persons 18 years or older, beyond those that were previously identified and discussed. Next slide. Our work is not finished and we continue to work. We continue to review data on myocarditis from national safety monitoring systems and manufacturer post-marketing requirements. Continue to review real-time monitoring of vaccine safety as vaccination efforts expand to younger age groups, booster doses, and new vaccines. We continue to collaborate across U.S. federal agencies, and we continue to collaborate with global vaccine safety colleagues on key issues that impact benefit risk. And we continue to provide updates to the ACIP COVID-19 vaccines work group and ACIP at future meetings. Next slide. I really have a shout out for all of these people. 45 meetings is a lot of meetings, and everyone shows up every time ready to work. And I especially appreciate my co-chair, Dr. Hopkins, who's a representative from NVAC, and our CDC co-leads, Lori Markowitz and Melinda Wharton. Thank you so much.
Thank you, Dr. Talbot. I'm going to pause and ask if there's any questions folks have for Dr. Talbot, Shimabukuro, or Koselik. Don't see any hands raised. We'll open it up to our liaison members. Okay, Dr. Daly.
Well, Dr. Talbot, as you went through your presentation, I was just struck by how you balanced what we've learned so far with the idea that we still continue to have work to do. And I just kind of want to reiterate that. And that work's going to extend across new indications, but it'll also extend across learning more about the outcomes for these individuals with vaccination-associated myocarditis. So I just appreciate you putting it in that longer-term, big picture context. So thank you.
Thank you, Dr. Daly. Okay, I don't see any additional hands raised. So I think with that, we will plan to close this session. And I want to thank all of our presenters for their excellent presentations. We will now recess, actually not as long as we had hoped, but we will plan to reconvene at 1 p.m. Eastern Time, which I believe is 10 a.m. Pacific Time. Thanks, everyone, and we'll talk soon. Thank you, everyone. It is now 1 p.m. Eastern Standard Time, and we will reconvene the meeting to begin the next session. We will start with Dr. Megan Wallace, who will be discussing the grade assessment on the Moderna COVID-19 vaccine. Dr. Wallace?
Thank you. Good afternoon. Next slide. The policy question under consideration is, should vaccination with Moderna COVID-19 vaccine be recommended for persons 18 years of age and older? Next. The components of the PICO question are shown on this slide. The population under consideration is persons ages 18 years and older. The intervention is 2 doses of the Moderna COVID-19 vaccine. The comparison is no vaccine. The work group identified the 6 outcomes listed here as the most important for the policy question. Next. The outcomes, importance, and data sources available for evaluation of these outcomes are summarized here. For benefits, 2 critical outcomes were selected: prevention of symptomatic laboratory-confirmed COVID-19 and prevention of hospitalization due to COVID-19. There were 2 important benefits selected: prevention of death due to COVID-19 and prevention of asymptomatic infection. The critical harm identified was serious adverse events overall. Additionally, specific harms that have been identified during real-world use were evaluated. An additional important harm, reactogenicity, was evaluated. For all outcomes, data from RCTs were evaluated. For all benefits, observational studies of vaccine effectiveness were evaluated. For serious adverse events, safety surveillance data were reviewed for specific outcomes. Next. To identify relevant randomized controlled trials, we relied on clinicaltrials.gov as the source. We included phase 1, 2, or 3 trials of Moderna COVID-19 vaccine that fit our PICO question. We sought out additional resources, including obtaining unpublished data from the vaccine manufacturer. To identify relevant vaccine effectiveness studies, we used an ongoing, publicly available systematic review conducted by the International Vaccine Access Center, or IVAC, and the World Health Organization, using studies identified through December 10th. From this database, we selected studies that provided vaccine effectiveness estimates for at least one of the benefits defined in our PICO question. Of note, studies that report on VE against any infection were not included, only studies that specifically evaluated VE against symptomatic or asymptomatic infection. We included only studies that had estimates of VE specifically for the Moderna COVID-19 vaccine and not estimates for mRNA vaccines as a group. We reviewed studies of general population and of special populations as long as they included persons aged at least 18 years. For observational data on vaccine safety, in consultation with VAST, we included data from safety surveillance systems that have been presented to ACIP. Next. This flow diagram shows the evidence retrieval for all records included in our evidence synthesis. 127 records were identified from the IVAC systematic review, and 7 were identified through other sources, including 5 records from clinical trials and 2 CDC safety surveillance systems. 38 full-text articles or other resources were assessed for eligibility, and 33 were included in the evidence synthesis. Next. A total of 26 records of observational studies were identified that met our inclusion criteria and addressed one or more of the PICO outcomes. We conducted a risk of bias assessment using the Newcastle-Ottawa scale, which assigns up to 9 points based on specific criteria related to selection, comparability, and assessment of outcome or ascertainment of exposure. Studies with Newcastle-Ottawa scores less than 7 were considered to have serious study limitations. Next. For each outcome, we assess the body of evidence for suitability for pooling. Given that we are working with a fluid evidence base that includes preprints that have not been peer-reviewed, we excluded estimates with serious limitations from the pooled estimates used for grade. If multiple studies were conducted in the same population, the most representative study was selected. Meta-analyses were conducted using the remaining studies. Initial estimates were evaluated for heterogeneity using I-squared. Sensitivity analyses were conducted to assess the influence of study characteristics. The pooled estimates were developed to summarize the estimates across several studies succinctly for grade and describe the best available real-world data for this policy question at this time. However, we acknowledge that the included studies represent different populations and times, and that the science in this area is developing quickly. For this grade analysis, we did not aim to parse out effects of time since vaccination and circulating variants in the VE studies. Next. The grade evidence type assesses the certainty of estimates from the available data. Initial evidence type is determined by the study design. A body of evidence from randomized controlled trials starts with an initial evidence type of 1, indicating high certainty. A body of evidence from observational studies starts with an evidence type of 3, indicating low certainty. The evidence type can then be downgraded due to risk of bias, inconsistency, indirectness, or imprecision, and other considerations could downgrade or upgrade the evidence type. The final evidence type may range from type 1 or high certainty, which indicates we are very confident the true effect lies close to that of the estimate, to type 4, indicating very low certainty, meaning we have little confidence in the effect estimate. The evidence type is not measuring the quality of individual studies, but how much certainty we have in the quantitative estimates of effect across each outcome. Next. Now I will review evidence of benefits. For each outcome, I will first review the data from randomized trials, then review the data from observational studies, and then provide the grade assessment for both. Next. For the critical outcome of symptomatic COVID-19, one randomized study provided data. This was the Moderna Phase 3 RCT, which was conducted in the United States and enrolled over 30,000 participants. The data were published and additional data were obtained directly from the sponsor. We used data through the unblinding date with a data cutoff date of May 4th, 2021. Unblinded safety follow-up continues in trial participants. To consistently apply grade in a rapidly evolving pandemic, we considered the data for benefits in the context of the pandemic during the study time. Next. Using the available efficacy population for all persons ages 18 years and older, there were 55 cases among 14,287 persons in the vaccine arm, and 744 cases among 14,164 persons in the placebo arm, which resulted in a vaccine efficacy estimate of 92.7% and a 95% confidence interval of 90.4% to 94.4%. This is the primary outcome of the study and the outcome used for grade. Next. Vaccine efficacy was also over 90% in a number of key subgroups, including those ages 65 and older, 75 and older, those at risk due to the presence of a comorbidity, those ages 65 years and older and at risk, and those with evidence of prior infection. Next. This table shows vaccine efficacy by timing. VE remained above 90% through unblinding. Next. Now moving on to the observational studies for symptomatic lab-confirmed COVID-19. This slide shows a brief summary of the 14 VE studies reviewed that evaluated this outcome. The most common study design was test-negative design, followed by retrospective and prospective cohort studies. Study locations were predominantly in North America. The preprint studies captured a more recent time period than the peer-reviewed studies. Among these 14 studies, 11 were included in the final pooled analysis for this outcome. Next. This forest plot shows the VE estimates from the 11 studies that were pooled. The pooled VE estimate from observational studies for the outcome of symptomatic laboratory-confirmed COVID-19 was 89.2%. Next. For the grade assessment for the outcome of symptomatic lab-confirmed COVID-19, we evaluated data from one randomized control trial for which the evidence type started at 1. The relative risk of 0.07 and tight 95% confidence interval strongly favored vaccination, and there were no serious concerns in the certainty estimate. The final evidence type was type 1, or high certainty, for this critical outcome. We evaluated 11 observational studies for this outcome. Recall that the evidence type starts at 3 or low for observational studies. The relative risk of 0.11 strongly favored vaccination, with a 95% confidence interval of 0.06 to 0.18. There were no serious concerns in the certainty assessment, and certainty increased due to strong association. For the observational studies, the final certainty was type 2 or moderate. Next. The second outcome for consideration was hospitalization for COVID-19. The protocol included a definition of severe COVID-19 with criteria shown on the slide, but this did not necessarily require hospitalization. We have obtained data on hospitalization due to COVID-19 from the sponsor as an ad hoc analysis. Next. This slide shows the two VE estimates from the randomized control trial. The first row shows the vaccine efficacy against severe COVID-19, a secondary endpoint defined in the phase 3 protocol, which was 98.1%. The second row shows VE against severe COVID-19 requiring hospitalization, which was our PICO outcome and the outcome used for grade. The VE estimate was 95.9%. Next. The 19 observational studies that evaluated VE against hospitalization due to COVID-19 are summarized here. The most common study design was test-negative design, and study locations were predominantly in North America. Among the 19 observational studies, which provided 20 VE estimates, 14 studies providing 15 estimates were included in the final pooled analysis. Next. For the outcome of hospitalization due to COVID-19, this forest plot shows the 15 VE estimates from the observational studies included in the meta-analysis. The pooled VE estimate from these studies was 94.8%. Next. For the grade assessment for this outcome, hospitalization due to COVID-19, we evaluated one RCT for which the evidence type started at 1. The relative risk of 0.04 strongly favored vaccination, but there were serious concerns of imprecision due to the small number of events observed from a single RCT. The final certainty estimate for hospitalization for COVID-19 based on RCT data was type 2 or moderate certainty. We evaluated 14 observational studies which provided 15 VE estimates for this outcome for a pooled relative risk of 0.05. There were no serious concerns in certainty assessment, and the certainty was increased due to a strong association. The final certainty estimate based on the observational data was type 2 or moderate. Next. The next outcome was death due to COVID-19. This was a secondary efficacy endpoint in the trial protocol, defined as any participant who died during the study with a cause directly attributed to a complication of COVID-19. Next. There were a total of 3 deaths due to COVID-19 among trial participants, all among placebo recipients. The available data indicates a VE of 100%. Next. 5 observational studies provided VE estimates for the outcome of death due to COVID-19. These were all cohort studies with study locations predominantly in North America. Next. This forest plot shows the 5 VE estimates from observational studies for the outcome of death due to COVID-19. The pooled VE estimate from these studies was 93.8%. Next. For the grade assessment for the outcome of death due to COVID-19, we evaluated one RCT. The relative risk of 0.17 favored vaccination, but the very wide 95% confidence interval did not rule out harms, leading to very serious concern for imprecision due to the small number of events observed in a single RCT. The final evidence type was type 3 or low certainty. The body of evidence from observational studies started with an evidence type of 3. There were no serious concerns in the certainty assessment. In light of the strong association, the certainty was raised 1 level to type 2 or moderate certainty. Next. The next outcome of interest was asymptomatic SARS-CoV-2 infection, which was a secondary endpoint in the phase 3 RCT. Asymptomatic SARS-CoV-2 infection was defined as having a negative SARS-CoV-2 status and both negative RT-PCR and negative binding antibody levels against SARS-CoV-2 at baseline prior to dose 1, and positive RT-PCR at the participant decision visit or seroconversion due to infection assessed by binding antibody levels against SARS-CoV-2 at day 57, 28 days after dose 2, and an absence of COVID-19 symptoms, including both symptoms for the primary endpoint of COVID-19 and the CDC definition of COVID-19. Next. Using the per protocol population for all persons ages 18 years and older, the VE for asymptomatic infection was 57.4, with a confidence interval from 50.1 to 63.6. Next. The 3 observational studies that examined VE against asymptomatic SARS-CoV-2 infection and met our inclusion criteria are summarized here. All were peer-reviewed and 2 were test-negative study design. Our most recent data are from September. Next. The VE estimates from the 3 studies are shown here. Note that there is substantial heterogeneity in the effect estimates. The pooled VE from these studies was 69.8%. Next. In the grade assessment of the outcome of asymptomatic infection, one RCT provided data. The relative risk of 0.43 favored vaccination, and there were no serious concerns in the certainty assessment. The final evidence type was 1 or high certainty. We evaluated 3 observational studies that had a pooled relative risk of 0.3. There was serious concern for inconsistency because the magnitude of relative risk from the 3 studies in the body of evidence varied widely. The final evidence type was type 4, or very low certainty. Next, I'll share data on grade for harms. Next. 4 randomized studies provided data on harms. These included the phase 3 trial, the phase 2 trial, and 2 published articles on the phase 1 trials, which did not have an unvaccinated comparator. Next. The phase 3 study included data on persons ages 18 years and older in the United States. The data evaluated had a final analysis cutoff date of May 4th and consisted of roughly 30,000 participants. Next. The phase 2 dose confirmation RCT enrolled healthy adults ages 18 years and older in the United States. We evaluated data on the 200 participants that received the 100 microgram dose and the 200 participants that received placebo. The primary outcomes for the phase 2 trial were safety, including reactogenicity and serious adverse events. Next. Here are the raw data on the critical outcomes serious adverse events from the 2 randomized studies. From the phase 2 trial, there were no serious adverse events in either treatment group. In the phase 3 trial, SAEs were balanced across treatment groups, with 1.8% of vaccine recipients and 1.9% of placebo recipients reporting an SAE. 12 participants reported 15 SAEs, which were deemed by blinded investigators to be related to vaccination. Next. We also assess specific serious adverse events that have been identified in safety surveillance during the period of the emergency use authorization, which have previously been described to ACIP. A rapid cycle analysis from Vaccine Safety Data Link evaluated chart-reviewed cases of myocarditis occurring among persons aged 18 to 39 years following dose 2. As shown in this table, based on events occurring in a 7-day risk interval after vaccination versus a comparison interval in vaccinated individuals, the adjusted rate ratio was 18.75. Next. Data from the National Vaccine Adverse Event Reporting System, or VAERS, showed an elevated ratio of observed to expected chart-confirmed myocarditis cases in the 7-day interval following vaccination among females ages 18 to 29 years and among males ages 18 to 49 years, with higher observed to expected ratios in males than females. Although VAERS data are subject to the limitations of a passive surveillance system, the elevated risk of myocarditis following Moderna vaccination is consistent with that observed in VSD. Next. Regarding anaphylaxis, a rapid cycle analysis of data from VSD evaluated chart-reviewed cases of anaphylaxis among all vaccinated persons aged 18 years and older. Based on events occurring in a 0 to 1 day risk interval after vaccination, the estimated incidence of confirmed anaphylaxis was 5.1 per million doses. Next. The grade assessment for serious adverse events was based on 2 RCTs. The pooled relative risk indicated a balance of serious adverse events between vaccinated and placebo groups, with a relative risk of 0.92 and a 95% confidence interval of 0.78 to 1.08. The certainty assessment was reduced 1 point due to serious concern of imprecision, because the confidence interval indicates that both reduced and increased risk of serious adverse events are possible. The final evidence type was type 2, or moderate certainty. The observational data concerning the specific serious adverse events of myocarditis and anaphylaxis included the description of the quantitative data shown on previous slides. We started with type 3 data from observational surveillance systems and did not decrease or increase the certainty. The final certainty was type 3, or low certainty. Next. For the outcome of severe reactogenicity, the phase 2 and 3 RCTs solicited events through electronic diaries for the 7 days following each dose. Both randomized studies used the same events and grading scales shown here. The local reactions solicited were injection site pain, redness, swelling, and axillary swelling and tenderness. The systemic events listed were fever, nausea and vomiting, headache, fatigue, chills, muscle pain, and joint pain. Next. In the phase 2 study, grade 3 or 4 reactions or systemic events were reported in 16% of persons in the vaccine arm and 3% of persons in the placebo arm. In the phase 3 study, grade 3 or 4 reactions were reported by 22.6% of persons in the vaccine arm and 4.5% of persons in the placebo arm. Next. Pooling the data from these two trials, the estimated relative risk for any grade 3 or 4 event was 5.03 with a 95% confidence interval from 4.65 to 5.45. There were no serious concerns in the certainty assessment. The final evidence type was type 1, or high certainty. Next. This table summarizes our grade assessment for the Moderna COVID-19 vaccine. In terms of benefits, the available data indicate that the vaccine is effective for preventing symptomatic COVID-19 with high evidence certainty. For hospitalization and death, the available evidence favors the intervention and certainty was moderate. For asymptomatic SARS-CoV-2 infection, the available data favors the intervention with high evidence certainty. In terms of harms, in the RCTs, SAEs were balanced between vaccine and placebo arms. In post-authorization safety monitoring, myocarditis and anaphylaxis were rare, but more common following vaccination. Serious adverse events had moderate evidence certainty. In terms of reactogenicity, severe reactions were more common in vaccinated persons, and 21.3% of vaccine recipients versus 4.5% of placebo recipients reported grade 3 or 4 reactions. The evidence type for reactogenicity was high. Next. There are important limitations that should be acknowledged. In this rapidly evolving pandemic, the available body of evidence often does not represent the most recent epidemiology, including the impact of a new dominant variant on VE. The evidence available for inclusion in this grade does not capture the impact of the Omicron variant on vaccine effectiveness. The VE estimates presented represent the best estimates within the context of the pandemic during the time of the study, but may not be representative of VE in different phases of the pandemic or with different circulating variants. The evidence available for inclusion in this grade is predominantly from the time periods in which Alpha and Delta were the dominant circulating variants. Next. In conclusion, the grade evaluation focuses on recommendations following licensure of the Moderna COVID-19 vaccine that has been in use for a year under an emergency use authorization. Evidence for benefits are supported by a body of evidence comprised of one large phase 3 randomized control trial and numerous observational studies conducted worldwide. The RCT evidence demonstrated efficacy for all beneficial outcomes, including the 2 critical outcomes, symptomatic disease and hospitalization. Efficacy data were further supported by a body of evidence from observational studies. Regarding harms, grade 3 reactions were more common in vaccine than placebo recipients. RCT evidence showed that serious adverse events occurred at a similar frequency in vaccine and placebo groups overall. However, 2 specific rare but serious adverse events have been associated with vaccination as identified through safety surveillance systems. Next. In closing, I would like to acknowledge the team that contributed to grade. Each of the people listed on this slide played a vital role in synthesizing the information that was presented today. Next. Thank you.
Thank you for your presentation. This presentation is now open for questions. I don't see any hands raised from the members. Are there any questions from our liaison members? Dr. Paling, thank you.
Okay, so Dr. Wallace, thank you for a beautiful presentation. I actually don't have any questions. I just wanted to say a very special thanks to the tremendous amount of work that was done in pulling this and how reassuring it is that the randomized controlled trials and the observational studies are showing the same pattern. So I just want to say a thank you to you and your team.
Thank you. And it was certainly a team effort. Thanks.
And thanks, Dr. Wallace. I think that goes for all of us with Dr. Paling's words. Dr. Daly.
Yeah, I was going to say something very, very similar, just that, you know, these data are all very important and you present it in such a clear and consistent way. And I'm sitting at my desk in Denver, but I would give you a standing ovation if I could. So again, thanks to you and your team for this, and we really appreciate it.
Perfect. I think with that, why don't we move on to the next presentation by Dr. Sarah Oliver. And just know that you can come back, and I know Dr. Wallace will probably still be in the room after Dr. Oliver's done. So we'll continue on with the ETR framework from the Moderna COVID-19 vaccine. Dr. Oliver.
Thank you very much. I can tell you we clapped for Dr. Wallace in the room. So, all right. Good afternoon. Next slide. So as a reminder, this is the policy question that we'll vote on later today. Should vaccination with the Moderna COVID-19 vaccine be recommended for persons 18 years of age and over? We presented this previously with the Pfizer BLA, but as a reminder, with the FDA authorization of an EUA, ACIP has made interim recommendations. Then, as the vaccine receives full FDA approval under the BLA, ACIP reviews the totality of the data available and votes to make a standard recommendation. Next slide. Then another reminder, for regulatory action, grade, the ETR framework, and the ACIP vote, we consider the Moderna COVID-19 vaccine compared to no vaccine. Next slide. Then this afternoon, we'll have additional questions for discussion focused on implementation, myocarditis, and intervals. During those discussions, we'll discuss data for both the Moderna COVID-19 vaccine and the Pfizer vaccine. Next slide. This is the PICO question we're using for the ETR framework. Next slide. And again, as a reminder, the ETR framework with each domain listed and the questions that will be addressed. Next slide. So first for the public health problem. Next slide. So this slide shows the trends in daily number of COVID-19 cases in the US. To date, there have been over 75 million cases reported to CDC. We recently experienced a substantial surge that peaked mid-January with a 7-day moving average of over 800,000 cases per day. Since mid-January, cases have been declining, and the current 7-day moving average is now just over 400,000 cases. Next slide. Next, we'll take a look at trends in daily number of COVID-19 deaths in the US. As of February 1st, there have been over 888,000 deaths due to COVID-19 reported in the US. Next slide. Then this slide illustrates the rates of COVID-19 cases by vaccination status. Unvaccinated people in all age groups had higher case rates than fully vaccinated people in the same age groups. Notably, in November, unvaccinated adults aged 18 years and over had 4 times greater risk of testing positive for COVID compared to fully vaccinated adults. Next slide. And then importantly, unvaccinated adults, the vaccines continue to provide substantial protection against severe disease and death. So unvaccinated adults, 18 years of age and over, had a 15 times greater risk of dying from COVID compared to fully vaccinated adults. Next slide. Then furthermore, people who were fully vaccinated and had received an additional or booster dose had an even further lower risk of testing positive and dying from COVID compared to people who were unvaccinated. But I'll highlight here that the largest gap is between those who are unvaccinated and those who are fully vaccinated. Next slide. This slide shows the weekly trends in COVID-associated hospitalization rates in the US. There's a reporting delay in recent weeks, but you can see that across all ages, hospitalizations have increased in recent weeks. Next slide. While COVID hospitalization rates have been increasing, it's important to evaluate the hospitalization rates by vaccination status. So this slide shows the rates of COVID-associated hospitalization by vaccination status in adults 18 to 49 years between January and December of 2021. In December, compared to fully vaccinated adults 18 to 49 years, the monthly rates of COVID-associated hospitalizations were 12 times higher in unvaccinated adults 18 to 49 years. Next slide. Additionally, compared to fully vaccinated adults 50 to 64 years of age, the monthly rates of COVID-associated hospitalizations were 18 times higher in unvaccinated adults in the same age range. Next slide. And then finally, in those adults 65 years of age and over, COVID-associated hospitalizations were 18 times higher in unvaccinated adults 65 and over compared to fully vaccinated adults in that same age range. Next slide. We know that those hospitalizations can take a toll on the healthcare system. So this slide shows ICU utilization by state. And as of February 3rd, over half of states were at 80% ICU capacity or greater. Next slide. I think we're all familiar with this at this point, but this graph shows that Omicron is now the dominant circulating SARS-CoV-2 variant in the United States, shown here in purple. Next slide. So next we'll take a look at the daily count of total doses administered and reported to CDC by date administered in the United States. So as of February 1st, the 7-day moving average for doses administered was over 464,000 per day. Next slide. But we do know that approximately 25% of people aged 18 and over are not fully vaccinated. Next slide. So now taking a look at COVID vaccine administration by vaccine type, over 540 million COVID vaccines have been administered in the US, and over 204 million of those were the Moderna COVID-19 vaccine. Next slide. Then we know that over 212 million people are fully vaccinated in the US, and over 74 million of those received the Moderna 2-dose series. Next slide. Then this slide shows the percent of COVID vaccination coverage by age and date administered. The highest coverage is among the oldest, with 95% of those 65 and over having received at least one dose. The lowest coverage is 75% with at least one dose among those 18 to 24 years of age. Next slide. Then as we focus on those fully vaccinated with Moderna by week and age group, again, we've seen similar patterns where more doses were administered earlier in the rollout and older adults received their vaccines earlier. Next slide. Then we know that those fully vaccinated varies by geographic location as well, as highlighted here in a map of the United States. Next slide. So in summary for the public health problem, the Omicron variant is the dominant circulating variant in the United States. In January, COVID-19 cases, hospitalizations, and deaths have increased, although cases have been declining in recent weeks. In November of 2021, unvaccinated adults 18 years of age and over had 4 times the risk of testing positive and 15 times the risk of dying from COVID compared to fully vaccinated adults. But we know that increasing cases are taxing healthcare resources, with many states facing ICU bed shortages again. We do know that over 200 million people are fully vaccinated in the US. However, vaccination coverage varies by age and geography. Next slide. So the work group agreed that COVID-19 disease among adults continues to be of public health importance. Next slide. So moving to benefits and harms. Next slide. We'll first very briefly review GRADE, which was excellently described recently. Next slide. As we just heard, for benefits, the clinical trial demonstrated efficacy against symptomatic labbed confirmed COVID, which was further supported by observational data. Overall efficacy was 92.7% with high certainty. The clinical trial also demonstrated efficacy against hospitalization, again further supported by observational data. The overall efficacy was 95.9% with moderate certainty of evidence. Deaths were uncommon in the clinical trial. However, observational data again demonstrated effectiveness against death due to COVID-19. The pooled vaccine effectiveness was 93.8% with moderate certainty of evidence. And finally, the clinical trial demonstrated efficacy against asymptomatic SARS-CoV-2 infection. Overall efficacy was 57.4% with high certainty. Next slide. Then in terms of harms, serious adverse events were reported in a similar proportion among recipients of vaccine and placebo. 2 specific rare serious adverse events have been associated with vaccination through safety surveillance. There was moderate certainty of evidence for these SAEs. Serious reactions were more common in vaccine recipients, and any grade 3 or more reaction was reported by 21% of vaccinated versus 4.5% of placebo groups. And the reactogenicity had a high evidence certainty. Next slide. In conclusion, the GRADE evaluation focused on recommendations following licensure of the Moderna COVID vaccine that has been used for a year under the emergency use authorization. Evidence for benefits are supported by a body of evidence comprising one large phase 3 randomized controlled trial and numerous observational studies conducted worldwide. The RCT evidence demonstrated efficacy for beneficial outcomes, including the 2 critical outcomes, symptomatic disease and hospitalization. Efficacy data were further supported by the body of evidence from observational studies. Regarding harm, grade 3 events were more common in vaccine than placebo recipients. But overall, RCT evidence showed that serious adverse events occurred at a similar frequency in vaccine and placebo groups overall. However, these 2 specific but rare adverse events have been associated with vaccination as identified through our safety surveillance systems. Next slide. So now we'll move to discuss the potential risk of myocarditis and the potential benefit and harm balance. Next slide. In vaccine safety surveillance, VAERS has demonstrated reporting rates of myocarditis greater than the background rates for males in the age groups 18 to 49 years and females after dose 2 in the 18 to 29 years. But we know that at least 90 days after myocarditis diagnosis, most patients reported no impact on their quality of life, and most did not report missing school or work. And most healthcare providers indicated that the patient was probably or fully recovered. Next slide. Now, as we think through the benefit-risk balance for the Moderna COVID vaccine in adults 18 to 39 years. Next slide. For assessment of this benefit-risk balance, the benefits were calculated per 1 million people who are fully vaccinated. Then I want to highlight for this, we focused on the age group of 18 to 39 years, which was selected because this age group has the highest rates of myocarditis and lowest hospitalization rates among adults, and would therefore have the closest benefit-risk margin. We use age and sex-specific hospitalization rates from COVIDnet and pooled VE estimates from 2 platforms. The benefits were calculated over a 150-day or 5-month period. Harms were calculated as per 1 million persons who were fully vaccinated, and the vaccine-specific myocarditis rates from the Vaccine Safety Data Link were used. Next slide. So then these are the vaccine-specific estimates of effectiveness against COVID hospitalization from both the IV network and Vision that were pooled to create a final VE estimate of 92%, which is the VE estimate used in the model. Next slide. This slide shows rates of myocarditis following the Moderna COVID-19 vaccine per million second doses administered among persons aged 18 to 39 years from VSD. Myocarditis was most common in males who had a rate of 67.5 myocarditis cases per million second doses in that 7-day risk period. Next slide. On this slide, we see the COVID-associated hospitalizations prevented by the Moderna vaccine compared with myocarditis cases expected, results presented per million fully vaccinated persons 18 to 39 years. On the left side of the figure, COVID hospitalizations prevented are represented by dark red bars, and on the right side, we see myocarditis cases expected by the light red. As you can see, over the course of 5 months, we would expect many more COVID hospitalizations prevented than myocarditis cases expected. Next slide. Then on this slide, you see the same structure, but with results presented per million fully vaccinated males aged 18 to 39. Again, as before, COVID hospitalizations on the left and myocarditis cases on the right. As you can see, again, over the course of 5 months, in males 18 to 39 years, who have the highest rates of myocarditis overall, we would still expect many more COVID hospitalizations to be prevented than myocarditis cases expected. Next slide. For the benefit-risk balance, there are a few limitations that should be noted. We consider direct benefits and risk over the 150-day period, comparing vaccine to no vaccine. The VE assumptions used in the model do not yet include Omicron-specific VE estimates, and we assume static hospitalization rate over 5 months, and the benefit risk profile would change as hospitalization rates change. And finally, the model does not account for booster doses or prior infection. Next slide. So to summarize the benefits and harms, the clinical trial and observational studies demonstrated the Moderna vaccine is effective in the prevention of COVID in persons 18 years of age and over. The risk of myocarditis or pericarditis is noted after the mRNA vaccines, and the highest risk was again seen after the second doses in younger males. However, the benefits for the Moderna COVID-19 vaccine far outweigh any possible vaccine-associated risk. Next slide. So in summary, the work group felt the desirable anticipated effects were large. Next slide. Undesirable anticipated effects were small. Next slide. And that the balance favored the intervention. Next slide. Now for values. Next slide. We've seen this figure previously showing the overall proportion reporting positive vaccine intentions by month of data collection, with bubbles proportional to the survey size. The surveys were conducted among adults asking about their intent to receive the COVID vaccine. And the overall intent has consistently increased since 2020 when the vaccines were authorized. Next slide. This slide shows vaccination status and intent among adults 18 years of age and over in the US from this survey. Almost 85% of adults reported that they are vaccinated or definitely will get vaccinated. 4% reported they probably would get vaccinated or unsure, and 10% reported they would probably or definitely not get vaccinated. Next slide. Then a survey of the American general population was conducted on individuals 18 and over between January 7th and 10th of 2022. Unvaccinated survey respondents were asked, does the discovery of the Omicron variant make you more or less likely to get the COVID vaccine? You can see that the majority of respondents expressed that it makes no difference, whereas a smaller proportion said that they would be less or more likely to receive the vaccine. Next slide. Then when those unvaccinated adults were asked what, if anything, would convince those who remain unvaccinated to receive a COVID vaccine, half of unvaccinated adults said that nothing would convince them to get a COVID vaccine. 1 in 7 offered that more research or transparency would convince them, and fewer said that they would get it if it was required for work or mandatory, if they received a large monetary incentive, if their doctor recommended it, or if the vaccine prevented 100% of infections. Next slide. We do know that initial data indicated following FDA's full approval of the Pfizer vaccine in the US, there was a slight uptick in the average number of Americans getting their first COVID vaccine dose, although not a rapid surge in vaccinations in the days immediately following approval. Full approval may have been enough to convince some to finally get immunized. Next slide. Then another ongoing survey designed by CDC and the University of Iowa to assess vaccine intent of unvaccinated Americans. In response to this FDA BLA for the Moderna vaccine, data was collected from January 27th through January 31st, 2022, with a current sample size of around 500 respondents. Next slide. When asked about reasons surrounding vaccine hesitancy, concerns about vaccine side effects, or general mistrust of COVID vaccines were the top reasons for remaining unvaccinated. Next slide. Then during the data collection period, 29% of the unvaccinated respondents said that they thought the Moderna COVID vaccine already had full approval from the FDA. Next slide. In relation to vaccine intentions in response to the Moderna BLA, 5% of unvaccinated respondents said that they would get a vaccine as soon as they could if the Moderna vaccine received full approval from the FDA. Next slide. An additional 20% of unvaccinated respondents said they would continue to wait and see if COVID vaccines were safe. Next slide. 50% said they would definitely not get vaccinated or would only do so if it was required. Next slide. 11% of unvaccinated respondents said that they would wait a few more weeks to get a COVID vaccine after the Moderna vaccine received full approval, but were open or unsure about getting that vaccine. Next slide. And an additional 11% of unvaccinated said that they would wait more than a year to get a COVID vaccine after the Moderna vaccine received full approval. Next slide. So overall, the work group felt that the overall population felt the desirable effects were large relative to undesirable effects. Next slide. However, there was probably important uncertainty or variability in how people value the outcome. Next slide. So moving to acceptability. Next slide. As of February 2nd, over 200 million doses of the Moderna vaccine have already been administered and implemented in a wide variety of settings, including state and local health departments, mass vaccination clinics, long-term care facilities, and retail pharmacies. Next slide. Vaccination with the Moderna COVID vaccine was already highly acceptable to stakeholders under FDA's emergency use authorization and ACIP interim recommendations. Vaccination may be more acceptable under full FDA approval and standard ACIP recommendations. Next slide. So the work group felt that the Moderna vaccine is acceptable to key stakeholders. Next slide. Moving to feasibility. Next slide. So these are the barriers, possible barriers to implementation that have been mentioned in previous ETRs. Next slide. The Moderna vaccine will be the second vaccine with the BLA. The BLA has only been issued for some indications, which could add complexity. The BLA is issued for the primary series in those 18 years of age and over, while the EUA recommendations remain for the additional dose and booster dose recommendations. In addition, recommendations made under EUI, which can only be made for vaccines with a BLA, will now be extended to include the Moderna vaccine. Next slide. There have been a variety of updates and improvements to the vaccine storage and handling requirements since the initial EUA. Now the vaccine can be stored frozen and refrigerated for up to 30 days prior to the first use. Next slide. And as throughout the pandemic, all COVID vaccines are provided to the US free of charge. However, health systems or health departments can incur costs for vaccine implementations, clinics, and outreach. And we know that financial hardships may arise if vaccine recipients need to take time off of work or could experience post-vaccination reactogenicity that would keep them from work. Next slide. We aren't anticipating any supply barriers. Vaccine supply in the US is sufficient for implementation of the intervention. As of February 2nd, over 200 million doses have already been administered in the US, which demonstrates that the vaccine is feasible to implement broadly. Next slide. And the work group said that the vaccine is feasible to implement. Next slide. Moving to resource use. Next slide. This graph illustrates one analysis with the estimated cost of preventable COVID hospitalizations among unvaccinated adults in the US. From June through November of 2021, preventable COVID hospitalizations among unvaccinated adults were estimated to cost over $13 billion. Next slide. Vaccine doses purchased with US taxpayer funds will be given to people living in the US at no cost. And several published modeling studies have found that COVID vaccines are likely to be of reasonable economic value and may also be cost saving under many circumstances. Next slide. So while not a primary driver of decision-making in the pandemic, the work group still felt that the Moderna vaccine was a reasonable and efficient allocation of resources. Next slide. Finally, for equity, next slide. This slide shows the cumulative COVID-19 associated hospitalizations in the US by race and ethnicity for March 7th of 2020 through March 22nd of 2022. As illustrated, American Indian and Alaskan Native, Black, and Hispanic populations have consistently had the highest rates of COVID-19 associated hospitalizations in the US. Next slide. Now we'll take a look at percentage of people 18 years of age and over who've received at least one dose of the COVID vaccine by race and ethnicity over time. As illustrated, American Indian and Alaskan Native populations have consistently had the highest percentage of those receiving at least one dose of COVID vaccine. Next slide. This figure shows similar with the percentage of COVID of people 18 years of age and over who've received at least one dose by race and ethnicity over time. Next slide. Now, taking a look at COVID-19 vaccination coverage by geography, only 20% of U.S. counties report 70% or more of the population 18 years of age and over that are fully vaccinated. Next slide. We know that vaccine uptake lags in adults living in rural and suburban areas compared to urban areas. As of November of 2021, 8 in 10 urban residents say that they've received at least one dose of a COVID vaccine, compared to 7 in 10 suburban adults and 67% of rural adults. 1 in 5 of those living in rural areas and 1 in 6 of those living in suburban areas say they will definitely not get a COVID vaccine, which is at least twice what urban residents say. Next slide. Then in an MMWR that was published just this week, COVID vaccination coverage was assessed among LGBT adults 18 years in age and older. By sexual orientation, gay or lesbian adults reported higher vaccination coverage overall than heterosexual adults, and there weren't significant differences in vaccination coverage among persons based on gender identity. Vaccination coverage was lowest among non-Hispanic, Black, LGBT persons across all categories of sexual orientation and gender identity. Next slide. So there's considerable variability in the interpretation of the equity domain, but overall, the work group felt that the approval of the Moderna vaccine would probably have no impact on health equity. Next slide. So in summary, next slide. This is the summary of the work group judgments for each of the ETR domains. Next slide. So I know this slide looks complex, but just highlighting that for both of the primary series and additional booster doses, and for all 3 COVID vaccines used in the US, there are EUAs in place. 2 of those EUAs, the primary series for Pfizer in those 16 and over, and the primary series for Moderna in those 18 and over, have full FDA approval with the BLA. The authorization and any vote by ACIP today won't override any existing recommendations for the EUAs. And ACIP will continue to review data as additional vaccines and indications move from EUA to BLA. Next slide. Overall, COVID-19 vaccines have been a critical tool in this pandemic, preventing millions of COVID-19 associated hospitalizations and death. To date, hundreds of millions of doses of the Moderna COVID-19 vaccine have been given, with over a year of incredibly closely monitored real-world safety and effectiveness data. Vaccinating the unvaccinated with a primary series continues to be important, with additional protection from all recommended COVID-19 vaccine doses important over the course of an evolving pandemic. Next slide. So this is the summary of the workgroup interpretations with the balance of consequences. We've shown this before, but where undesirable consequences outweigh desirable on the left and desirable consequences outweighing undesirable on the right. Next slide. The workgroup felt that the desirable consequences clearly outweigh undesirable consequences in most settings. Next slide. Then looking for the type of recommendation proposed by the workgroup. Next slide. The workgroup recommended the intervention. Next slide. Again, there is a small but mighty team that puts all of this together, and so none of this would happen without them. Want to thank them. Next slide. Yeah, okay. Happy to take any questions and turn it over to you, Dr. Lee.
Thank you, Dr. Oliver, as usual, an excellent presentation and a really wonderful overview of the work of the work group. I want to open this presentation for questions from the committee members. or from our liaison members? Dr. Hahn.
Yeah, thank you. First of all, I agree. Wonderful presentation and wonderful to hear. I wanted to make a comment that really just I came to fully understand in the last week or so, and I just wanted to bring it forward. We continue to get questions about hospitalization case rates, but also particularly hospitalization rates among people partially vaccinated. And we kept saying, no, we consider them unvaccinated because they're unvaccinated, and that's where they show up in the data. And it wasn't until recent conversations with continued queries, let's say, from members of the public, that I realized that the perception, and I would go so far as to say kind of the rumor or the theory, is that partially vaccinated people, if you will, people who've had a single dose, or maybe people who've just gotten their second dose, make up a large percentage of what we're calling unvaccinated people in the hospitals, and that the hospitals are filling up with people who got a dose of the vaccine, and maybe even that somehow gave them COVID, whether it's from the vaccine itself or whether it's from some sort of immunosuppression after the vaccine. I can't say, but I did not grasp that was the concern. But we have gone ahead and started to produce data showing this as a separate group. And I just wanted to bring it up now. I know it's a little bit off the topic of what we're talking about today, but we keep showing these slides, and it keeps striking me every time that we might want to think about showing this group separately. And for example, we were able to demonstrate that no, our hospitals, that's a very small percentage of people in our hospitals right now that had a single dose or that had recently been vaccinated. So I just wanted to make that comment, and I don't know if there's any response needed, but I just wanted to say that. Thank you.
Thank you, Dr. Hahn. Are there any additional questions or comments? While we're waiting to see if any additional hands will be raised, I just wanted to, comment on the resource allocation issue, which I recognize the mandate of ACIP is really the health of the U.S. population, but also just wanted to highlight that the estimated impact or economic burden doesn't really reflect the true cost of the pandemic in our society. It's not just hospitalizations and the cost of those hospitalizations. It's, the work missed, the businesses closed, wages lost. It's the worsening of the already existing educational disparities in this country, which I think also has long-term economic consequences on this generation of kids directly impacted by the pandemic. I recognize it's nearly impossible for you to capture all of that in our resource sort of assessment. But I do think it's important to acknowledge that in some way, because this goes well beyond the way we typically think about vaccine deliberations at ACIP. Are there any other questions or comments from our committee members or from our liaison members? Dr. Paling.
Dr. Oliver, thank you for a fantastic presentation. It was very clear. I just wanted to get input. Was there much diversity in the opinion of the work group in voting for the recommendation?
Thank you. There absolutely was not. The work group overwhelmingly agreed that they would recommend the intervention, which is the 2-dose Moderna primary series. Thanks.
Thank you. I don't see any additional hands raised at the moment. While we're waiting to see if there's any additional questions, comments, or clarifications, I'm actually going to ask you, Dr. Oliver, to, if you're able to put up, and I believe we're ready for this, put up the wording for a proposed vote. That would be really helpful.
Dr. Lee, do you want me to read it?
Please go ahead.
Okay. So the language for the vote is the Moderna COVID-19 vaccine, BLA approved vaccine called Spikevax, the 2-dose primary series, is recommended for persons 18 years of age and over. This isn't included in the vote language, but we just wanted to make sure that we clarified the ACIP recommendations addressing the EUA uses of the Moderna vaccine will remain in effect. So this only would move the recommendation for the 2-dose primary series from kind of that interim recommendation under EUA to full recommendation. The other EUA votes would remain in effect.
Thank you. Are there any questions, clarifications, or discussion points that people would like to add? Okay, do any of our voting members wish to make a motion? Dr. Paling, I saw your hand raised.
Yes, I would like to make a motion to accept this verbiage. Thank you.
Thank you. So proposal to accept the ACIP vote language on this current slide. Dr. Alt?
I will second the motion.
Thank you, Dr. Paling and Dr. Alt. It's been moved and seconded that we adopt the recommendation language presented by Dr. Oliver and the work group on behalf of the work group. Any additional questions or issues the committee would like to discuss before the vote? Okay, I see people are eager to vote. Since there's no additional hands raised, we will move forward, and I see my ACIP members already turning on their video. Please state your, as a reminder, after you turn on your video, I'm going to ask you to state your name, whether you have a conflict of interest, and then your vote. Give me a moment, sorry. All right, terrific. Today we will start with Dr. Alt.
Alt, no conflicts, yes.
Thank you. Ms. Bata.
Bata, no conflicts, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Just to warn my colleagues, I'm going actually in alphabetical order today. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen.
Over Chen, let me state that my university has grant funding from the Emergent Biosolutions for development of a Shigella vaccine. I don't perceive this as a true conflict. My vote is yes.
Thank you, Dr. Chen. Dr. Sineas.
Sineas, no conflict, yes.
Thank you. Dr. Daly.
Matt Daly, no conflict, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflict, yes.
Thank you. Dr. Lair.
Amy Lair, no conflict, yes.
Thank you. Grace Lee, no conflicts, yes. Dr. Paling.
Kathy Paling, no conflict, yes.
Thank you. Dr. Sanchez.
Los Sanchez, no conflict, yes.
Thank you. Dr. Talbot.
If Talbot, no conflicts, yes.
Thank you. I believe we have 13 yeses, 0 nos, and so the motion passes as stated. I'll ask if there's any comments people would like to make on their vote. It's not required, but I just wanted to make sure I offer the opportunity to my colleagues. Dr. Daly.
Yeah, I have to be honest. I still have a sense of wonder at what's been accomplished here, that and a deep sense of gratitude. We now have 2 vaccines against COVID-19 that are fully licensed in the US. And these vaccines were authorized and then licensed along a rapid timeline while still following all the well-established regulatory processes in place before the pandemic. And as I mentioned earlier today, an estimated 1.1 million deaths have been averted through vaccination in the US and countless more globally. And I don't think we can take this for granted. We shouldn't assume that this was an inevitable outcome. To put this in a more personal context, we all have individuals in our lives, parents, grandparents, children, friends, who may have gotten sick or died from COVID who did not because of vaccination. And for that, I'm very grateful. I say all this while still wanting to acknowledge that many have lost their lives to COVID, and we're all still vulnerable, particularly the very young, the very old, the unvaccinated, and those with immunocompromise. So I know we still have a lot of work to do, and we have a lot of challenges ahead of us with respect to the pandemic and the role that vaccines play. But today, I'm just very appreciative of all that's been accomplished. Thank you.
Thank you, Dr. Daly. And we all appreciate your leadership of the COVID vaccines work group, which has been quite busy. Dr. Bell.
Thank you. I wanted to sort of comment on a sort of a corollary to what Dr. Daly just said. The ACIP, one of the things that we value the most is transparency. And one of the things, therefore, that I think we can see from this process today is in a broad context, evaluating risks and benefits using evidence, scientific evidence that's been accumulated over a long period of time now with millions of people vaccinated. We can see the power and the value of vaccination. And so I would just like to say one other thing that we continue to see is that the biggest risk to individuals is not getting vaccinated. So I hope that by this transparent process where we have summarized in a very sort of comprehensive way, looking at the context, the big picture, and then very sort of detailed individual scientific data, the huge value and benefit of getting vaccinated. And I hope that at least for some people who are still thinking about whether they should get vaccinated, that this process and this transparent meeting helps them to do the most important thing that they can do to protect themselves and their family, and that is to get a vaccine.
Thank you for those words, Dr. Bell. Any other comments or statements? I see Dr. Duchin would like to make a comment.
Thank you, Dr. Lee. I would just like to reinforce the importance of the booster dose. I know we've been talking about the primary series here, rightly so, but there are many people in our community and many communities throughout the country who have received that primary series and who haven't yet, were eligible, but yet have not received the booster dose. And it's critical to understand how necessary that booster dose is to receive the full protection that these vaccines can offer against serious disease, including hospitalization and death. So I just want to state that again. And also for people who wonder about Omicron and, will we be needing an Omicron specific vaccine? I'm wondering if you or one of the experts can talk about what's on the horizon with respect to the potential need or not. I don't believe it's clear that there will need to be an Omicron vaccine specifically developed, but I would love to hear from someone authoritative about where we're at with that. Thank you.
Thank you. Dr. Duchin, well, you know what I would like to do, if it's okay with everyone, Dr. Duchin, remind me that you asked that question, but what I would like for us to do is to maybe take a break, allow my CDC colleagues to confer about who the appropriate respondent might be to that. And I just want to thank the committee for an efficient day, an efficient vote, perhaps because for all of us, this decision was one that was straightforward and not complicated, unlike many of our other prior decisions. So appreciative that we have gotten through the morning, would like to actually take a 15-minute break. So let's plan to convene again at actually 25 minutes after the hour. We'll return for the afternoon session, which will be a focus on some of the clinical considerations and clinical discussions that have been ongoing. And Dr. Duchin, hopefully we'll be able to get back to your question then. Thanks, everyone. Okay, it's now 25 minutes after the hour. We are returning from break and we have a series of presentations this afternoon. We are going to start with an update to clinical considerations by Dr. Hall from CDC. As a reminder, we only vote on recommendations, but for the clinical considerations, which are often nuanced and respond to much of the feedback that comes through when implementation occurs, that this is meant for discussion. So please provide feedback and discussion around the clinical considerations. And I'll turn it over to the room at CDC to get us started.
All right, thank you. I'm Alicia Hall, and today I'll be covering anticipated updates to the interim clinical considerations for use of COVID-19 vaccines. Next slide, please. So anticipated updates will include clarification and updates on guidance for people who are moderately or severely immunocompromised, updates to recommendations on passive antibody products, and reduction and reorganization for ease of use. Next slide, please. I'll start with updated guidance for people who are moderately or severely immunocompromised. All guidance in this section will apply only to this population. Next slide. As a reminder, recommendations for people who are immunocompromised at the time of vaccination are already different than recommendations for most people. This is because this group is at increased risk for severe COVID-19 and more likely to have serious breakthrough infections. They may not mount a protective immune response after a 2-dose primary series, and in general have lower vaccine effectiveness than people who are not immunocompromised and have waning protection over time. Next slide. Before I dive into changes, here is the current COVID-19 vaccination schedule for people who are moderately or severely immunocompromised. Similar to the recommendation for the general population, mRNA COVID-19 vaccines are preferred for all doses over Janssen COVID-19 vaccine. For those in this population who choose an mRNA COVID-19 vaccine primary series, this includes a 2-dose primary series, 1 additional dose, this is not indicated for people who are immunocompetent, and 1 booster dose for people ages 12 years and older, for a total of 4 doses. For those who choose Janssen, this includes 1 primary dose and 1 booster dose. Next slide, please. There has been recent confusion about the recommendations for this population, including reports of people who choose mRNA COVID-19 vaccines being denied their 4th dose. In addition to communication efforts, we are adding more clarification in the clinical considerations to emphasize this population should receive 3 doses for a primary series and 1 booster dose if they are ages 12 years and older for that booster dose. There are no changes in the number of doses here. It is simply clarification to address these challenges we are hearing. Next slide. The next few changes I'm going to discuss are possible through use of emergency use instructions, or EUI. EUI are allowed under the Pandemic and All Hazards Preparedness Reauthorization Act. EUI provide information about emergency use of FDA-approved medical products that may not be included or differ from the information provided in the FDA-approved labeling package insert. Since EUI are only for FDA-approved products, this only applies to the 2 approved COVID-19 vaccines, which are Spikevax or Moderna, for which guidance would apply to people 18 years and older, and Comirnaty or Pfizer-BioNTech, for which guidance would apply to people 12 years and older. Next slide. EUI materials, including fact sheets for healthcare providers, fact sheets for recipients and caregivers, and FAQs can be found on the website listed on this slide. Next slide. Revisions utilizing the EUI mechanism for people who are moderately or severely immunocompromised include a shorter booster interval after an mRNA COVID-19 vaccine primary series, an additional dose after a Janssen COVID-19 vaccine primary series, and case-by-case clinical decision-making. Next slide. Currently, people who are moderately or severely immunocompromised who received an mRNA COVID-19 vaccine primary series are recommended to receive a booster dose at least 5 months after completion of the series. This 5-month booster interval will be revised to at least 3 months after completion of the mRNA primary series. Next slide. The rationale for this decision was out of an abundance of caution to help this population that may not be as well protected get their booster dose sooner, particularly with concerns about initial immune response, loss of protection over time, and high community transmission due to the Omicron variant. To support this change, small studies demonstrate immunogenicity of a 4th dose when administered 1 to 3 months after the 3rd dose. Among participants with seronegative or low positive responses after 3 doses, 42 to 66% were seropositive after 4 doses. Additionally, multiple studies demonstrate immunogenicity of a booster dose as early as 3 months in the general population following a 2-dose primary series. And finally, multiple countries have implemented booster doses as early as 3 months in the general population following a 2-dose primary series. Next slide. Next, guidance will be added on the schedule for people who are moderately or severely immunocompromised and who received a Janssen COVID-19 vaccine primary series. These people are currently recommended to receive 1 booster dose at least 2 months after completion of the primary dose. An mRNA COVID-19 vaccine is preferred for the booster dose, but Janssen COVID-19 vaccine can be used provided the patient is educated on the risks and symptoms of thrombosis with thrombocytopenia syndrome, the need to seek medical care should such symptoms develop, and the availability of mRNA COVID-19 vaccines. Next slide. The revised guidance will add an additional dose to this schedule. So, people who are moderately or severely immunocompromised would be recommended to receive 1 additional dose at least 28 days after the primary Janssen COVID-19 vaccine dose, and 1 booster dose at least 2 months after completion of the additional dose, for a total of 3 doses. We realize many people may have already received 2 doses, their primary dose and booster dose. Our guidance will address what to do if someone has already received a booster dose. There is not guidance for more than 3 doses. Next slide. Finally, we'll be adding language that, on a case-by-case basis, providers who care for moderately or severely immunocompromised patients may administer mRNA COVID-19 vaccines outside of the FDA and CDC dosing intervals based on clinical judgment, when the benefits of vaccination with a different schedule or dosage are deemed to outweigh the potential and unknown risks. However, providers should not routinely administer additional doses of COVID-19 vaccine beyond those recommended in this guidance. Additionally, I'll note antibody testing is not currently recommended to assess the need for vaccination or assess immunity following vaccination. Next slide. Putting these recommendations together, the revised schedule for people who are moderately or severely immunocompromised is shown on this slide, with differences from the current schedule shown in orange. So, people who receive an mRNA COVID-19 vaccine primary series should receive 3 primary doses followed by a booster dose 3 months after completion of the primary series. The 3-month interval is the only change here. People who receive a Janssen COVID-19 vaccine primary series should receive an additional dose 28 days after the primary series, followed by a booster dose 2 months after the additional dose. Both the additional dose and the interval has changed here. Finally, I'll move on to passive antibody products, which applies to everyone, not just those who are immunocompromised. Next slide. Currently, for people who have received passive antibody products for COVID-19, there's a recommended deferral period before vaccination. People should defer vaccination for 30 days if the product was used for post-exposure prophylaxis and 90 days if it was used for treatment. With our revised guidance, people who previously received antibody products had a little freeze there. With our revised guidance, people who previously received antibody products, for instance, anti-SARS-CoV-2 monoclonal antibodies or convalescent plasma, as part of COVID-19 treatment, post-exposure prophylaxis, or pre-exposure prophylaxis can be vaccinated at any time. There is no longer a recommended deferral period for COVID-19 vaccination following receipt of an anti-SARS-CoV-2 antibody product. I will mention here, though, in people who previously received a COVID-19 vaccine, Evusheld for pre-exposure prophylaxis should be deferred for at least 2 weeks after vaccination, per the product EUA. Next slide. The reason for removing the deferral period is based on a balance of benefits and risks. First, a study among nursing home residents and staff demonstrated that recipients of the monoclonal antibody bamlanivimab mounted a robust immune response to mRNA vaccination, regardless of age, risk category, or vaccine type, suggesting an interval dose does not need to be tailored to particular subgroups. Although antibody response was numerically lower in people who received monoclonal antibodies, it was still considered to be high, and the clinical significance of the reduction is unknown. Most notably, there was no correlation between interval to COVID-19 vaccination and neutralizing titers. Programmatically, there can be challenges to current intervals between receipt of monoclonal antibodies and COVID-19 vaccination, which may reduce the likelihood of getting vaccinated. And finally, in the current setting of the COVID-19 pandemic, getting people vaccinated, including booster vaccination, is a priority, and the benefits likely outweigh any potential risks for immune interference from monoclonal antibodies. Next slide. Finally, we're in the process of streamlining the content and layout of the interim clinical considerations for increased usability. You can find our interim clinical considerations on the website shown on the slide, and they may look a little different the next time you go there with this streamlining of content. Next slide. And I failed to make an acknowledgement slide, but I do just want to thank our CMO and clinical guidelines and clinical education group for being critical in putting this guidance together. Thank you.
Thank you so much, Dr. Hall. And I have to say, these changes are very much welcome for those of us who are providing care or recommendations on the front line. So this is really helpful, practical implementation information that I think will make a huge difference to many of the patients we care for. I'm going to ask if there are any questions or discussions people want to raise as part of these clinical considerations that are being proposed. Dr. Cotton.
I'd just like to second what you said, Dr. Lee, that this is a really, really important update for immunocompromised patients. In the past 2 months, I've seen many of these immunocompromised patients who had followed all the rules still have significant breakthrough infections, and I really think that this will help dramatically. So thank you very much for these important updates, and also on the passive antibody, because as many of us are rolling these out, clarity there is going to be really, really helpful. So greatly appreciative.
Thank you, Dr. Cotton. Dr. Brooks?
Yes, and again, excellent presentation and glad to see this. I have a question regarding the J&J for immunocompromised. It shows that for the second dose, you should only use an mRNA vaccine, but for the quote-unquote booster, you could use any vaccine. Can you just explain that difference in recommendation?
Yeah, thank you for that question because it is confusing. So the main reason for this is due to legal limitations. So for the recommendations that have been added for moderately or severely immunocompromised, including this recommendation, they're possible through those emergency use instructions, which can only use licensed vaccines. So the additional dose we've added on must be Pfizer or Moderna because that's all that's allowed through the emergency use instructions. And the booster continues to be preferred for Moderna and Pfizer due to the risk for TTS.
Okay, thank you.
Thank you. Dr. Sanchez.
I have a similar question about that. So, so for the Janssen product, the additional dose, like you said, only Pfizer, Moderna, but then the booster, it could be also the Janssen. And I guess my question is, are the data that strong that it has to be at least 2 months and the other one at least 3 months? And especially if the second dose is a Pfizer, Moderna, can't we just harmonize and say that all of them should be given 3 months or later? It'd be nice to just, I mean, we're grappling with the 21, 28, 1 month, 2 months. Why not just do both booster doses all at 3 months?
Yeah, I understand what you're saying. It is very confusing to have all of these different intervals. So the 2 month is currently allowed under the EUA for the booster. We had not considered extending that. For the mRNA, we wanted people to get it sooner, but Janssen is already sort of sitting with that 2 month. So we would have to look into what would be possible to actually extend it. And I'm not sure we would necessarily want anyone to get the booster later.
Thank you. Dr. Lear.
Yeah, so we just voted to extend the BLA for the primary series from Moderna. It seems to me that these clinical considerations are going past that and making suggestions that still fall under the EUA. And I guess I just want clarification that it's appropriate to do that. My sense in the past has been the EUA was a strict guideline and that you shouldn't bend those rules at all. And so if we're going past that, is that appropriate? Thank you.
Yeah, thank you for that question. It is kind of confusing because this is through the EUI instead of the EUA. CDC is allowed to issue emergency use instructions that go outside of what is indicated in the package insert. So that is the reason that we're able to do that and it still be covered.
Thank you. Dr. Freihofer?
Thank you. This has been an excellent presentation. My question is about slide 7 and the EUI. Again, a little bit more confusion on my part. So it says applies only to use of Spikevax that's approved for 18 and older and Comirnaty for age 12 and older. I thought that the Comirnaty was only FDA approved with the BLA for 16 and older.
Great question. I was actually waiting for that question because these EUI are super confusing. So you're correct. Comirnaty is 16 and older, licensed for the 2-dose primary series. So essentially, and I will caveat that I am not a legal expert, so I will explain this as best I can. But essentially, the EUI allow for use of approved vaccines. So since Comirnaty is the gray cap and purple cap vials, since those are, as they would be called, BLA compliant vials, anything in the EUI can apply to those vials, and since they can be used for ages 12 years and older, that is why it can apply down to that age. I hope that explained it. I know it's super confusing.
And this is Sarah and Bay. I wanted to also, I know, emergency use instructions are kind of a new pathway that many people are hearing about for the first time. I just want to make the point that we are using these in close coordination with FDA, and it's through mutual consultation that we have sometimes made the decision that it is more appropriate to use an EUI for certain things versus other regulatory mechanisms. So we're not going outside of the FDA, we're actually collaborating with them to find the best path forward that would legally allow us to make some necessary changes to the clinical considerations.
So this is Sandy Fryhofer again from the American Medical Association. So we can still do this for those as young as age 12, though. That slide is correct then, right?
That is correct. Yeah. So unfortunately, not able to go down to the 5 to 11 age range, but can go down to the 12 years.
Thank you.
Thank you. Are there any other questions, comments, discussion? Okay. Thank you, Dr. Hall, for your presentation. We will move on to our colleagues from the Public Health Agency of Canada, Dr. Tunis, Dr. Warshawski, and Ms. Ogunaki-Cook, who are kindly sharing their Canadian experience with us around COVID-19 vaccine primary series extended intervals. So, Dr. Tunis, I'm going to turn it over to you.
Thanks so much. Can you hear me okay?
We can, thank you.
Excellent. Yeah, thank you for the opportunity to come present here today. So if you can go on to the next slide, just for a brief overview, we're going to talk about the Canadian program context. We'll go through some highlights of evidence that have informed the Canadian recommendations, thinking about the one-dose effectiveness during the duration between doses. We'll look at the immunogenicity with longer intervals, the effectiveness with longer intervals, and then the safety with the longer intervals as well, which is some emerging data. Next slide, please. So Canada's National Advisory Committee on Immunization, or NACI, has been providing advice on the COVID-19 vaccine intervals since 2020. And I think it's important to note a bit of a structural difference throughout the pandemic between the Canadian and US context. So under the terms of reference, even under a regulatory interim order throughout most of the pandemic, which would be roughly comparable to the EUA in the US, NACI was permitted to issue off-label advice on COVID-19 vaccines as per usual. So there have been a number of off-label recommendations really from day one of the COVID-19 vaccines, and there's been no issue around that. So that's a bit of maybe a structural difference. NACI has provided several updates on extended intervals for the primary series as evidence has evolved. And so here is really just Cole's notes on a sort of a timeline of how things evolved in Canada and with some highlights internationally as well. So from the beginning with the COVID-19 vaccines in December, NACI actually recommended an alternate interval of 28 days for Pfizer, which is of course longer than the 21-day authorized interval. Then early in December, Quebec's Provincial Immunization Committee, which is a provincial committee within Canada, there are strong linkages between NACI and that provincial committee as well. That provincial committee recommended first doses to all priority groups before second doses. Then December 30th, we saw JCVI in the UK recommend 3 to 12-week interval for Pfizer-BioNTech and a 4 to 12-week interval for AstraZeneca to maximize first dose to priority groups. Then an alternate interval was recommended by NACI in January, moving out to 6 weeks or 42 days based on the clinical trial data and the efficacy estimates that did include up to 42 days. So that alternate interval, preferably within 42 days, would be to maximize first doses to priority groups. Then the big shift in Canada happened really in March when NACI recommended up to a 4-month interval for all COVID-19 vaccines. And there was a full statement with all of the evidence and rationale in April. And then in the fall, that interval was refined further to 8 weeks. So NACI recommended an optimal interval of 8 weeks for adolescents and adults.
When the pediatric 5 to 11 program came through in Canada, NACI recommended at least 8 weeks for that in November. And then I've just noted that on January 21st, WHO and SAGE recommended a 4 to 8 week, or preferentially 8 week interval as well. Next slide, please. So as you can see, it's been an evolving story in Canada around intervals. The settling place does seem to be around 8 weeks. The core principles that have informed NACI interval recommendations have been fairly diverse. So the extended interval recommendation up to 16 weeks, that was back in March of 2021, was informed by initially a trigger for limited supply. There was early vaccine effectiveness assessment of strong one-dose protection from mRNA clinical trials and also from Israel, and later from Canada and UK research and surveillance. AstraZeneca 2-dose clinical trial, which did show that longer intervals yield better vaccine efficacy. There was modeling to optimize program impact in the context of limited supply, and of course, immunology and vaccinology principles, and ethics, equity, feasibility, and acceptability. And the subsequent move in the fall towards an 8-week interval was additionally informed by Canadian and UK vaccine effectiveness data, demonstrating increased protection with those longer intervals, which plateaued around 8 weeks. Then the immunological data on the breadth and duration of immune response with longer interval, Canadian safety surveillance showing lower rates of myocarditis with the longer interval, which you're going to hear about later in the presentation, and ethics, equity, feasibility, and acceptability again. So just to note that while the safety and myocarditis has been an emerging part of the story now, it actually is a late comer to the Canadian interval story, that originally it was driven more by other vaccine principles, and now the safety and myocarditis rates have also additionally augmented and informed that. Next slide, please. So just to briefly recap on some immunological principles around the longer intervals, we know that affinity maturation can be improved, and the longer interval between primary and secondary antigen exposures will allow immune memory cells more cycles of affinity maturation to develop higher affinity, and this may increase the breadth and or neutralizing activity of the response. There's less potential for immune interference also with longer intervals, so the circulating antibodies may interfere with immune responses of the subsequent exposures because of epitope masking, where the circulating antibodies can occupy antigen binding sites, and also reduced antigen availability, where antibodies can actually form immune complexes and be cleared out if the antigen is reintroduced too soon. Next slide, please. So I'll hand it over now to Dr. Warshawski to go through some of the evidence on the effectiveness, immunogenicity, what we've seen, and then also the emerging safety. Thanks.
Thanks very much, Dr. Tunis, and just confirming that you can hear me?
Yeah.
Great. Thanks for the opportunity to present and to continue the story that Matthew has started. So the first area that we explored when we were looking at our extended interval was the vaccine effectiveness with regard to the one dose. So we had been looking at the literature that was available at the time, and as Matthew mentioned, we published a statement on April 7th that summarized the literature to that point. So based on that summary, one dose of mRNA vaccine was shown to be effective against symptomatic disease and infection at about 60 to 80%. Some of the estimates were a bit lower, some of them were a bit higher, but they were in that range. Now that was a little lower than we had expected based on the one dose efficacy from the clinical trial, which was 92%, and also lower than the effectiveness and efficacy with the 2 doses. But very reassuringly, the one dose protection against serious outcomes was higher than against symptomatic disease and infection at around 80% or more. Next slide, please. So our next question was, how long would the protection from one dose last? And here we relied on information from our colleagues from the UK, which, as Matthew mentioned, had started the extended interval ahead of us. So they presented to us on a regular basis, and this is a summary of the data that they have. Here we're seeing the vaccine effectiveness following the first dose over time. So in the upper left, you can see for the 50 to 64-year-olds who have had one dose of the Pfizer-BioNTech vaccine, the vaccine effectiveness is around 60%, but then when you get out to about 8 weeks after that first dose, it decreases a little bit to 40 to 50%. Similarly, in the upper right-hand corner, you can see for the 65 to 79-year-olds, around 60% out to 10 weeks, and then it decreases a little bit after that as well. So on the next slide, So knowing that there is vaccine effectiveness with one dose and that it lasts, 8 to 10 weeks, the other thing that we were very interested was, as Matthew mentioned, this principle from immunology that the longer the interval between the first and second dose, you might expect a higher immune response after that second dose. And this was borne out in trials that came out of the UK as well. This is their consensus cohort of 750 people who they followed, who had periodic serological testing. They were 50 years of age and over. And here you can see that based on the interval between their first and second dose, the geometric mean titers that were achieved after the second dose. So you can see here that when the interval is shorter, the geometric mean titers are lower. And then as the interval gets longer between the first and second dose, the GMTs get higher after that second dose. And there are also subsequent studies from this group that show that if you potentially if you extend the interval between the second dose and the booster dose, you also get higher titers there as well. So with this immunologic information, one can anticipate that that may translate as well into vaccine effectiveness. So on the next slide, this is also data from the UK, and here they did look at vaccine effectiveness. So this is vaccine effectiveness after the second dose of the Pfizer-BioNTech vaccine. And on the x-axis, what you're seeing there is the interval between the first and second dose. And you're seeing it in the various age groups. So if we focus on the third column, which is the 65 to 79-year-olds, you can see that when the interval is shorter, so 19 to 29 days between the first and second dose, there your vaccine effectiveness is around 75%. But when you go out with a longer interval between the doses, so 6 weeks or more, you see the vaccine effectiveness become higher, so up to 90% and a bit lower than that. And you can see that in the various age groups as well. The one thing to note, though, is that when you have a shorter interval, it's also likely a longer period of time from your second dose to when the study is done. And that longer interval between the second dose and the time of the study can also affect your vaccine effectiveness. So those two concepts can be conflated: the interval between your second dose, between your first and second dose, and the time from your second dose to the study. So there are some studies from Canada that have helped to try to tease those two concepts apart. So on the next slide, this is a study by Skowronski and et al., our colleagues from across Canada, who have looked at the mRNA vaccine effectiveness against infection and hospitalization by the interval. So to orient you to this slide, because I know it's pretty busy, on the left, we see data from two of our Canadian provinces. So on the left-hand side is British Columbia, and on the right-hand side is Quebec. And what you're seeing on the x-axis here is the interval between the doses. So the blue shows you the vaccine effectiveness after the second dose based on infection, and the brown shows you the vaccine effectiveness after the second dose based on hospitalization. So if we look at the Quebec as an example, you can see that when the interval is short, so 3 to 4 weeks, against infection, you're seeing a 79% vaccine effectiveness. But when the interval is longer, say 7 to 8 weeks between the first and second dose, the vaccine effectiveness after the second dose is 89%. So about a 10% difference with the longer and the shorter interval. And if you look at the hospitalizations in the brown, you can see the same thing. So with a 3 to 4 week interval, the vaccine effectiveness against hospitalization is 87%. And with the longer interval, it goes up to 97 and 98%. So with both, there's about a 10% vaccine effectiveness difference if you go from a shorter interval to a longer interval. And similarly, in British Columbia, they found similar things. The difference there wasn't quite as large, but about a 6% difference between the shorter interval and the longer interval. Now, on the next slide, what Skowronski and al. did as well is they looked at this over time. So here we're seeing Pfizer vaccine after the second dose, British Columbia on the top, Quebec on the bottom. Here on the x-axis, what you're seeing is the time since the second dose. And the different colors show you the people who've had their vaccines at different intervals. So the purple is the shorter interval between the first and second dose, versus the yellow and the green are longer intervals between the first and second dose. So if you look at the Quebec as an example, with the shorter interval, they have a lower vaccine effectiveness, and that lower vaccine effectiveness persists out over time. And that compares to the longer intervals where the vaccine effectiveness is higher, and that persists as well. So on the next slide, another example of this. This is from Kwong et al. From Ontario. And here they looked at in various parts of the outbreak, but we'll focus on the Delta wave. They're looking again at the vaccine effectiveness depending on the interval between the first and second dose. So in the red, you see people who've had a short interval, 2 to less than 5 weeks, and compared to the yellow and the blue, which are longer intervals. And you see the vaccine effectiveness as you go out over time from that second dose. And again, what you're seeing is that the vaccine effectiveness is lower if the interval is shorter and higher if the interval is longer, and that persists out over time. Not as big a difference in this study as in the previous study, but still that same, about a 5% difference that you're seeing persists out over time. So on the next slide, the summary for this portion of our journey to the extended interval, we see that the one dose provides good protection against symptomatic disease and infection at about 60 to 70%, and that lasts out to somewhere between 8 and 10 weeks. The protection for serious infection is higher, about 80% or more, compared to protection against infection, so better protection against serious disease. And we also see that once you've gotten the second dose, the interval with the longer interval in the primary series results in a higher antibody response, and that higher antibody response also translates to somewhat higher vaccine effectiveness. So the next slide, please. So as Matthew mentioned, we've had some varying intervals over the time, but what we see here is data on fully vaccinated people out to mid-August. And what we could see as in the Canadian population on the left who have been fully vaccinated, about 52% of them ended up with an interval that was between 50 and 77 days. And very few, only 4%, had a shorter interval of 28 days or less. This varied a bit depending on our provinces and territories. Particularly notable in the territories, our 3 territories are smaller and northern, and they received a higher allocation of doses originally, so they used a shorter interval between their first and second dose, whereas the rest of our provinces that are shown here, they had a range of intervals for their population over time. So on the next slide, what we didn't expect was that there would also be a benefit from this prolonged interval based on safety. So that was not anything that we knew, and as Matthew said, that sort of emerged. So when the safety signal with regard to myocarditis and pericarditis with the mRNA vaccines was first identified, our colleagues in Ontario, as well as nationally, we began to look to see if the difference in the interval might impact the rate of myocarditis and pericarditis. So here I'm going to present a study by Buchan et al. Done in Ontario that looks at myocarditis and pericarditis rates based on vaccine product, schedule, and interval using a 7-day risk period between vaccination and the onset of myocarditis and pericarditis, and also using the Brighton collaboration levels 1 to 3. So in this study, they showed that the reported rates of myocarditis and pericarditis were higher after the second dose of an mRNA vaccine than after the first, which we've seen in a number of other studies. And this was particularly for individuals who received Moderna as their second dose. The highest reporting rate was for myocarditis and pericarditis in the males 18 to 24 years of age following Moderna as their second dose. And when we looked at that age group, the 18 to 24-year-old males, Moderna had a 5 times higher rate of myocarditis and pericarditis compared to Pfizer after the second dose. And a really interesting finding of this study was that for both vaccines, the longer interval resulted in lower myocarditis rates, whereas the shorter interval had higher myocarditis and pericarditis rates. And we'll show that a little bit more in the slide that follows. As well, the study showed that among individuals who received a heterologous schedule with Moderna as their second dose, so Pfizer as their first dose, Moderna as their second dose, the rates of myocarditis and pericarditis were higher than those who received a heterologous schedule, so who received either Pfizer or Moderna. So in conclusion, this study, in addition to showing that the age and sex risks that we know about with regard to myocarditis and pericarditis, this study also shows that vaccine product and vaccine schedule and interval may also have an impact on the rates of myocarditis and pericarditis. So as well, our national passive surveillance system, which is called CAFIS, has also been looking at this data, particularly the interval data, and that CAFIS data will contain Ontario data as well as information from our other provinces and territories. And in that CAFIS analysis, they have also found that the interval makes a difference with regard to your myocarditis and pericarditis rates. So being shorter interval, higher rates, longer interval, lower rates of myocarditis and pericarditis. So just to explore the Buchan et al. Study just a little bit more on the next slide, and to highlight some of the points that are made. So again, this is a 7-day risk period. Overall in the study, there was 297 cases of myocarditis and pericarditis. This, what we're showing here, is a sub-analysis of 202 cases from June onwards who had received 2 doses. So the data is stratified by the schedule that was received. So the first 3 bars are 2 doses of Moderna. The next 3 bars, 2 doses of Pfizer. Following that, Moderna followed by Pfizer in a heterologous schedule, and then the reverse heterologous schedule of Pfizer followed by Moderna. And within each schedule, you can see the interval between the first and second dose going from 30 days or less out to 56 days or more. So the first thing you note from this graph is the heterologous schedule, Pfizer followed by Moderna, having a higher rate of myocarditis than the other schedules. And as well, what's notable in this graph is the difference in myocarditis rates between the shorter interval and the longer interval. So for both the homologous Moderna schedule and the homologous Pfizer schedule, comparing a shorter interval of 30 days or less to a longer interval of 56 days or more, there is a 5-fold or more higher rate of myocarditis with the shorter interval compared to the longer interval. So with that, the next slide is just the concluding slide. So here what we're showing is that overall in Canada, we're seeing the same risk profile with regard to younger males after the second dose being at increased risk. We're also noting that myocarditis risk is higher after Moderna for the second dose, particularly with the heterologous schedule as well, but particularly noting that the shorter interval seems to result in a higher rate of myocarditis and pericarditis compared to a lower rate with a longer interval. And some references are provided here. And with that, I will pass it back to Matthew.
Thanks, Bryna. And on the next slide, there are just some acknowledgements of those who helped prepare the presentation. And next slide, please. Deep acknowledgements, of course, to the committee membership themselves, who have labored tirelessly over this advice over the last 2 years. And it's been quite challenging from a communications perspective at times. Whenever going off label, of course, there's always a bit of a communications challenge, and they've weathered it very well. And next slide, please. Then also the affiliated working groups. I think there are 1 or 2 more acknowledgement slides, but yeah, great. The high consequence infectious disease working group and also the vaccine safety working group under NACI, similar to the VAST working group here at ACIP. And yeah, thanks. Happy to entertain any questions at this time.
Thank you so much, Dr. Tunis and Warshawski. This presentation is now open for questions, and I just wanted to comment that I think the silver lining of this pandemic has been that it's strengthened our collaboration with international partners such as Canada and Israel and others, and it's really created a focus on what we can share and learn together to improve the health of our respective populations. So we really, appreciate you being here and sharing this information with us. Are there any questions from committee members that they would like to ask of our Canadian colleagues? Dr. Paling.
So first of all, I want to say thank you. This is really helpful, and it's wonderful to hear how the myocarditis differed. I wanted to ask if you learned anything about the resolution of myocarditis when you look at the shorter interval versus the longer interval. Thank you.
Thanks. It's a great question. So we also have my colleague Susanna Oguneki-Cook from our surveillance group at Public Health Agency of Canada. But I'll start off. To my knowledge, we have not yet been able to ascertain any differences in severity or resolution based on interval. But Susanna, I'll just turn to you to confirm if that's correct.
Thank you, Matthew. You are in fact correct. This is an area of active interest, and we are working with some external partners to put in place some outcome monitoring studies that will help us to look in more details. But the data we get within surveillance does not have that ongoing monitoring components to give us that richness of information at this time. Thank you.
Thank you. Dr. Daly?
Yeah, thanks so much for the presentation and for the collaboration, as Dr. Lee said. So do you have any sense about whether the individuals who got a shorter interval were different in any sort of systematic way from the individuals who received doses at a longer interval? Thank you.
Yeah, so that another great question. I mean, in broad strokes, as Brenna showed in one of her slides, we did see a difference in terms of our territorial populations where there was more complete allocation pushed to those territories early on that allowed shorter intervals before the sort of preference towards extended intervals was implemented. So there are some distributions across the country where we do see shorter intervals dominantly. We also have, I think, if you can flip forward to maybe one or two slides, like in the supplementals here, there's also an age-based one. Next slide, please. This also shows interval by age group, but I'll defer to Susanna also on how those have been controlled for in the myocarditis analyses. Susanna, can you comment?
Yeah, that is an interesting question, and it is a tough one, an analysis that is complicated, as you said, because as you see from this slide, the dose interval does have some like an age component to it, because that's how the vaccine rollout went. We use an age-based component to it, and we, in the surveillance data, we don't necessarily have that depth of clinical information to be able to really dig deep into the clinical presentations by age. We did see, as mentioned earlier, we did see that there, overall we had a shorter interval than the territories. However, that's such a small population, we didn't have enough cases to be able to really take a look and differentiate between what the pattern of myocarditis was for that group compared to the other populations. So we really are looking to this study that I mentioned that we're organizing to be able to really dig deeper into some of these aspects that you've asked about. Thank you.
Thank you. Dr. Sanchez.
I want to thank you as well, because really not only interesting, but really important data, and thank you for sharing it with us. I mean, I think first of all, with the availability of the vaccines and the fact that we wanted to achieve as high efficacy as possible with the 2-dose, I think that, and the studies that were done with 3 weeks and 4 weeks, I think, we certainly wanted to make sure that as much of the population and as opportune time as, in a timely fashion, that, we recommended those intervals. And certainly that may change with however the pandemic goes on. But I think it does have some important implications here. And first of all, it's really interesting with that the Moderna booster after the Pfizer was associated with more myocarditis. So maybe that we should be, at least in the highest risk groups, the males, the younger males, that we should be maybe recommending the Pfizer, a preference to Pfizer versus Moderna. And then it also talks about pathogenesis, because the longer interval was associated with higher geometric mean titers, but less myocarditis. And so maybe it's more of a, I don't know, it's maybe, Moderna certainly is a higher dose than the Pfizer. And maybe it's not just all some immune antibody mediated process. But no, thank you for the data. I think it really may impact our ultimate recommendations, because we're trying to get that booster dose closer. Maybe that's not the optimal thing that we should be doing. Thank you.
Thank you, Dr. Sanchez. Stinchfield.
Hello, Patsy Stinchfield, Nurse Practitioner Association. Thank you, Canadian neighbors, for this great presentation. I think about hepatitis B vaccine series and longer intervals that we worry about losing people for follow-up. Do you see any data where you're not having completion of the series as the intervals are lengthened? Any concerns about that?
That's an excellent question. I haven't seen our coverage group be able to tease that apart. Those that are receiving incomplete series, whether there was a sort of temporal association between them actually not being able to receive the second dose for a number of months, like early on in the rollout, for example, and then giving up. Is I think what you're kind of talking about. Bryna, are you aware of anything like that we've been able to tease apart in Canada?
No, I'm not aware of anything. I think it's mostly been driven by the context of the outbreak. So if the outbreak is settling down, people maybe are a bit less enthusiastic about their vaccines, but as the outbreak ramps up, they become more. So I think it may be more related to what's happening with the outbreak, but to reemphasize the importance of getting the second dose and the booster. So I don't think we've seen anything, though, that how the interval would impact that.
Can I add, this is Susanna, just that one of the things we've been very fortunate to see in Canada is we have high coverage overall. So our latest information is showing that we have almost 83% of the population that is fully vaccinated. So I think Omicron had a lot to do with that, of pushing the folks who may have, if we had any stragglers, Omicron seemed to have really created impetus for people to go and complete their schedules and then to subsequently show up for boosters.
Great, thank you.
Thank you. I'm looking for other questions. While we're waiting, I actually have one question, or one comment, one question. So to me, the data that you presented today are fairly convincing that an extended interval is not only potentially safer from a myocarditis standpoint, but also potentially more effective. And I guess the question I have for you is, do you think it is also more durable? So have you noticed in your provinces where they have had shorter vaccination intervals, whether or not the need for a booster is greater than in your areas where there are extended vaccination intervals? And the reason I ask this is because there's not only the immediate question around this series, but the potential question about the need for future boosters, and can we mitigate the need for ongoing repeated boosters, because every time there's a booster, we just, it carries both benefits and risks. So the cumulative benefit risk profile over time does change.
Yeah, that's such an excellent point, and it's one that we've been very preoccupied as well. I think that like yourselves, many of us are trying to compare notes with other countries throughout the pandemic, and we've of course been closely watching what happens in Israel, understanding that Israel has been using the authorized interval. Like everything has been short and quick as things rolled out there, which I suppose has also been the case largely in the U.S. And I think there is a sense that the booster programs in Canada were actually held off a little bit longer than in other countries, and part of our understanding is that was due to the longer durability of due to those longer intervals, but it's a little bit confounded because those who got longer intervals over the summer also had a shorter time since their second dose. So if you're worrying about time since second dose, that we were at a bit of an advantage in that respect going into the fall compared to some other countries. And then that was maybe compounded by also the longer intervals affording some more durable immunity. And then there has also been some research around the breadth of response as well, that longer time between exposures, whether vaccine or actual viral exposures in this case, could actually allow that affinity maturation to improve also the breadth of response against variants. So that's part of the rationale that we see NACI articulating in some of their statements, is the durability, higher effectiveness, and also possibly the breadth against variants that's been of interest to the committee. And we've seen not only with the primary series, but the committee continues to recommend a 6-month interval for boosters, although many jurisdictions have gone a little bit shorter on that. Brian, I'll just ask you to weigh in if you can call to mind any of the evidence that actually does speak to the longer intervals yielding better durability over time as well.
Yeah, I mean, I think we were seeing it, as you were saying, Matthew, out into the Delta period. So we were still having fairly high vaccine effectiveness in Canada as we headed into the Delta period, even against infection as well as against severe disease, because I think that our interval was longer. There were some populations where we did use a shorter interval, particularly at the beginning of our outbreak, where we were vaccinating older adults in long-term care facilities. And in that population where we saw the shorter interval being used, there was a more rapid decline in the vaccine effectiveness, whereas in the general population, we saw the sustained higher level of protection against both infection and severe disease well into that Delta period. So as Matthew said, we didn't need the booster as quickly because we were still seeing that sustained protection in our Canadian data.
The other population are healthcare workers that dominantly received a short interval, except I think in the province of Quebec, there was a longer interval used, but dominantly in Canada, healthcare workers got a short interval. And similarly, they were prioritized early on for the boosters because there was concern about that waning protection that was occurring earlier there, potentially.
Thank you. Dr. Sanchez?
Yes, thanks. Just another comment. What vaccines are you using in Canada? Are you using the AstraZeneca or any of the others, or are these are the messenger RNA ones the predominant ones? And do you have any preferential use of one versus the other, especially as it relates to the myocarditis? Have you made any recommendations based on your data?
Yeah, thanks. So it's very dominantly been an mRNA program in Canada. There was AstraZeneca that was also used in the winter spring of 2021, but it accounts for a very small proportion. I think it's Brenda might have the numbers at her fingertips, but it's somewhere around the 5% range was viral vector, and then the vast majority has been mRNA. Also, Janssen was recently, supply was made available to some Canadian provinces and territories in the past few months, but it's a relatively small amount. So there's been a very small amount of viral vector. The program has been over 90%, I think, mRNA, it's really dominantly an mRNA program. And Brenda, I'm going to ask you to weigh in at the end, but I'll just answer the other part as well about the preferential recommendation. So since the spring of 2021, or maybe even the winter, NACI has been preferentially recommending mRNA over viral vector vaccines. And then as the TTS or VIT emerged, that strengthened the position even further for the committee. So they, similar to ACIP, who have now also recommended preferentially mRNA over viral vectors, that position has been long-standing in Canada, so which I think was part of what pushed towards the dominantly mRNA program. And then within the mRNA category, based on the myocarditis signals that have been observed, NACI actually has preferentially recommended Pfizer over Moderna for those 12 to 29 years of age for both primary series and also for booster dose. So there is there's a preference for mRNA over viral vector And then within that age cohort of 12 to 29, there's a Pfizer preference over Moderna, in addition to the extended intervals that have been implemented. And Brianna, do you have the numbers on the program breakdown?
I don't have them right here, Matthew, but I believe you're fairly right. It's around 4% or something that were AstraZeneca. And the one thing that we do have is some mixed schedules where we had people who started with AstraZeneca and finished with an mRNA, and also, as mentioned, the mixed mRNA schedule, so heterologous. Most of the heterologous is Pfizer with the first dose and Moderna with the second dose. So we have a fair number of people, I don't know the exact number, somewhere around 12% or something like that, who have received that heterologous schedule, either heterologous AstraZeneca with an mRNA or heterologous mRNA schedules.
And I would just add, I think that one, on the theme of this question, something that's been, that we've been trying to communicate in Canada is that the strength of this surveillance system and of the research that's been able to go on has allowed us in Canada, and I think internationally in many cases, to take these very safe vaccines that are obviously authorized, and then over time we can even improve on that as we can target populations where they can even be used to make them more safe than even originally understood. So that's generally been, I think, quite a great story out of this. So through the surveillance and the research, we've been able to iterate and refine the program and actually improve the safety of already safe vaccines. So that's been a nice lesson learned in the pandemic. It can be a challenging communication message at times as things evolve, but we're quite pleased that they've been able to evolve in a positive direction to iterate on over time.
Thank you, Dr. Tunis, and thank you to your colleagues. I would love to end on that statement because we very much agree that safety is paramount to all of us, and we continue to have a focus on that to ensure that we can deliver our vaccination programs and protect the population. We will move on to the next presentation now, which is the Vaccine Safety Data Link. Our colleague, Dr. Nikki Klein from Kaiser Permanente, Northern California, who will be speaking about myocarditis after Moderna and Pfizer-BioNTech COVID-19 vaccines. Dr. Klein.
All right, great. Thank you. And good afternoon. And thanks for the opportunity to talk about myocarditis and the Vaccine Safety Data Link. Next slide, please. So today, as an overview, today I'll be giving a brief review of the rapid cycle analyses monitoring COVID-19 vaccine safety conducted by the Vaccine Safety Data Link, and then really focus on myocarditis and pericarditis during the days 0 to 7 after mRNA vaccination. And here, I'll be discussing the risk after each vaccine compared to the risk among comparators who were 22 to 42 days after vaccination, and then also of direct head-to-head comparisons of the Moderna vaccine versus the Pfizer vaccine during the days 0 to 7 after vaccination. Next slide. This is a slide I think everyone here has seen numerous times, but this is the Vaccine Safety Data Link. It was established in 1990, and it's a collaboration between the CDC and 9 integrated healthcare delivery organizations shown on the map. Next slide. So you've also heard before, we're monitoring the safety in the Vaccine Safety Data Link of COVID-19 vaccines weekly using pre-specified outcomes of interest. And then we're also describing the uptake of COVID-19 vaccines over time among Vaccine Safety Data Link members. We've been doing the surveillance since December 2020. Next slide. So these are all the pre-specified outcomes that we are monitoring weekly. You can see in gray, myocarditis, pericarditis, which will be the topic of today's conversation, and I will be focusing exclusively on that. Next slide. So just a brief reminder, we initially were using the codes on the left for our early surveillance, but based on some feedback and discussions internally with the VSC investigators, we expanded our ICD code list within the past few months, and we have now expanded to include the additional ICD codes listed in red. So those, all of the data and analysis that we'll be showing you are based on all of these codes on the right-hand side. Next slide. So here is the vaccine uptake and primary analysis, and this is data through January 15th, 2022. Next slide. In the VSC, administered nearly 15 million total doses of COVID-19 vaccine, and you can see that 73% of the age-eligible population is fully vaccinated. Next slide. And as you've heard before, the vast majority of vaccines that have been administered in the VSD are the mRNA vaccines. A little bit more the Pfizer, BioNTech than the Moderna, but substantial numbers of each with very few Janssen vaccines administered. Next slide. So for the analytic strategy, we compared the number of outcomes observed in the risk interval, which was 1 to 21 days after COVID-19 vaccine, were compared to the number expected. And let's just go to the next slide. So here's a slide that I think you saw earlier today, as well as a number in previous presentations as well, but I'll just briefly remind you. So this is the analytic strategy. So, and the example is myocarditis, which is what we'll be talking about today. So on each calendar day that an outcome occurred in a vaccinee, and the example is on June 3rd, we compared vaccinees in their risk interval with similar vaccinees who are in their comparison interval on days 22 to 42 after vaccination. You can see on the bottom half of the graph, the picture. And by similar, in terms of comparators, we mean that the comparators were in the same age group and of the same sex, race, and at the same VSD site on that day on June 3rd. And these analyses apply to all of the, what we call the vaccinated concurrent comparator analysis, which I'll be showing you. Next slide. So for the rest of the presentation, we'll be focusing just on a subgroup of 18 to 39-year-olds, and these are with verified myocarditis and pericarditis cases after mRNA vaccines. And again, this is data through January 15th, 2022. Next slide. So here you can see the doses that have been administered through that date in 18 to 39-year-olds by week. And you can see in red are the Pfizer doses, and in blue are the Moderna doses. And they were mostly occurred in this age group over similar time periods. Not exactly the same, but very similar, and with a similar, a little bit more Pfizer than Moderna, but robust uptake of both. Next slide. Now here, these just shows the days, the intervals between doses 1 and 2 amongst 18 to 39-year-olds. And now this is in the entire VSD population. As you can see that for Pfizer, almost all the doses were given 21 days between dose 1 and dose 2, with a little bit of variation on either side of day 21, but not much. And then similarly for Moderna, nearly all the doses were given on day 28, with some doses given a couple days later or earlier than that, but not much variation between each manufacturer. Next slide. So for our chart review summary, so for myocarditis and pericarditis, we perform chart reviews for all cases that we identify, and we've completed 297 cases through January 15th for all cases, and we still have a few that are still pending, and those are all under 18 years of age. We are chart reviewing all cases amongst 5 to 39-year-olds, and we identify the case anytime post-vaccination. So after initial chart review, they're adjudicated either by an infectious disease clinician or a cardiologist, and they confirm that the case is incident following vaccination, that they meet the CDC case definition, and those include myocarditis, pericarditis, or myopericarditis, and then evaluate the level of certainty for myocarditis. So with this adjudication, we've now verified 213 out of 297, or 71% of myocarditis and pericarditis cases. And 79 of those have been verified amongst 18 to 39-year-olds, and those all with the onset of 0 to 7 day risk interval. And those the risk interval that we will be, I'll be focusing on for the rest of the analyses. Based on then that 0 to 7 is based on our earlier findings of significant clustering of cases in the first week after vaccination. Next slide. So here is the vaccinated concurrent analyses results. So this is again comparing the myocarditis and pericarditis in the 0 to 7 day risk interval among 18 to 39-year-olds versus cases in the comparison interval, and this is the vaccinated concurrent comparator on the same calendar day. What you can see here is that all the adjusted rate ratios are elevated for all vaccines after both doses, or dose 1 or dose 2. But I've focused here on dose 2 after both Pfizer and Moderna. And you can see after Pfizer, we have an adjusted rate ratio of 14.3 and the excess cases of 22.4. And Moderna after dose 2, you can see a rate ratio of 18.75. It's highly statistically significant with an excess case of 31.2. Now, these are the same results as you saw earlier today by Dr. Shimabukuro in terms of the Moderna dose 2. Now, what this suggests is that you have indirectly, because they're not being directly compared, Pfizer and Moderna are not being directly compared here, but they're being indirectly compared. If you look at the numbers, you can see that the rate ratio after Moderna appears to be higher than after Pfizer, but that they're both very elevated. And if you actually look at the excess cases in the risk period, you can see that there's roughly, do a rough comparison of 31.2 versus 22.4. But again, these are indirect calculations of indirect comparisons. Next slide. So here is just in terms of our, what is shown in the charts for our verified myocarditis and pericarditis cases 0 to 7 days after any dose. And this is after either mRNA vaccine. And this is just showing you that based on our chart view, this is cases only, that we're not seeing any obvious differences in the clinical cases from the chart between the 18 to 39-year-old Pfizer or Moderna cases of myocarditis and pericarditis. Next slide. Now, but the question is, based on the analysis that I showed you 2 slides back about the vaccinated concurrent comparators, is there a difference in the risk of myocarditis and pericarditis between the mRNA vaccines? And so as I mentioned, that the vaccinated concurrent comparators indicate that both vaccines are associated with increased risk of myocarditis and pericarditis in 18 to 39-year-olds. And that it's indirect, and that indirect concurrent comparators indirectly suggest that Moderna may be associated with more risk. So we wanted to directly test whether the risk of myocarditis and pericarditis after Moderna differs from that after Pfizer. And so we conducted head-to-head comparisons among 18 to 39-year-olds. Next slide. So this is also data through January 15th, Moderna versus Pfizer. Next slide. So here is the days between dose 1 and dose 2, only for the verified cases. For myocarditis and pericarditis in the 0 to 7 day risk interval for 18 to 39-year-olds. And what you can see here is that similar to what I showed you in the entire VSD population in this age group, that the interval between doses 1 and dose 2 was pretty consistent with what we saw in the overall population. It's centered around 21 days for Pfizer and around 28 days for Moderna. Next slide. So here you can see this is the symptom onset of the verified cases in the 18 to 39-year-old Pfizer vaccine product. Now these are focusing, it's a busy slide, but if you focus on the line, the red line and the blue line, and those lines represent the rates per 1 million person days of verified cases after Pfizer in red and after Moderna in blue. What you can see is that there's a very strong clustering just visually of both of cases after both vaccines. In the first week after vaccination. And when we actually do temporal clustering scan statistics, you can see that the clustering is highly statistically significant in the first 3 to 5 days after both, after Moderna, and 0 to 2 up to 0 to 4 days after Pfizer. What you can also see is that by eye, the line of Moderna line appears to be a little bit higher than after the red line after the red line with representing the rate after Pfizer. But there's a difference, there's a distance between those 2 lines in the first week after vaccination. But to directly test that, next slide, we directly compared the intervals, and these groups were comprised of individuals who are inside the risk interval, which is days 0 to 7 post-vaccination, and the individuals were of the same age group, sex, race, ethnicity, and from the same VSD site, and on the calendar day when an mRNA vaccine had a myocarditis or pericarditis case. So we estimated rate ratios of 95% confidence intervals, and by that is the rate post-Moderna divided by the rate post-Pfizer. And then we tested the null hypothesis that the rate of myocarditis and pericarditis after vaccination did not differ between the Moderna and Pfizer. Next slide. Now you can see that that is just shown graphically below I won't go through this in detail, I've done it before, but you can see that on June 28th, we would take that as an example for a case of myocarditis, and we compare after Moderna vaccinations on June 28th with similar comparators as shown here on the people in their 0 to 7 risk interval after Pfizer. Next slide. So here is the updated results of myocarditis, pericarditis in the 18 to 39-year-olds in the 0 to 7 day risk interval, Moderna versus Pfizer. What you can see here is that when you, for following either dose with both sexes, we have an elevated rate ratio of 1.61 that is statistically significant, and excess cases of 80 cases per 1 million doses. Now, the other analyses were trended similarly, although none of the other analyses that's shown here met statistical significance. But focusing, I think, most if you look at dose 2, I think that's probably the most relevant one of comparing Moderna versus Pfizer, which is analogous to what I showed you earlier. You see excess cases of 10.7 excess cases is not highlighted in red, but you can see that on the all doses, 10.7 excess cases. Next slide. Now, when we do analyses of which pericarditis is excluded, again, you can see that the adjusted rate ratios all are similar in terms of the level of increased point estimates, although none of these analyses meet statistical significance. Next slide. And finally, this is a summary of myocarditis and pericarditis at day 0 to 7 after dose 2. And this is just limited to dose 2 in the 18 to 39-year-olds. And this is really just a summary of some of these analyses, which are in the earlier slides, really focusing on those dose 2 analysis. And you can see then, and now again, the analysis that includes pericarditis includes both sexes. You have an excess cases of 10.7. Although, again, none of these analyses met statistical significance. Next slide. So to summarize, among 18 to 39-year-olds, both mRNA vaccines were associated with an increased risk of myocarditis and pericarditis in the 0 to 7 days post-vaccination, particularly after dose 2. So we estimated a 22.4 excess cases per million doses after Pfizer and 31.2 excess cases per million second doses after Moderna. Among 18 to 39-year-olds, there are no noticeable clinical differences between cases after Moderna and those after Pfizer. Direct head-to-head comparisons provided evidence that the risk of myocarditis and pericarditis may be higher after Moderna than after Pfizer. And when we compare Moderna versus Pfizer, we estimated that Moderna was associated with an additional 10.7 cases of myocarditis and pericarditis per million second doses. And just a word of that, if you, that 10.7 is really, we think about it as a better adjusted excess case estimate, better adjusted than the 22.4 or 31.2 minus 22.4. That's measuring similar analyses, but these are better adjusted when you do the direct head-to-head. So both mRNA vaccines were associated with an increased risk of myocarditis and pericarditis for individuals age 18 to 39-year-olds, which I think is really what I think with the message that we really want to convey is that they're both associated with increased risk. And next slide. And again, as always, I'd really just like to acknowledge team at Northern California Kaiser Permanente, the CDC, and all the folks in the Immunization Safety Office and Marshfield Clinic, and then all the VSD sites. Thank you.
Thank you, Dr. Klein. This presentation is now open for questions. I don't see any hands raised from our committee members. I'll ask if there are any liaisons who have any questions of Dr. Klein. Dr. Zimmerman?
Do we have any data from your study on the background rate differences, if any, in your populations? Over.
Well, if you go to our background rate, which is what we use for our comparison of excess cases, are derived from our population from the comparison interval. I think Dr. I'm sure Bakuro mentioned that earlier, but if you go to slide 45, I believe, this is in the background slides. Yeah, so here you can see that these are the incidence rates per person years in the risk interval and the comparison interval. And those comparison intervals are the background rates which we're using to calculate our excess cases for our vaccinated concurrent comparator analyses. If that answers your question.
I'm sorry, I should have been clearer. For background rates from COVID disease-induced myocarditis.
Oh, I'm sorry. No, we don't have that as part of this study.
Thank you. Dr. Duchin.
Thank you. A quick question. Sorry if I missed this. I know that your primary analysis was looking at the 7-day risk window after the second dose, but you also included data on the risk window through 21 days and then showed us cases of myocarditis out past 7 weeks. And I'm wondering if those cases were also reviewed or in any way adjudicated to determine whether you think they might be vaccine associated or not.
Yeah, that's a great question. So if you go to slide 36, please. So we review all cases after vaccination of myocarditis, pericarditis, and adjudicate them. And if you look at slide, if you could go to slide 36, please. This is our primary analysis of our 21-day risk interval. So you can see here that our adjusted rate ratios, while they're not, they're numerically lower than I was showing you for the 0 to 7-day interval. What is actually quite remarkable is this, it's not highlighted in red, but actually if you look at dose 2 after both Pfizer and Moderna, you see the same excess cases for the risk interval per 1 million doses of 22.6 and 31.3. And so what that tells us is that actually all the excess risk is in the 0 to 7-day interval because it's the same as the excess cases that we see in the 0 to 7-day. But we do look at all the cases and we do confirm all the cases in both the risk interval and the comparison interval.
Thank you.
Thank you. I don't see any additional hands raised at the moment. So what I'd like to do is to move on to the next presenter. Thank you, Dr. Klein, as always, for monitoring vaccine safety on behalf of the country and also coming to present and share this data at our ACIP meeting. Ms. Danielle Mulia will be presenting on myocarditis and COVID-19 vaccine intervals, international data and policies. Please go ahead.
Thank you so much. Next slide. Today's presentation will examine international data and policies on preferential recommendations of an mRNA vaccine product or extended primary series interval as they relate to myocarditis and/or pericarditis. I will review data on the risk of myocarditis by mRNA vaccine product, focusing on the highest risk group, younger males post-second dose. Next, I will review data on an extended primary series interval, specifically how that relates to myocarditis risk and vaccine effectiveness. And finally, I will present international policies related to preferential recommendations or extended primary series intervals. Throughout this presentation, myocarditis and/or pericarditis will be generally referred to as myocarditis unless a specific study is being referenced. Next slide. Next slide. First, to contextualize this presentation, a quick refresh of U.S. findings. As we heard earlier today, in the Vaccine Adverse Event Monitoring System, or VAERS, among males ages 18 to 24 years, the observed myocarditis reporting rate within a 7-day risk interval after a second dose of Moderna was 40 per million doses. And in the Vaccine Safety Data Link, among males 18 to 39 years, the rate for myocarditis in the 7 days after a Moderna vaccine was 1.5 times the rate for the 7 days after a Pfizer vaccine. However, the adjusted rate ratio of 1.5 was not statistically significant. Next slide. Next, to review key findings from Canada we heard earlier today. In a study of passive and enhanced surveillance, the myocarditis and or pericarditis reporting rate among males 18 to 29 years in the 7 days after a second dose of Moderna vaccine was 140 per million doses, which was almost 5 times higher than the Pfizer reporting rate of 25 per million doses. In Ontario, during the period of enhanced passive surveillance, among males 18 to 24 years, the myocarditis and or pericarditis reporting rate after a second dose of Moderna was over 5 times the Pfizer reporting rate. The reporting rates included all reports during the length of the study. Next slide. The UK's Yellow Card scheme is a national passive and active surveillance system. Among all persons ages 18 to 29 years, the myocarditis and pericarditis reporting rate after a second dose of Moderna was 71 per million doses, roughly 2.5 times higher than the Pfizer reporting rate of 24 per million doses. In a self-controlled case series of myocarditis hospitalizations in the UK, among males younger than 40 years, after a second dose of Moderna, there were 101 additional events of myocarditis per million doses compared to 12 additional events of myocarditis per million doses of Pfizer. Next slide. The Nordic collaboration, which includes Denmark, Finland, Norway, and Sweden, presented the results of their study of all 23 million residents ages 12 years and older to the Vaccine Safety Technical Advisory Work Group, or VAST, on January 10th. While these data are not publicly available, within a 7-day risk period, the rate ratio for myocarditis after either dose of Moderna vaccine versus an unvaccinated comparator was higher than Pfizer. The highest rate ratios observed were among those receiving a second dose of Moderna in a heterologous mRNA primary series. Next slide. Next, we have a retrospective cohort of all 5 million residents of Denmark, ages 12 years and older. The case definition is hospital diagnosis of myocarditis or pericarditis, increased troponin levels, and a hospital stay lasting more than 24 hours within a 28-day risk period. Analysis was done using a Cox proportional hazard model with covariates for age, sex, vaccine priority group, season, and clinical comorbidities. Next slide. Here we can see the absolute rate of myocarditis per 100,000 doses and the adjusted hazard ratio with an unvaccinated comparator for those ages 12 to 39 years and by gender after any dose. The rates were about 3-fold to 4-fold higher for those vaccinated with Moderna compared to Pfizer. In a post-hoc analysis of males ages 12 to 39 years, the rate of myocarditis was 9.4 per 100,000, or 94 per million post-dose 2 of Moderna. Using an unvaccinated comparator, the adjusted hazard ratio of myocarditis was 9.8 for Moderna and 1.5 for Pfizer. Next slide. And finally, looking to France and Germany. In both national adverse event surveillance systems, the highest reporting rates of myocarditis were among young males. In Germany, among males ages 18 to 29 years, the myocarditis and pericarditis reporting rate after any dose of Moderna was 117 per million doses, roughly 2.5 times higher than that of Pfizer. And in France, among males ages 18 to 24 years, the myocarditis reporting rate after a second dose of Moderna was 139 per million doses, roughly 3 times higher than that of Pfizer. Next slide. Here we summarize the myocarditis rate ratios comparing Moderna to Pfizer by country, subpopulation, and dose number. Looking across the studies, we can see a 1.5 to 5-fold increase in myocarditis after a second dose of Moderna vaccine compared to a second dose of Pfizer among younger males. Direct comparisons of rate ratio should be interpreted with caution due to differences in subpopulation, study design and modeling, and national setting and implementation factors. Next slide. In summary, global data suggests that the risk of myocarditis may be higher for Moderna than Pfizer vaccine. There are limitations to this review. Absolute rates are not readily comparable due to differences in case definition and risk period, subpopulation, case ascertainment, calendar time, and vaccine implementation factors, including extended primary series intervals. Finally, a limited number of geographic locations are administering both Moderna and Pfizer and had data available. Next slide. Turning now to the risk of myocarditis by primary series interval, or the time between the first and second doses. Next slide. We return to the work of Buchan and colleagues out of Ontario, examining rates of myocarditis by dosing intervals of less than 4 weeks, 5 to 7 weeks, and greater than 8 weeks among adults ages 18 years and older. Next slide. This figure shows rates per million doses among males ages 18 to 24 years by vaccine schedule and dosing interval. Across the 3 schedules of primary series, rates of myocarditis decreased as the intervals between dose 1 and dose 2 lengthened. Within each vaccine schedule, the lowest rates of myocarditis were observed among those with the longest time between dose 1 and dose 2. The highest rate was observed among persons who received Pfizer for their first dose and Moderna for their second dose, within the shortest interval, 4 weeks or less between doses. Next slide. In summary, limited data suggests the rates of myocarditis may be lower with an extended interval between dose 1 and dose 2 of a primary series. These observed rates were observed both with Moderna and Pfizer vaccine. Next slide. Looking now to data on vaccine effectiveness with an extended primary series interval. Next slide. Results from this test-negative case control study from May to October 2021 among 1.2 million community-dwelling adults aged 18 years and older in British Columbia and Quebec were presented earlier today by Canada. Next slide. Here we can see adjusted vaccine effectiveness estimates against SARS-CoV-2 infection in green and hospitalization in blue by dosing interval in weeks. Results from British Columbia are shown on the left and Quebec on the right. mRNA vaccine effectiveness against SARS-CoV-2 infection and hospitalization was 5 to 10% higher with an extended interval of 7 to 8 weeks compared to a standard interval of 3 to 4 weeks. Increases in vaccine effectiveness can be observed to level off at around the 7 to 8 week interval. The overall vaccine effectiveness against hospitalization and infection for a 2-dose mRNA series with an extending dosing interval of 7 weeks or greater was 94 to 97% for hospitalization and 89 to 91% for infection. Next slide. And now turning to England. Here we have a test-negative case control study of vaccine effectiveness from October 2020 to June 2021 among adults aged 50 and older attending community testing. Next slide. In this figure, we see age group across the top and interval between dose 1 and dose 2 in weeks across the bottom. Across all age groups, starting at age 50, estimated Pfizer vaccine effectiveness against SARS-CoV-2 infection was higher with extended intervals, those greater than 6 weeks, compared to the standard 3 to 4 week interval. Next slide. Looking now at immunogenicity with an extended primary series interval. In a study by Payne and colleagues out of the UK that examined SARS-CoV-2 infection-naive persons, serological responses were higher after an extending dosing interval of 6 to 14 weeks compared to a standard interval of 3 to 4 weeks. Among persons with an extended interval, there were higher antibody and B cell responses as well as sustained B and T cell responses compared to a standard interval. An extended interval may promote efficient T cell expansion and long-term memory cell persistence. 3 additional studies found that neutralizing antibody titers were higher following an extended dosing interval of 6 to 14 weeks with an mRNA vaccine compared to a standard interval of 3 to 4 weeks. Next slide. In summary, global data suggests that an extended primary series interval may improve immunogenicity and vaccine effectiveness. Neutralizing antibody titers were higher following an extended dosing interval of 6 to 14 weeks with an mRNA vaccine compared to a standard interval of 3 to 4 weeks. Vaccine effectiveness against infection and hospitalization were higher with an extended interval of 7 to 8 weeks compared to a standard interval of 3 to 4 weeks. One limitation to note is that these studies were conducted prior to the Omicron surge, during which the absolute VE may be lower. Next slide. Turning finally to global policies. Next slide. Canada's National Advisory Committee on Immunization, or NACI, strongly recommends a complete mRNA series for all persons ages 12 years and older. Among persons ages 12 to 29 years, Pfizer is preferred for the primary series. For all mRNA primary series, the optimal interval is 8 weeks. Next slide. In the UK, there is a preferential recommendation for the use of Pfizer over Moderna in persons ages 12 to 17 years. The Joint Committee on Vaccination and Immunization has advised a minimum interval of 8 weeks between first and second doses for all persons over 18. For children and adolescents ages 12 to 17 years who are at higher risk of COVID due to underlying conditions, living accommodations, or who are contacts of immunocompromised persons, the recommended interval is 8 weeks. However, for children and adolescents that do not fall into these high-risk groups, a 12-week interval is preferred. The guidance does go on to note that in periods of high incidence or concern over a new variant, the interval can be shortened to 8 weeks. Next slide. Looking now to the Nordic countries. In Sweden, Pfizer is recommended over Moderna for persons ages 12 to 30 years. The recommended interval for both vaccines, 3 to 4 weeks. In Norway, Pfizer should be offered to persons ages 12 to 30 years. Children and adolescents ages 5 to 15 years without severe underlying conditions may receive 1 or 2 doses based on their parent's decision. Person ages 16 years and older should receive 2 doses. The recommended interval for persons ages 18 years and older is 3 to 12 weeks. For adolescents ages 16 to 18 years, the recommended interval is 8 to 12 weeks, and for children and adolescents ages 5 to 15 years with severe underlying conditions, the recommended interval is 8 to 12 weeks. However, this can be adapted down to 3 weeks based on medical assessment. Next slide. In Finland, boys and men aged 12 to 30 years are only offered Pfizer. Girls and women ages 12 and older are offered Moderna or Pfizer. The recommended interval is 6 to 12 weeks for all persons ages 5 years and older. And in Denmark, both Moderna and Pfizer vaccine are approved for persons ages 12 years and older. The primary series interval is 3 to 6 weeks, and studies have shown that the median interval between dose 1 and dose 2 is 5 weeks. Next slide. In Singapore, children and adolescents ages 18 years and younger should receive Pfizer vaccine. The recommended interval is at least 21 days. Guidance notes myocarditis risk may decrease with a longer interval, but encourages a second dose at 21 days due to Omicron. And in Taiwan, both Pfizer and Moderna vaccines are approved for persons ages 12 and older, and the recommended interval between first and second dose is at least 12 weeks. Next slide. In Australia, the recommended interval is at least 3 weeks for Pfizer or 4 weeks for Moderna, and among children ages 5 to 11 years, the recommended interval is 8 weeks. Guidance notes that the interval can be shortened in special circumstances to a minimum of 3 weeks, such as in an outbreak response, prior to the initiation of significant immunosuppression or international travel. Next slide. Finally, in France, HAS recommends persons under the age of 30 be given Pfizer over Moderna when available. The recommended interval is 6 weeks. And in Germany, the recommendation is for persons under the age of 30 to be given Pfizer over Moderna. The recommended interval is 3 to 6 weeks. Next slide. This review has a number of limitations. It was not a systematic review, and the studies presented are biased toward findings that influence national vaccine policy. Caution should be used when comparing myocarditis rates across studies as surveillance systems, case definitions and risk intervals, subpopulation age ranges, and vaccine implementation differ substantially. And finally, national vaccines policies are constantly evolving. Some policies extending the primary series interval evolved from implementation strategies to reach the most people with a first dose. Next slide. In conclusion, observational data suggests that myocarditis may be associated with receipt of Moderna mRNA vaccine in persons ages 18 to 29 years, especially in males, and shorter primary series intervals. Extended primary series intervals may improve vaccine effectiveness. And several countries have implemented policies or recommendations to lengthen the interval between doses in the primary series, which may improve vaccine effectiveness and mitigate myocarditis risk. Some have preferentially recommended use of Pfizer among males and or persons aged 30 years or younger, which may mitigate the risk of myocarditis. Next slide. I would like to thank the team that helped pull this all together, with a very special thanks to Katie Curran, without whom this would not have come together. And now I'm happy to take any questions.
Thank you so much. This presentation is now open for questions. While we're waiting for hands to be raised, I'll just thank you again for the comprehensive overview of the various policies. And much of the tension over the course of the past year for us as a committee has been to try and simplify the message and actually make it more straightforward for implementation. And this, from a global perspective, I recognize how confusing this must be going from country to country, but recognizing that everyone's trying to do the right thing, which again is to optimize health and mitigate risk. Ms. Bata.
Thank you, and thank you, Ms. Mulia, for this information. Just a quick question. In the U.S. summary of findings, you've described the reporting rate after a second dose of Moderna is 42 million, but we don't have the second dose of Pfizer. Do you have that handy?
So that was pulled from the presentation earlier from our immunization safety office colleagues. I don't have the updated number from them. Dr. Shimabukuro, are you on and want to comment on the VAERS data?
We certainly have those numbers. I just don't know if we have them accessible right now. We can get those Pfizer numbers.
Thank you.
Thank you, Dr. Sanchez.
Thank you. And it just brings up a lot of questions in my mind and issues that, as we try to refine vaccine policy and recommendations, and as you mentioned, Grace, the pursuit for safety, as well as obviously efficacy. And it seems to me that it's not just a matter of saying, Pfizer recommended over Moderna. Certainly the Pfizer has been associated from the data suggests more myocarditis. But if we really want to look at to try to even minimize the myocarditis occurrence, we're going to have to also deal with the intervals. So I think it's and trying to make a preferential recommendation, not just for the actual vaccine, but also for the interval. And I think that that this has a lot of implications, and know we haven't talked about booster here, but it's also will have implications as well in terms of the, because it seems to me that in young males, probably, I mean, I know 29, but the risk even went up to 39, less than 40, and even slightly increased in the 40 to 49, that it's not just recommending maybe, the Pfizer dose, but it's also at a longer interval in those individuals. And certainly even among those who received the first dose of Moderna, that the subsequent dose should be Pfizer. Thank you.
Thank you. And I think Dr. Oliver will take us through additional discussion and conversation. So are there any additional questions or clarifications for this presentation that is open right now? All right, well, why don't we move?
Dr. Lee, this is Tom. I can give you those Pfizer rates now. Or if
Thank you. Please
want
go ahead.
them. I'll have to talk. So as was stated, the dose, the reporting rates for Moderna in males after dose 2 in the 0 to 7 days was 40, and the corresponding 40 per million. And the corresponding rate for Pfizer was 37 per million. And then for 25 to 29-year-olds in Moderna, after dose 2, 0 to 7 days was 18.3 per million. And then for Pfizer was 11.7 per million. And after those ages, there really isn't much of a difference between the two vaccines.
Thank you, Dr. Shimabukuro. All right, well, why don't we go ahead and move on to Dr. Sarah Oliver's presentation. She'll provide a summary and the workgroup interpretation on the topic of extended intervals for mRNA COVID-19 vaccines. Dr. Oliver.
Thanks so much, and good afternoon again. Next slide. So we went through this earlier, but the policy question for the previous ACIP vote was, should vaccination with the Moderna vaccine be recommended for persons 18 and over? Again, comparing the Moderna vaccine to no vaccine. Next slide. What we want to discuss in this presentation is an additional question for discussion that, based on new and emerging data that you've heard this afternoon, should CDC consider guidance around the interval between dose 1 and 2 for mRNA COVID-19 vaccines? And again, for this discussion, we will be discussing both Moderna and the Pfizer COVID-19 vaccines. Next slide. Then just to highlight that VAST, our safety technical committee, reviewed the most recent data from 3 US safety monitoring systems, as well as data from international partners. Again, as you've heard, reported rates of myocarditis following the mRNA vaccines are higher than background, highest after dose 2 and in adolescent and young adult males. In most safety monitoring systems, the myocarditis risk is somewhat higher after the dose 2 of Moderna than dose 2 of the Pfizer vaccine. And data are limited, but emerging around the myocarditis risk following different dose 1 and dose 2 intervals. Next slide. So just summarizing what we have heard previously from the international data around myocarditis after the mRNA vaccines. Again, the risk of myocarditis was higher for Moderna than Pfizer, and again, highest after the second dose among younger males. But the rates of myocarditis were lower with an extended interval between the first and second doses of the mRNA vaccine primary series. Next slide. Then a summary of the extended primary series interval data around immunogenicity and vaccine effectiveness. An extended primary series interval may improve immunogenicity and vaccine effectiveness. That antibody responses were higher following an extended interval between the first and second doses of the mRNA vaccines compared to a standard interval. And vaccine effectiveness against infection and hospitalization were higher with an extended interval compared to a standard interval. Next slide. So now we can consider the benefit-risk balance for mRNA COVID-19 vaccines, again looking specifically in adults 18 to 39 years, but comparing vaccine-specific benefits to vaccine-specific harms with the mRNA vaccines. Next slide. The benefit-risk assessment uses the same methods as those previously described, but now includes vaccine-specific VE and myocarditis inputs for both the Moderna and Pfizer vaccines. Next slide. So these are the vaccine-specific estimates for effectiveness against COVID hospitalization from both IV and Vision. The pooled VE estimate was 92% for Moderna, which you saw earlier, and then is 87% for Pfizer. Next slide. Then this slide shows the vaccine-specific rates of myocarditis per million second doses administered among persons 18 to 39 years from VSD. And again, as you've seen before, the rates are the highest in males, 67.5 per million second doses for Moderna and 46.8 per million second doses for Pfizer. Next slide. So you've seen the setup for this before, but you can see the COVID-associated hospitalizations prevented compared with myocarditis cases expected from the vaccine, with results presented per million fully vaccinated persons aged 18 to 39 years. On the left is COVID hospitalizations prevented by Moderna in the dark red, and hospitalizations prevented by the Pfizer vaccine are in dark green. Then on the right side of the figure, expected myocarditis cases after the Moderna vaccine are in the light red, and expected myocarditis cases for Pfizer are in light green. I just want to point out one thing. So to further emphasize how the benefits far outweigh the risk, you note that on this slide and in the slides I showed in the previous ETR presentation, the scale is different on the right, so you can actually see the myocarditis cases. If we showed them on the same scale, the myocarditis bar would be so small that it would be difficult to interpret. But overall, and as we compare both vaccines, you can see that over the course of 5 months, again, the benefits of receiving either mRNA vaccine far outweigh the risk. More myocarditis cases would be expected among the Moderna COVID-19 vaccine recipients than Pfizer, but more COVID hospitalizations would be prevented among the Moderna recipients compared to Pfizer as well. Next slide. So in this slide again, you can see that it's the same setup for males aged 18 to 39 years, again for whom the myocarditis rates are the highest. The benefits still for the mRNA vaccines far outweigh the potential risk. Again, more myocarditis cases would be expected among the Moderna vaccine recipients compared to Pfizer, but again, more COVID hospitalizations would be prevented among the Moderna recipients than the Pfizer recipients. Next slide. Highlighting again the same limitations as the previous benefit-risk balance that we showed, focusing on individuals 18 to 39 years for direct benefits and risks over that 5-month period compared to vaccine versus no vaccine. And again, the assumptions don't include Omicron-specific VE estimates, assume a static hospitalization, and don't account for booster or prior infection. Next slide. So again, just summarizing the benefit risk, COVID hospitalizations averted by the Moderna COVID-19 vaccine are greater than for the Pfizer BioNTech COVID-19 vaccine. On the risk side, the myocarditis after the Moderna COVID-19 vaccine are likely greater than for the Pfizer BioNTech COVID-19 vaccine. Next slide. In summary, again, the benefits for both mRNA vaccines far outweigh the risk of myocarditis compared to no vaccine. When compared to the benefit-risk balance for Pfizer, Moderna prevents more hospitalization, however, more myocarditis cases would be expected. Next slide. So again, we've summarized several times. I'll skip to the next point, which is the rates of the myocarditis were lower with extended intervals between the first and second dose of the mRNA vaccine, and that the extended vaccine primary series may improve immunogenicity and vaccine effectiveness. Next slide. So then the question we're proposing for discussion today is, based on this new and emerging data, should CDC consider guidance around the interval between dose 1 and dose 2 for the mRNA vaccines? Before the discussion, we'll walk through a few more considerations around this possible extended interval. Next slide. So overall, if there were recommendations around an extended interval, who would it apply to? Overall, there are around 33 million unvaccinated individuals if we focus in on that 12 to 39-year-old age group. The population with no vaccine at all is lower as you get into the older age groups. Next slide. Then there are several considerations regarding extended intervals between the first and second doses of mRNA vaccines. If we think through the possible benefits, specifically for safety, we've seen that the extended interval appears to reduce the risk of myocarditis, with the lowest rates of myocarditis with an interval at least 8 weeks. Extending the interval also appears to increase the vaccine effectiveness for the primary series, although we've seen that this benefit may level out at about 8 weeks. For implementation, it is possible that uptake of the COVID-19 vaccine primary series could increase if individuals or parents desire an action that they could take that would lower their risk for myocarditis. Next slide. Then thinking through possible risk. With regards to effectiveness, there will be a longer duration of time where individuals would only have the benefit of a single dose of an mRNA vaccine. Then for implementation, for aspects that require being fully vaccinated, such as quarantine, travel, or restaurants, and extending an interval would extend the time before somebody would be considered fully vaccinated. Next slide. So overall, the work group had several thoughts around the extended interval. An individual's risk of getting COVID likely increases the longer they're only partially vaccinated with a single dose. That risk needs to be balanced with the benefits of lowering rates of myocarditis and optimizing the long-term vaccine effectiveness. This balance is influenced by the trajectory of the pandemic and recent epi of COVID-19 and can change over time. Early in the pandemic, the priority was for individuals to have optimum protection from the primary series as quickly as possible. However, guidance around COVID vaccines can be updated as new data become available, and the focus expands to also look to the future of the COVID vaccine program. Next slide. The work group emphasized that clear communication for COVID vaccines and preferred intervals is important. Being specific for what interval is desired and for whom will be critical for those and needed to implement any updated guidance. Also, there may be populations where the benefits of that earlier interval at 3 or 4 weeks would outweigh any possible risks of myocarditis. The licensed interval of 3 weeks for Pfizer or 4 weeks for Moderna would continue to be recommended, especially in circumstances where early protection is desired. Overall, after having discussions, the work group supported a preferred interval of 8 weeks between the first and second doses of an mRNA COVID-19 vaccine primary series. Next slide. Again, acknowledging our team that worked to help pull all of this together. And next slide. So questions we want to pose to ACIP is, what do you think about the possibility of an extended interval between the first and second doses of the mRNA COVID-19 vaccine primary series? And what time frame would you think that preferred interval should be? I want to highlight that we're bringing this for discussion. We'll need to continue in discussions around what would be possible or what may happen, but we wanted to make sure we got ACIP input as we consider what CDC guidance may be on this. Thanks.
Thank you, Dr. Oliver. This presentation is now open for questions. Dr. Kaling.
Okay, so thank you, Dr. Oliver, for this great conversation. And I want to appreciate everybody in the ACIP for putting together these presentations and pulling information from around the world and what we're seeing. I did find the data that was presented from Canada, from our Canadian colleagues, and from around the world very persuasive that an extended interval, particularly in younger persons at increased risk of myocarditis, would particularly be beneficial. I also appreciated the caveats that the work group included, because it looks like, and we're all hopeful, that we're beyond the peak of Omicron. And so when the pandemic is receding, this is a particularly good time to do a prolonged interval, but that there may be cases and circumstances in which a shorter interval would be recommended. And so I did like the extended interval, and I did like 8 weeks, thinking that that looked like the ideal time according to Canadian data. So thank you.
Thank you, Dr. Paling. I'll ask if my other committee members would be willing to weigh in on these questions. It would be really helpful to the committee, well, to the ACIP and to the CDC. Thank you, Dr. Daly.
Yeah, you know, in some ways, my views are represented in some of the work group conversations that Dr. Oliver summarized. But just to jump in and say I'm in favor of extending intervals, and doing so provides benefits to the recipients of Pfizer vaccine and also provides benefits to the recipients of Moderna vaccine. And I appreciate the desire to have clear communication, and that's why I think I prefer an 8-week interval, but also to give some flexibility if somebody needs to achieve protection sooner. Over.
Thank you. Ms. Bata.
Speaking from the front line and what we're seeing in practice, in particular with the Pfizer vaccine and the 3-week interval, is that many times even 3 weeks wasn't observed, that it was much earlier. And so I think that can be a big influencer on efficacy. And so I like pushing it out, and based on other vaccine schedules that we've seen and have learned, that extended time seems to provide a better immune response. So I would be in support of the 8 weeks.
Thank you. Dr. Sanchez?
Yeah, no, thank you, Sarah. And so this is kind of what I brought up earlier. And in terms of the first question there, I do agree, and I would favor an extended interval, especially among the younger male individuals because of the association with myocarditis. And we really, I mean, this is an age group that in general does not have severe infection, but still should be protected. And so I think that that trying to optimize vaccine safety in that group is extreme. It's without a, I mean, it's we have to optimize that. And so I definitely think that I would make a recommendation for an extended interval in that group. And I guess and clarify this a minute. So when we're looking at the extended interval, the occurrence between the Pfizer versus the Moderna, the differences seem to be less significant. And I'm asking with respect to trying to make a recommendation for one versus the other product, particularly in those who are at highest risk for myocarditis, where if it is a shorter interval, it should be the Pfizer product if it's needed, if somebody wants a quicker protection. But I certainly would favor the longer duration, the 8 weeks.
Thank you, Dr. Sanchez.
Can you comment on?
Yeah, I was going to ask, which point did you want clarification on?
The clarification one was the Moderna versus Pfizer one.
Yeah.
Was dealing with both with the 8-week interval.
Okay.
Yeah.
Dr. Oliver, can you respond?
Sure. Thanks, Dr. Sanchez. So I think overall, especially around that kind of clear communication, the thought was any recommendations around an extended interval would be best to be applied to both mRNA vaccines. So we wouldn't, only have an extended interval for one or the other. Then the other thing, I mean, the work group really, if you look at kind of the countries that have made recommendations for a preferential for one vaccine over the other, it was around the myocarditis concerns. And ultimately, it seems like we potentially have a mitigation measure for those myocarditis concerns, which could be the extended interval. And so if you kind of look at the totality of the benefit risk, taking in VE as well as the myocarditis, it was really kind of felt that the extended interval may kind of lower that risk of myocarditis, which would hopefully negate the need for a preferential recommendation. I think certainly individual clinicians could make a choice around which vaccine they thought would be best in any specific circumstance, but as a kind of nationwide public health policy, that the extended interval would be a good way to mitigate the myocarditis risk.
Thank you. And I certainly do not imply or suggest that there should be a different interval between the two. I mean, we need to, again, harmonize it. But my understanding, if I remember correctly from the Canadian data, was that with the extended interval, the differences in myocarditis with Moderna versus Pfizer was not so significant. And maybe I might be wrong, but because if there is, then I would think that we would want a preferential product.
Thank you. Dr. Cotton.
I was curious as to the thoughts of the working group about the people to whom this would apply who are still unvaccinated, how a change in the interval might impact their desire or ability to get vaccinated, and how that might change their thoughts. And I was wondering if anybody had any comments about that. It might be something that you're not able to really fully evaluate until it happens.
Yeah, Dr. Daly, would you like to respond?
Yeah, this is going to be, thanks for that question, Dr. Cotton, and I sincerely agree, and thanks, Dr. Sanchez, for your comments, because I've been thinking about those too. I mean, I think, folks that are not vaccinated today have some reluctance for sure, and that reluctance may be across, multiple, there may be multiple reasons why they're reluctant, right? But certainly vaccine safety is one that's raised again and again. And I think, as always, these are complicated things and they're hard to communicate and it's nuanced. But I think if we're communicating, we have vaccines that are highly effective and have a high degree of safety, but we have a way to make them even safer and to reduce your risk from myocarditis. And if that's the particular reason why they're hesitant, it could encourage some additional vaccination. I think it's probably not just myocarditis, and that's not just the only issue, but it may convince some who are reluctant to vaccinate. And again, I think if the message is we already have a highly effective and highly safe vaccine or vaccines, and this is an approach to make them even safer, that might convince some folks over.
Thank you. Dr. Lair.
Thank you. You asked for my opinion, and I agree with the extended interval, and I support the 8-week recommendation.
Thank you, Dr. Lair. If there are other members who would also like to state their opinion, whether it's the same or different, I think that would be incredibly helpful. Dr. Sanchez?
No, I just want to add that I think the myocarditis risk is for those parents and individuals who are aware of it. I do think that it is an issue, and from a personal standpoint, it was brought up by my sister in vaccinating her children, and of course I recommend the vaccine anyway. But I do think that if we can ameliorate it, make the vaccine safer, I think that it's extremely important.
Thank you. Ms. Hayes.
Yes, thank you. Carol Hayes at the American College of Nurse Midwives. Could someone briefly remind me of the original clinical trials for the mRNA vaccines on the different schedules that they did? How many different times did they study what the frequency was between the two doses? Like, I thought my memory is that they tried multiple different schedules. And so can anybody remind me of that?
This is Dr. Oliver. I will say that, again, as we mentioned, I think early on when we were in the kind of the middle of a pandemic, the goal was to get vaccinated, get that kind of optimum coverage, optimum protection as quickly as possible. So the early clinical trials for both mRNA vaccines had the 3 or 4 week intervals. There are actually representatives for both, so I'm happy to see if either have data on extended interval. But I think the answer is the bulk of the kind of early, phase 2, phase 3 clinical trials really did focus on that early protection, because again, the goal was to get everybody as high a protection as quickly as possible. I don't know if, yeah.
This is Rita Dash from Moderna. And, I think your point is exactly right. And by and large, the participants of our vaccine trial were extremely compliant with the 4-week interval, but we do have data out to 6-week interval showing, sustain the same level of efficacy.
Thank you. Dr. Talbot, I saw your hand raised. Did you want to make a comment? I'm going to pick on you now.
Yes, just briefly. I think in many ways it's a win-win. It's not only the reduction of adverse events, but it's also the improvement in immunogenicity. And I think as we approach these new variants, the higher the antibodies and the more diverse these antibodies are, the better protected people will be. So I think it's a win-win from both safety and immunogenicity to spread out. Thank you.
Thank you, Dr. Talbot. Well, other members, if you haven't had a chance to weigh in, would really appreciate it. I'll just weigh in with my opinion now. I actually agree very much with what Dr. Talbot just said, which is that not only could this be more efficacious, but also offer an improved safety profile. I do think an extended interval between the first and second doses is an opportunity. And it's interesting because we actually have a gap right now in pediatric vaccination. So this does extend the opportunity. I would say 8 weeks, and harmonizing that would make it straightforward, hopefully to implement with a range, recognizing again that Dr. Paling mentioned that our hope, although I don't know if we're quite out of the woods yet, that with the Omicron wave just starting to recede, and hopefully before another wave arrives, we'll have an opportunity to really optimize the immune response in young children. The other thing I wanted to, I'll pause there and I'll actually call on my colleague, Dr. Bell.
Thank you. Being a member of the work group, I've had the opportunity to really have a very robust discussion about this already, which Dr. Oliver, I think, reflected very accurately. And I was, very taken with the consistency of the work group members' feeling about this issue of the extended interval and the pretty much overwhelming agreement that an extended interval makes sense, as you say, for both safety and efficacy reasons. So I think I'm in support of that, and I think that at the end of the day, the picking an interval like an 8-week interval as we have, but recognizing there needs to be some flexibility is kind of the best way to thread that needle and keep things as simple as possible.
Thank you, Dr. Bell. Dr. Alt.
I think one of the potential problems is during that gap, we're going to have people who are going to get infected or be vulnerable. So we're going to have to think about that when we make clinical considerations. I was trying to go back through my copy of the slides to see if that was specifically addressed, and it looks like it was kind of tangentially addressed. If anybody on the work group can comment about that.
Dr. Daly or Dr. Oliver, would you like to comment? Dr. Daly.
Yeah, so Dr. All, we did discuss that, and it's time at risk, but it is, to be sure. But as Dr. Paling said, you know, if this is implemented at a time frame when case counts are falling, that's a benefit, and it's still a fairly short period of time. It's a 4-week difference there, or 5-week difference there. So the work group felt comfortable with the idea that you'd get some protection from a first dose, even if that second dose was delayed a little bit. But it's hard to sort of quantify that. So, and then I would like to make one point, and this is again kind of back to how we communicate this. I think how we communicate this is really important. And I think we, you know, and I agree with Dr. Sanchez that when I hear parents who raise concerns about vaccine safety, they often bring up specifically the issue of myocarditis. So I think we, you know, probably are best served by starting with that saying from Dr. Oster, which is, you know, look, COVID is worse on your heart than vaccination, and myocarditis and any other adverse event, particularly anaphylaxis, was quite rare with the intervals we've used in the past. And then this is just an opportunity to make myocarditis even rarer with an 8-week interval. So again, I think we sort of want to emphasize those points as we communicate this over.
Thank you. Dr. Brooks.
Yes, I just want to say that the benefit of greater immunogenicity and the decrease in the rates of myocarditis make it clear to me that this is a good recommendation. The level of coverage as you go out, it looked like from the Canadian study, didn't drop off appreciably. So the concern about lowering immunity over time by only one dose is not that a major worry of mine. I think that it affords a level of safety and also demonstrates to the public that we are very focused on doing this in the right way and making these adjustments that are overall beneficial.
Thank you, Dr. Brooks. Dr. Duchin. Okay. Dr. Duchin, I see your hand is raised. I don't know if you would like to make a comment.
Sorry, I did not
Okay.
unmute successfully.
Okay.
I also agree with the rationale around improving vaccine safety and improving vaccine effectiveness. I think the type of graphics that were showed earlier may be very helpful in communicating to the public around any changes that may be made in the vaccine schedule. And also wondering if someone can comment on any implications for timing of booster doses if a extended primary series interval is adopted.
Dr. Oliver, I'm going to ask you if you can respond to that last part.
Thanks, Dr. Duchin. For the last point, I can say that the booster dose recommendations are based on timing since completion of the primary series. So that recommendation would stay the same, and the clock would count when you get that second dose. It would be, 5 months after that when you were fully vaccinated when you got that second dose. So that would not change.
Yeah, great clarification. Thank you.
Thank you. I did want to actually comment on 2 additional points. One is that recognizing that the current authorization either sits at 21 or 28 days, would really appreciate that flexibility in terms of whether a full recommendation is needed versus clinical guidance. This, to me, feels like a good opportunity to use clinical guidance, both from a timeliness perspective, but because we have an opportunity, again, to optimize the immune response in young children, many of whom remain unvaccinated. And our hope is that this will continue to improve vaccination rates over time. So that's just my own personal opinion, but I wanted to just recognize that there seems to be generally supportive comments in favor of an extended interval, and we'll look at understanding whether or not there's the regulatory allowance for these comments to be incorporated into clinical guidance. The other comment I wanted to just make, and I think, Dr. Sanchez brought it up, was this question about Moderna versus Pfizer, and also recognizing and acknowledging the variable vaccination policies that are occurring in different countries. I do think that, I'm personally not yet sure that there is sufficient evidence to make a preferential recommendation for two reasons. One being that I do think some people decide that they would like Moderna. And in the same meeting, we've talked about people who have a suboptimal immune response. And so allowing that flexibility to be available to individual patients and clinicians to think about the benefit-risk balance for that individual, I think would be important to reflect. And that's a little bit harder, I think, with a preferential recommendation. And the second being that right now, the Moderna is authorized for, or now fully approved for 18 and older. So for those two reasons, I just wanted to offer that. I'm not exactly sure where that will head, but I want to just acknowledge the fact that there are differences in policy decisions across countries. Dr. Sanchez.
Thank you, Grace. And as much as I agree with what your statement is, that if there is a higher risk of myocarditis in the highest risk group, less than 30 years old or 39 years old, whatever, less than 40, and we have a vaccine that, given as a second dose, we have a vaccine that's associated with lower risk. I think we should have a preferential recommendation for that vaccine in that age group, and males. But I guess my question remains, with the extended interval between the first and second dose, does that difference in vaccine, does it really mitigate the increased risk with the Moderna? But currently, my preference and what I would recommend somebody who received either Moderna or Pfizer as the first dose, and they're in the high risk group for myocarditis, I would say no, get the Pfizer.
Thanks, Dr. Sanchez. Appreciate that perspective. Any other comments or questions regarding these questions for ACIP? Dr. Daly.
Well, I'm just going to respond to Dr. Sanchez's comment from the work group perspective, and Dr. Lee, this is going to restate some of the things that you stated. But the ACIP COVID-19 vaccines work group, Dr. Sanchez did discuss all the issues that we're discussing today, and did feel like an extended interval was a strategy for increased safety and decreased myocarditis risk for both mRNA COVID-19 vaccines, but really didn't find that there was compelling evidence to currently have a preferential recommendation for one mRNA vaccine over another. Over.
Thank you. Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as a practicing physician. I greatly appreciate all the data that's been presented today about ways to make the vaccines work better and make them safer, but also greatly appreciate what you mentioned, Dr. Lee, about increasing flexibility for the doctors that care for these patients to help patients make decisions. And by adding some flexibility there, physicians know what the points are that patients are concerned about, and what is the thing that might make them go ahead and get a vaccine now or wait. And the Moderna, in our previous conversations, we've heard that Moderna seem to be more durable. Now we're on the downward curve of Omicron, and the myocarditis concern is a big one. But I love in this whole conversation the concept of giving guidance, but also giving some flexibility. And I also look forward to more details on the clinical guidance about the immunocompromised patients and expanding who that group of patients is for those new booster recommendations. But thank you so much for today's discussion.
Thank you, Dr. Freihofer. Dr. Lair.
I want to point out one thing which came out in the slides, that there is a higher risk of myocarditis from Moderna, but there's also a benefit in hospitalizations. And I don't want that to get lost. And so when we talk about a preferential recommendation, I think we need to look at the whole picture. And I think the hospitalizations might be just as important as the myocarditis. Thank you.
Thank you, Dr. Lair. Okay, I don't see any additional hands raised at this moment. I'm actually going to turn it over to Dr. Oliver, and then we will move towards closing the meeting soon.
Thanks. Was just going to make a quick comment around Dr. Duchin's point, just to acknowledge that we didn't forget that he asked that question. And I think the short answer is I think none of us know if we've learned anything throughout the pandemic. It's that our crystal balls aren't always great at predicting what the future will be. But we are aware that there are studies ongoing for Omicron-specific vaccines. And as we learn what's going on with the pandemic and the pandemic evolves, as well as additional data become available, we'll review it. We'll review it in the work group, and then we'll bring it to ACIP. So we look forward to kind of discussing what may be in the future, but I don't think any of us are able to kind of predict what we think the future of these vaccines and especially with variants will end up being. But thanks.
Thank you, Dr. Oliver. Very much agree with you on that point. I see no additional hands raised, so the committee has completed its business for today. Are there any objections to adjourning today's meeting? Before we adjourn, I'm going to ask Dr. Wharton, do you have any additional comments or updates you'd like to brief the committee on before we adjourn?
Thank you, Dr. Lee. I'd like to thank the committee for sticking with us through a very long day. I appreciate all your thoughtful discussions. As Dr. Fink mentioned in his opening remarks, FDA has announced that the Vaccines and Related Biological Products Advisory Committee will be meeting on February 15th to discuss Pfizer's application for use of their vaccine in 6 months to 4-year-old children. And should that vaccine be authorized for that use, then I think we'll be meeting again. But that's for the future, and just a heads up that as things develop, we'll be in touch with the committee and sharing information as we can. So thank you.
Thank you, Dr. Wharton. And with that, I haven't seen any objections yet, so I would like to now adjourn today's ACIP meeting. Thank you, everybody, for your time and your expertise and your patience. We are all grateful for this committee's work and for the work of our CDC staff, liaisons, and ex officio members. Have a wonderful day, and I'm sure we'll be talking soon. Thank you, everyone.